Yeah, ma'am.
Good morning, everyone. I want to congratulate each one of us as we have all made it to the grand finale, that is last day of this fantastic week-long anesthesia academic series. I'm Dr. Shivpriya and I will be the day coordinator for this last day of week-long academic fest with power-packed sessions. I would like to thank all of the students, faculty, moderator who chose to be here on Sunday morning. I know Sunday is for the rest and brunching and chai. And since it's Friendship Day, it feels just right to spend it with colleagues who have turned into close-knit academic family. Over the past few days, we have covered topics from oxygen therapy to ventilation to sepsis and shared some fantastic case discussions, great case discussions. So today, as we wrap up, let's take in every bit of the final day sessions. So without further delay, I would like to invite the chairperson of our very great first session of today. So I would like to welcome Dr. Sri Priya. Please display resume. So she is additional professor in AIMS Mangalagiri, and she has got sorry for technical glitch. Can I get her Can I get her CV on the display, please?
CV already showing, ma'am. Can you visual, ma'am? CV.
She has got 27 national and 23 international publications in her record. And she has got Best Peer Reviewer Award 2023 and Best Publication Award 2024. Her area of interest are regional anesthesia, anesthesia machine, safety in anesthesia practice, and airway. I welcome you, ma'am, and I hand over this session to you. Welcome, ma'am.
Thank you, madam. A very good morning, everyone. At the outset, I extend my heartfelt congratulations to the entire organizing team of Appec 2025 under the able guidance of Dr. Nirja madam for successfully conducting the 7-day anesthesia postgraduate pre-examination course. It is commendable that this academic event is conducted year after year since 2020 with such consistency, dedication, and enthusiasm. I thank the organizers for inviting me to chair this session. In this session, we have two insightful lectures. The first talk is on anesthesia machine. I take immense pleasure in introducing the first speaker, Dr. Sanish PJ. Sir is a senior consultant at Anantapuri Hospital and Research Institute, Trivandrum. His areas of interest are airway management, perioperative medicine, physics in anesthesia, pediatric anesthesia, trauma management, and resuscitation. Sir has developed the educational app and YouTube channel Anesthesia Tools, which serves as an excellent learning resource. I encourage all postgraduate students to explore this platform and make the most of the content it offers. He has authored two textbooks, Review in Clinical Anesthesiology for Postgraduates and Textbook of Anesthesia for Technicians. He is a register of Indian College of Anesthesiologists and a scientific committee member of Indian Resuscitation Council Federation. Sir will be speaking on anesthesia machine. Over to you, Dr. Sanish.
Very good morning to one and all. Thank you for the organizers of Appec 2025 for giving me the opportunity to be part of this prestigious academic program. Let me get into my topic. So another 35 to 40 minutes, we'll discuss understanding anesthesia workstation. I think for the examination point of view, you'll be thinking more about anesthesia machine rather than workstation, and you know very well when monitors and few components are added to the anesthesia machine, it becomes the workstation. So here is where we started from the history, from the initial Morton's inhaler. We kept on evolving throughout the decades and the last 1.5 centuries and more. And this is the first prototype, what we call as Boyle's machine, which came into existence in 1917 after Henry Edmund Gaskin Boyle. Not going into the history part of it. Late 1960s, it evolved into something more familiar to the present generation. And now the story today is completely different. We are thinking about anesthesia workstation. So during my discussion, I will describe mostly on Boyle's machine or the basic machine parts, and then in between I'll tell you the updates as well. Okay, so here we go. The present anesthesia workstation, we can have two sets of components. One is electrical components, and the second one and the essential part is pneumatic component. Pneumatic components are divided into high pressure system, intermediate pressure system, and low pressure system. This is a schematic diagram of anesthesia machine or workstation or the basic parts. In the lower bottom part, you can see the highlighted portion. This is the high pressure system for oxygen. Similarly, we have a high pressure component for nitrous oxide, and if you are connecting cylinder for air, this is the component for air. This is the high pressure system. Now, what exactly is high pressure system? The high pressure system receives gases from cylinders at high and variable pressures and reduces those pressures to lower, more constant pressure suitable for use in the machine. So bird's eye view, you can see the hanger yoke assembly here, the swivel gauge, the index pins, the port, the gasket, the Bodox seal, and now the second part is cylinder pressure gauge. Here we can see nitrous oxide pressure gauge, and then beyond that it is the pressure regulators, primary pressure regulators. So these three main components make up the high pressure system in anesthesia machine. So here is the list: hanger yoke assembly, cylinder pressure gauge, primary pressure regulator. These are the components of high pressure system. Now coming to the first part, the hanger yoke assembly, it consists of a body, the structural framework which is screwed or fixed onto the main framework. Then it's a retaining screw, it's a swivel gate type. So this is the swivel gate or toggle gate, what we call, and this is the nipple through which the gas enters the anesthesia machine. It has a washer or Bodox seal, and below you can find the index pins for non-interchangeability of cylinders. The parts which are not visible to us in this view is filter and the check valve assembly. Filter makes sure that particulate matter don't enter into the pneumatic system, and the check valve assembly makes sure that there is no exit of gas when no cylinder is attached to the hanger yoke assembly. Again, parts of hanger yoke assembly. This is the body. Okay, this is the retaining screw. Yeah, this is the nipple through which the gas enters. These are the index pins. The cylinder yoke holds the index pin holes. Here the index pins, and the Bodox seal or washer which ensures gas tight seal. And now two more components, the filter and the check valve assembly. Okay, here is the body, different manufacturers, different machines. You will see it in different forms. And something about the pin index safety system. This makes sure that the cylinder hanger yoke is non-interchangeable. That means a hanger yoke meant for oxygen, you cannot attach nitrous oxide or any other medical gas cylinder. I'm not going into the details for want of time, but remember that the index pins are attached, arranged in a 9 by 16 inch radius around the nipple at 12 degree each position from clockwise. From 1, here you can find the first, second, third, jump over to the 4th, 5th, 6th, and in the middle you can see the 7th pin, that is for N-tonox. The corresponding index pinholes in the cylinder yoke you can see in the opposite direction. The numbering is from counterclockwise direction. Okay, yeah. So each index pins are 4 mm in diameter. They are 6 mm long, with the exception of the pin number 7, which is slightly thicker. Regarding check valve assembly, so when there is gas entering through the nipple from the cylinder, you can see the plunger moves back and gives way so that the gas can enter the machine. Okay, what happens when the cylinder pressure is less or empty? The plunger bounces back and there is no way the gas can exit from the machine to outside. But this is not 100% reliable. So whenever you are not mounting a cylinder, make sure that you use something called yoke plug. Okay, yoke plug, so that there is no outside flow from the machine to the atmosphere. So yoke plug is pin index independent, so you can use the same yoke plug for nitrous oxide and oxygen alike. And now cylinder hanger yoke assembly is mentioned for a particular gas. So usually for oxygen there will be 2 hanger yoke assemblies and 1 each for nitrous oxide. For oxygen, 2 are usually mandatory, because when one cylinder is getting exhausted, you can use the other cylinder as reserve. You can switch over to the reserve cylinder easily. So this is the dummy cylinder block or blanking cap or blanking plug, which I was mentioning. Okay, check valve assembly helps us to see that no gas exits from the machine to atmosphere. So usually only one cylinder of a gas should be open at a time. The other one remains as the reserve. Now we go to the cylinder pressure gauge. Cylinder pressure gauge displays cylinder pressure for each gas supplied by the cylinders. This is the Borden pressure gauge type. The simple mechanism is, there is a hollow copper tube. When the cylinder pressure is exerted into the lumen of this tube, the hollow metal tube, the metal tube straightens and the tip of the tube is connected to a clock-like wheel mechanism, so that we can have a dial moving over a scale, calibrated scale, which will indicate the pressure inside. Remember, for oxygen, when the cylinder pressure drops, you can see the contents are also getting low proportionately. So full cylinder is 2000 psig. So 1000 psig means half the cylinder is full with oxygen. But this is not true with nitrous oxide cylinders, because nitrous oxide exists as a vapor in equilibrium above the liquid nitrous oxide. So until the last drop of liquid nitrous oxide is vaporized or converted to vapor phase, your dial won't move from 750 psig. So when the nitrous oxide cylinder pressure gauge starts dipping, the pressure, the calibrated scale starts dipping, that means your nitrous oxide cylinder is almost empty. Yeah, this is another picture of the Borden pressure gauge. So now you need to understand that there are pressure gauges for the pipeline supply as well as the cylinder supply. So here you can see the identity marker for cylinder, so that you are sure that this pressure gauge indicates the cylinder pressure. Newer machines, we have digital pressure readouts, so you will see those values here. Okay, so you need to understand the exact value and the unit to know whether your cylinder pressure is appropriate or less. Third part is pressure regulators. This is the component that reduces the high and variable pressure found in a cylinder to a lower, more constant pressure suitable for use in an anesthesia machine. That means when the cylinder pressure is full, say for oxygen 2000 psig, when it starts dipping from 2000 to 1500, 1500 and all, the pressure delivered to the intermediate pressure system should be almost 45 to 50 psig. So this is the component that makes sure this conversion is done and a more constant pressure is supplied beyond or downstream the high pressure system. So these are the pressure regulators. You can see here, this is the pressure regulator for oxygen. You can find this part is this one. This is the factory reset mainspring. I'm not going into the details. Here you can see the pressure relief valves also, this one. Okay, so you need to identify these things probably in your Viva if you are quizzed on this. Yes, these are oxygen pressure regulators, my dear. Okay, so but when we come to nitrous oxide pressure regulators, things are slightly different, because instead of the mainspring here, you can find the oxygen regulator pressure coming and supplying here. So nitrous oxide pressure regulators are sometimes termed as slave regulators. That means when the oxygen pressure is not there, oxygen supply is not there, there is no output from the nitrous oxide regulator. So it is also called as a balance regulator or slave regulator. In this diagram also you can identify the balance regulator, which is a fail-safe mechanism in most of the machines. Okay, fine. Now you come to the intermediate pressure system. Intermediate pressure system is a majority of part here. So this starts with the pneumatic component of master switch, then pipeline inlet connections. These are the inlet connections. Then pipeline pressure gauges. Here you can see pressure gauges, pipeline pressure gauges for air, nitrous oxide and oxygen. Yeah, all the pipings. The gas power outlet, I will come to that. Oxygen pressure failure devices. The most important oxygen flush, additional pressure regulators or secondary pressure regulators, if any, and up to the flow control valves. So this is the boundary when the flow control knobs are closed. So this is the boundary until which the intermediate pressure system exists. This is the master switch. It can have a pneumatic component or electrical or electronic component. It depends on the specific workstation which you are working. These are the pipeline inlet connections. You can see on the back or side of the machine. So these are non-interchangeable. This is either diameter index safety system or non-interchangeable screw thread system. So this also ensures that nitrous oxide pressure pipeline cannot be assembled into air or oxygen and vice versa. Okay, fine. Important thing is you need to identify the cylinder or pipeline pressure indicators in the machine. Here you can find the indicators. There are no symbols of cylinder here, so these are pipeline indicators. Again, I would like you to have a closer look at the pressure indicators. Okay, you need to identify the unit in which it is mentioned. Here you can see the inside values are given in PSI and the outside values are given in 100 kilopascals. So you should know how much will be the expected value when the pipeline supplies are working correctly. Okay, so pipeline pressure indicators should be upstream the check valve assembly, so that it doesn't depend on the cylinder pressure supply. So whenever pipeline is disconnected, it should read 0. When the pipeline is connected, it should immediately reflect the pressure supplied by the specific pipeline supply. So this is the pressure pipeline pressure regulator, and this is the location. Okay, pipeline pressure indicators I have already mentioned. You should identify the ones for oxygen, nitrous oxide and air. Now coming to the piping. If you have a Boyle's machine in your institution, definitely open the lid and see where the pipelines are going. So you should be able to trace from which all parts the pipelines go from the oxygen pressure regulator and which all parts the nitrous oxide pipelines go. This is very important because the pipings are a source of leak. The leak accepted is less than 25 mL per minute. And if you can't study with the help of Boyle's machine workstation, it's more complicated. You can find more sorts of pipings, short tubings, but remember that if you ask a biomedical technicians, they will know from exactly from where to where it is connected. There are non-interchangeable mechanisms to make sure that cross-linking is not there. Yes, there are some case reports or incidents with technical issues. Gas power outlet. When you are given a Boyle's machine for your vivavos, usually examiners tend to take your attention to that, because most of their modern machines, you can't find this, because anesthesia ventilators are now integrated with our anesthesia machine or workstation. So these are gas power outlet which will help to drive the bellows type ventilators. So this will also provide the drive gas so that you can have a mechanical ventilator during your anesthesia practice. So where do you identify the gas power outlet? It's concealed, it is inside the workstation, but definitely yes, there is a drive gas supply from the intermediate pressure system. Oxygen supply failure alarm, you can see a box like device here. So this is the Boyle's machine or previous version thing. Either you are getting an audible alarm or a visual alarm in most of the anesthesia machines, so that you will not be giving a hypoxic mixture to your patient. There are different kinds of anti-hypoxic mechanisms. That itself is a different topic. I'm not going into the details. One such example is oxygen pressure sensor shut-off system. So here you can find when oxygen supply pressure is more than 20 psig, it will allow the transfer of nitrous oxide, the flow of nitrous oxide to the flow meter. But when the supply is less than 20 psig, this valve gets shut off and there is no flow beyond this. So this is a kind of anti-hypoxic prevention mechanism. Now we come to the link 25, nitrous oxide oxygen proportionating system. That means we don't allow any creation of a mixture with less than 25% oxygen when nitrous oxide is used as the second gas. Okay, how do we do that? In this machine, there is a mechanical linkage between the flow control knobs of nitrous oxide and oxygen, and you can find 29 teeth sprocket for oxygen and 14 teeth sprockets for nitrous oxide. So every time nitrous oxide knob turns twice, oxygen knob also turns once. This happens only when nitrous oxide is turned without turning oxygen. So if you want to reduce nitrous oxide, it won't disturb oxygen knob at all, because your target is anyway achieved. So that is the advantage. But here actually we don't get a 1:3 ratio, 1:4 ratio, that is the 25%. So there is one more mechanism apart from this pneumatic linkage, is this one. Either there is a second stage oxygen regulator where oxygen is supplied with a pressure of 14 psig, second stage nitrous oxide regulator supplies with 26 psig. So eventually with the mechanical linkage providing 1:2 with the pneumatic linkage additional, it eventually comes down to 1:4 or 25% ratio is maintained. Remember, when nitrous oxide is reduced, this mechanical device is linkage is not engaged. Another way of getting it done, apart from the tooth sprockets for oxygen, nitrous oxide, the 2915, is here you can see the flow control knobs. The valves are very sharper. Okay, so the impact on reducing oxygen is more precise, and nitrous oxide has a blunt needle valve. So this also can provide the conversion of this 1:2 into 1:3 or 25% oxygen guarantee with the proportionating system. North American Dragger has proposed the SORC, Sensitive Oxygen Ratio Controller. There is an interconnecting shaft between the oxygen supply and the nitrous oxide supply. So when the oxygen supply is present, the interconnecting shaft moves rightwards as in this diagram. This opening is open, and then proportionately nitrous oxide goes into the flow meter. But anytime oxygen is comparatively less, this shaft tends to move towards left, regulating the outlet here. So the eventual oxygen failure will not allow nitrous oxide to be supplied to the outlet, that is SORC. Pneumatic and mechanical interlock system is the key word to remember in this. The problem with this mechanical linkage is when a third gas is activated, all your calculations fail. So most of the newer machines will allow only to select a second gas, either nitrous oxide or air, not both together. So when nitrous oxide is on, this safety feature may be active, but when air is there, this safety feature is no longer needed because air itself will contain 21% oxygen along with whatever you set in 100% oxygen as the first gas. So this mechanism is called a gas selector switch. It can be either digital or mechanical as shown in this picture. Now we come to oxygen flush, a very important thing, something that we use for emergency. So O2 plus is the symbol, and the flow of oxygen given is unmetered 35 to 75 liters per minute. This is very important, unmetered 35 to 75 liters per minute. Two things you need to remember: the risk of possible barotrauma and the risk of awareness, because suddenly into the mixture, especially if you are running a low flow anesthesia, suddenly you are flushing in 35 to 75 liters per minute. You don't know how much you have flushed in. So again, you need to look into your gas analyzers and make sure that once the crisis is over, the depth of anesthesia is also maintained. This is how oxygen flush works. So oxygen inlet is powered from the intermediate pressure system, but here this is locked. So what happens in on position, or when you push the oxygen flush, the spring is compressed. Now there is a way into the outlet, and now the oxygen, pressurized oxygen, will get into the outlet 35 to 75 liters per minute unmetered. So that is all about oxygen flush. Second stage pressure regulators are also part of the intermediate pressure system. You can find the secondary regulators close to the flow control knobs in this picture. The flow adjustment control or flow control knobs, these are the final boundaries in the closed position of intermediate pressure system. It could be mechanical knobs, as you see here. All the knobs are color coded, probably touch coded also, and the chemical name is also written on the flow control knobs. But when you come to the newer workstations, it is all electronic flow control knobs, some hybrids and some completely electronic or graphical display of the flow. Okay, coming to the conventional flow control knob, here you can see the inlet. Hope you can find my markings, and goes to the outlet, and this small orifice is regulated using this valve system or using the control knob. Okay, so it could be protected by various methods, like keeping it slightly above the working space, protected with guards, things like that. There are different mechanisms. So whenever you turn clockwise, conventionally you are closing the flow meter, and when you turn anti-clockwise, you will be opening. How much is the flow? Either you have digital readout. Here you can find the total gas flow also from this flow meter. But conventional flow meters are called top tube. So depending on the level of the bobbin, you read against a calibrated scale and you find out how much is the flow across the flow meter assembly. So when there is flow, the bobbin ascends, and depending on the shape of the bobbin, you read it against the calibrated scale. Okay, so this is called bobbin or float. Coming to low pressure system, so we go into the details of flow meter assembly in low pressure system. There are hypoxic prevention safety systems in low pressure system, pressure relief valves, and check valve or unidirectional valve, and the last one is common gas outlet. So here you can see the parts of the low pressure system. Beyond the flow control knobs, it's the flow meter assembly, the back bar on which you can mount your vaporizers. You can see two vaporizers here, and then the pressure relief valve, and the piping takes you all the way down to the common gas outlet, and there is a check valve or unidirectional valve to prevent impact of barotrauma, high pressures into vaporizers and our pneumatic components. The flow meter assembly, conventionally they are mentioned as rotometers. This is Thorpe's tube. So these are variable area or variable orifice, constant pressure principle. Sorry. Okay, when the gas flows, the bobbin rises, and when the pressure is balanced by the weight by cross-sectional area beyond the bobbin, it's low pressure system. The indicator float or bobbin can be of different types. Whichever is the shape, you read it at the rate limiting or orifice limiting diameter. For spherical ones in the middle, and the plumb bob or non-rotating flow, you read at this point. Most of the bobbins will have a white dot to make sure that the bobbin is still rotating, so that you are not reading at a level where it is stuck with something else, static electricity or something. So when the bobbin is rotating, the dot is rotating, you tend to read against the calibrated scale, and you understand the how much is the flow you have kept. So in this assembly, you can see 3 sets of flow meters, one for oxygen, one for nitrous oxide, and one for air. And each set consists of one small flow meter tube for low flows, where you can read 100 ml per minute, 200 ml per minute, like that. The second one is connected in series, where you can read at 1 liter per minute, 2 liter per minute, 3 liter per minute, like that. So each flow meter is calibrated for a given gas, generally at 20 degrees Celsius at 1 atmospheric pressure. So here you can see single taper tube or dual taper. So the purpose is dual taper. Initially you can read the low flow range, and then you go into higher flows. It can also be a digital readout, as you see here, I mentioned before. This is the connection. The 2 flow meter tubes are connected in series. So less than 1 liter per minute, you tend to read through the first tube, and then beyond that you can read on the bigger flow meter tube. Okay, the arrangement of flow meter, the logic is simple. The oxygen flow meter should be as downstream as possible. Otherwise, what will happen is, if there is a leak in any other flow meter, say nitrous oxide or air, oxygen also might tend to get leaked or lost through those leaks. So if the oxygen is maximum downstream or close to the outlet as far as possible, that is called the fail-safe arrangement. So outside, whatever you see may not be the sequence in which the gases join the back bar. So conventionally, standard recommendations are there, like oxygen flow meter joins maximum downstream to the back bar. The flow meters can be depicted graphically, as you see in the digital screen. This is something similar to the conventional one, but this is completely graphical representation of the flows. So it could be conventional, as I mentioned, with each gas. It could be hybrid, where you have individual knobs for each gas. You can read the liters per minute for each gas, and there is an indicator for total gas flow set. And now newer machines, you use the same knob which you use for setting your tidal volume, respiratory rate, or whatever, and you get display of the each individual gas in a graphical form on your graphical screen. Anti-hypoxia devices, very important topic. It could be 1 mechanical devices, 2 pneumatic devices, and 3 electronically controlled. I mentioned about some mechanical devices like Link 25. Pneumatic devices are also there. There are some audible and visual alarms are integrated into the newer machines. It could be completely electronically controlled, where nowadays newer machines have electronic gas mixing. So before it releases to the next component, again it is analyzed to check whether the appropriate oxygen percentage is adequately maintained. So electronically controlled anti-hypoxia device, what they do is, in case oxygen percentage delivered beyond that level is less, it will shut off the second gas, either nitrous oxide or air, for some time, until the oxygen percentage reaches back to the set level. Anyway, it's the responsibility of the anesthesia provider to look into that. We have gas analyzers in almost all the anesthesia workstation with the monitors. So it's your responsibility. Instead of the set oxygen percentage, you need to look into the actual exhale oxygen percentage and inhale oxygen percentage throughout the anesthetic, because at least 21% was the patient's human right. Just because you intubated and connected him to an artificial environment, that should not be denied, and there should be adequate compensation for the other VBIQ mismatch and other changes due to the positive pressure breathing. Pressure relief valve, I mentioned, beyond the vaporizers, you can see, and this makes sure that any pressure builds up inside the system is vented out beyond a cutoff margin. So your pneumatic components are not damaged, your vaporizers are not tested. This is the unidirectional check valve. So during your intermittent positive pressure ventilation, the pressure fluctuations should not get translated into the pneumatic components of your anesthesia workstation. So it is mostly taken care of at this level. Plus, whenever you press the oxygen flush, there is a risk of transmitting the positive pressure back to the pneumatic components, which is not desirable. Okay, so one another damage caused by the possible oxygen flush activation is lightening the depth of anesthesia, because I mentioned it's unmetered oxygen flow. Suddenly your low flow precise oxygen proportion control goes hayward, because suddenly you are flushing in 35 to 70 unmetered oxygen into that. So there is a risk of sudden lightening of the plane of anesthesia whenever you have to activate oxygen flush. You need to be careful about that. The last part is common or fresh gas outlet. Newer machines, you can find the auxiliary ACGO, common gas outlet. Usually we use it only when we use Mapleson circuits for pediatric anesthesia, etc. You need to know the knob, which position it is to be connected, because conventionally we use closed circuit. So the knob usually will be in this position. Okay, you have to be very careful. Okay, so what I need to emphasize here is, nowadays we don't see the common gas outlet as it is in our newer anesthesia workstation. It actually we are getting two outlets, that is one for inspiratory limb and one for expiratory limb, with a portion, majority of portion of the breathing circuit, the closed circuit, integrated within the anesthesia workstation. So you get to connect only to the inspiratory limb and expiratory limb and wipe is gas analyzer. So all the inspiratory, expiratory valve and all the other components are integrated within the anesthesia workstation. Again, you should know what is auxiliary oxygen flow meter. So using the common ACGO for supplementing oxygen for regional anesthesia cases is not recommended, because you cannot suddenly switch over to general anesthesia with that anesthesia workstation. So your workstation is supplied with courtesy or auxiliary oxygen flow meter. You can make use of that. You can connect face mask here and dial the oxygen flow here. Again, in the newer machines, there is something similar to this mechanism, alternate auto control. So in case your electronic components get jammed or software hitch happens, you can switch over, activate this alternate auto control, switch over to this, and some of the workstations even allow addition of vapor, anesthetic vapor like your sevoflurane or desflurane also into this mixture. So it's not only oxygen that you can provide in those crises. So that is the advantage of alternate auto control. So if your machine is equipped with the alternate auto control, make sure you are familiar with that as well. Again, I need to emphasize that before you start anesthesia practice, or when the first case of the day, definitely you do your anesthesia workstation checkout procedure. There are two sets of procedure, one before the first case of the day and between each cases. The anesthesia machine checkout, there is no universal recommendation. Depends on your machine, depends on your manufacturer's recommendations. Some of the checklists are automated, some require your intervention during the checkout procedure. So make sure you get involved into that. Make sure you are aware of the importance of routine anesthesia machine checkout procedure. And what you can do is You can go to the YouTube. I think I have demonstrated the anesthesia machine checkout procedure in detail. Okay, so nothing compensate a practice, routine practice. Okay, so that's the message. I've tried to give you an overall view of the anesthesia machine and a little bit onto anesthesia workstation, which I think will help you in your exams. Simple advice: read Dorsch and Dorsch, read the Miller. Miller, the chapter is excellent. It's very simple, very explanatory illustrations are there. So be confident, because when anesthesia provider is confident of his equipments and the manufacturer's recommendations, especially with the newer software dependent technologies, the more you are familiar, more you are capable of troubleshooting it, it will make a difference. The good day to all. Thanks for the opportunity. And again, I thank the organizers of Appec 2025 for giving me the opportunity. I'll be happy to take questions.
Thank you, Dr. Sanish. You have clearly covered all the important aspects of PG should know regarding anesthesia machine before they appear for the exam. And the basic anesthesia machine, as we know, has only pneumatic components that is divided into the high pressure, intermediate, and the low pressure system. Dr. Sanish has taken us through all the components at each segment with all the photos of each component for clear understanding of the PGs. He has also covered all the anti-hypoxic devices that are available in the basic machine. And as he clearly mentioned, anesthesia machine checkout, we cannot have a single checklist that is suitable for all the contemporary anesthesia workstation, but we should know how the system check should be done in the machine we are using. And that is what is expected when you appear for the exam. You should thoroughly know the machine you are using. It is also useful in an emergency to deal with any complication. Thank you, Dr. Sanish.
Thank you. Thank you for the opportunity.
Dr.
Wonderful
Shivpriya,
presentation, Anish.
I don't see any questions in the chat box here. Do you have any questions in the YouTube channel? I think her internet is unstable. So,
Yes, ma'am. What were you saying, ma'am?
do you have any questions in the YouTube channel for Dr. Sanish?
I think there are any questions.
Okay, then shall we move to the next session?
Yes, yes, definitely.
Thank you.
ma'am.
Thank you. Thank you.
Thank you, Dr. Sanish. I take pleasure in introducing Dr. Bharat Paliwal. Sir is a Deputy Medical Superintendent and Additional Professor at All India Institute of Medical Sciences, Jodhpur. His areas of interest are intensive care, chronic pain management, and palliative care. He has several achievements to his credit. He has won the first prize for poster presentation at NZPS 2024 New Zealand and at SAR 2017 Colombo. He has received the ISA National Diligent Award 2024. He has done observership in intensive care at King's College, UK, fellowship in pain management, palliative care. He is a ACLS and BLS instructor of FCCS. He is an editorial member of several journals, and he has 63 publications to his credit. Sir is going to speak on yet another important topic, brain death for organ donation. Over to you, sir.
Morning all. Today we'll be discussing about brain death and something about organ donation. I am Dr. Bharat Paliwal, working as additional professor at AIMS Jodhpur. So brain death or brainstem death, what it is commonly known as. Before going to that, we should understand what is brainstem. So it consists of three things. First part is the midbrain, labeled as number 3 in the picture. Then we have pons, labeled as number 4, and medulla, which is labeled as number 5. So each of these part has certain vital functions. Like midbrain is involved in the motor control, in the sleep-wake cycle, as well as in the temperature regulation. whereas pons act as a relay center between the cerebrum and the cerebellum, whereas the medulla part is involved in various vital involuntary functions like respiration, like your heart rate, like your maintenance of the blood pressure. So this term brainstem or brainstem death was first used in the Medical Royal College of UK conference on 11th October of 1976. Thereafter, this is an acceptable form of death as per the Transplant of Human Organ Act 1994, and it was followed in the subsequent amendments. Basically, the pathology involves first a primary injury to the brainstem or brain, which is further aggravated with the secondary injury, leading to herniation and finally establishment of the death of the brainstem. Coming on to the pathophysiology, so when there is a primary injury, it leads to an inflammation and some amount of edema. This leads to an increase in ICP in the brain. The inflammatory mediators leads to progressive brain damage, and uh, this all culminates into an increased ICP, which reduces the perfusion of the brainstem. There is the establishment of a Cushing's response, which further aggravate the brainstem ischemia. Uh, in the subsequent course, there is a sympathetic storm, which affects the cardiac functions and leads to some amount of alveolar disruption, which leads to pulmonary edema and then oxidative stress. So this vicious circle continues, and there is a progressive increase in ICP, finally leading to tonsillar herniation and brainstem death. So three things are necessary to label it as a brainstem. First, should be a presence of an irreversible coma. There should be an absence of brainstem reflexes, and there should be apnea. To label it as the triad is the active, we need to rule out other reversible causes like shock. The patient should not be in hypotensive. There should be presence of a normothermia. We should rule out intoxication and envenomation like neurotoxic snake bite. Then there should be an absence of brainstem encephalitis. Patient should not be suffering from Guillain-Barré syndrome. There should not be an electrolyte disturbances, especially severe hypophosphatemia. And you should also rule out other neurological, neuromuscular disorders that may affect the testing. So these confounders should be first ruled out. So when all the cranial nerves are examined, so the basic neurological examination consists of absence of any pupillary reflex that includes both direct as well as the consensual reflex. The cranial nerves involved are cranial nerves second and third. Then cornea reflex. It is usually tested by a cotton wick. If there is an absence of blinking response, then it's again a marker of brainstem death. The efferent and the afferent nerves involved in it are cranial nerves number 5 and 7. Then there should be an absence of an oculocephalic and the ocular vestibular reflex. We will see in the next slide what are these. There should be an absence of cuff reflex and the gag reflex. Both of these reflexes are mediated with cranial nerves 9 and 10. And patient should not respond to any noxious stimuli. The most common noxious stimulus we use is a supraorbital pressure or sometimes the sternal pressure. Now, what is oculocephalic reflex and oculovestibular reflex? So, the normal compensatory mechanisms allow the fixation of the gaze irrespective of the movement of the head. So that is a normal response. So if somebody is looking in the front, if you turn the head, the eyes move in the opposite direction so that the gaze remains fixed, as we can see in the picture. However, in the brain death, this reflex is absent. So the eye is turned down to the side where the head is turned. If her head is turned to the right side, it will turn to the right. If her head is turned to the left side, it will turn to the left. So there is an absence of this reflex in brain dead patients. Similarly, the oculovestibular reflex. So normal response is that if you put a ice water or syringe ice water in the ear, then the gaze, the eye shows nystagmus or movement towards the side where we have instilled the cold saline. Whereas the abnormal response is that the gaze is deviated to the other side. So absence of normal doll's eye and the presence of abnormal vestibular reflex signifies that patient is having brain death. When the cranial nerves have been examined, an important test is the apnea test. So again, we should rule out hypothermia, we should rule out hypovolemia, there should be an adequate fluid status of the patient. Then we should also rule out hypocapnia. So PCO2 should be more than 40 mm of Hg, and we usually pre-oxygenate the patient before starting an apnea test. So how do we do an apnea test? So for this, we pre-oxygenate the patients with the 100% oxygen, and for 10 to 15 minutes do a baseline ABG. Then we disconnect the patient from the ventilator. Uh, Once disconnected, we pass a soft catheter through the endotracheal tube, and through that catheter, we keep a flow of 4 to 6 liters of oxygen. And closely look for any respiratory movements, any abdominal movements, any thoracic movements. So this observation period continues for next 10 minutes. After the finishing the 10 minutes, we take an ABG and look for the values of PO2, PCO2, and pH. So if the patient is able to sustain for 10 minutes, then we look out to this value. If the patient becomes hemodynamically unstable, or his saturations fall below 88%, or there is presence of any hemodynamic instability due to arrhythmia, then we terminate the test. Those who complete this 10 minutes test, then we go on to see the ABG values. So if patient does not have respiratory movements during this 10 minutes and PCO2 value is more than 60 millimeters of mercury in the ABG, or if the baseline value is above 40 mmHg, then a 20% increase is in there in the 10-minute ABG, and still the patient is not breathing, then it shows an apnea test is positive. So this is a positive apnea test. Once we do it, we repeat it over the next 6 hours to verify it. So after the second apnea test, the brain test stem is certified. So this is a normal form 10A of giving certification for the brain death. So you can see it carries all the reversible causes as well as the test which I have mentioned right now. There is less chances that you may miss. You can go through these forms. It's freely available on the website. What is important to note is that this certification is done by two physicians. One of them should be a neurosurgeon or a neurophysician, and other maybe doctor who is uh, certified from the hospital in the list of the physicians or doctors who can who are part of this certification. Besides this, the hospital in charge signs this certification, and one of the treating doctors also signs this certification. Please note that none of these should be involved in the transplant program for this certificate to be valid. There are certain ancillary tests as well. In case there is a dilemma on the clinical test, then we can go on to certain tests. One of them is cerebral angiography. So as you can see in the picture, normal cerebral angiography, you can easily make out the vascularity, whereas in this is absent in case of a brainstem because there is no perfusion inside. The another common test that may be employed is EEG. So in case of brainstem death, there is a flattening of all waves. So as you can see in this picture. Another common test that may be employed is the transcranial Doppler and the radionuclide scan. So what is transcranial Doppler? So insolation of the middle cerebral artery, you can see here. So it has a positive systolic peak, then a gradual downfall, and followed by a diastolic flow. So this is a normal pattern. If the vessel is of the opposite side, then you can see the same pattern on the other half of the line. Whereas in case of the brainstem death, what we can see is that these patterns are sparsely interspaced. They may be absent. Uh, so the absence of systolic peaks, irregular peaks, they certify that patient is brain dead. With the increasing ICP, the waveform changes. So before brainstem death, you may find that there are systolic peaks without diastolic flow, or there may be an oscillating flow pattern. So these are the various stages of increasing ICP. So once the brain stem death is certified, then patient can be considered as a potential donor. You be sure that there are no reversible causes that are not been excluded before certifying somebody as brain death. So once there is an identification of a potential donor, then intensivist has a role of coordinating with the transplant team. Besides that, he has to preserve the vitality of the organs before they can be harvested. So the recommendations has been put forward by the ISCCM Society, and these I will be discussing in my further slides. So how to manage such potential organ donor in ICU? So basic approach as for any other stabilizing the patient is ABC, that is airway, breathing and circulation. So airway should be patent. So the such patients are usually intubated and on mechanical ventilation. So oxygenation is taken care of and ventilation is taken care of. Then breathing part is, since the patient is mechanically ventilated, there is apnea, patient has no spontaneous respiration, so patient is on mechanical ventilation. Circulation part is taken care of. You have to maintain adequate systolic blood pressure, which we'll discuss subsequently. There is a role of family counseling by the transplant coordinators. So once you certify them, they take over the counseling part. Then finally, there is set protocol by which there is a donor is the organs of the donors are allocated as per the national registry and state registry. And finally, it is handed over to the retrieval team when the things are ready. So what we need to take care in the while the care of this patient is that hand hygiene should be followed. There should be a position change to prevent sores, bed sores. Eye care should be there to prevent drying of the cornea. Basic monitoring which we routinely involves, that needs to be continued. Special care to be taken regarding maintaining the body temperature, and bedside echo is done to look for the cardiac status to maintain the hemodynamics. Investigations that are frequently taken up includes arterial blood gas analysis, the seeking the lactate for the tissue perfusion, looking for the electrolyte balances, and blood sugars. So these investigations are to be repeated every 2 to 4 hourly. There are other tests also done to rule out just like CBC, to rule out any infective focus, to look to keep a watch on the kidney and liver function test to have their harvestability at the time of retrieval, correcting the coagulation disorders if any, and ruling out any urine infection, besides microbiological testing for any presence of any viral infection. So there is no role of any empirical antibiotics, but if these cultures are suggestive of some infection, then a culture sensitivity directed antibiotic has to be given. There are certain absolute contraindications like presence of any malignancies or some untreatable infections like rabies, some disseminated fungal infections, febrile meningoencephalitis of unknown origin. So there are few contraindications that needs to be ruled out in this. So we need, since the patient, most of the such patients are young patients following a trauma, so you need to rule out there is a presence of any continuous loss of blood either from the GI source or bladder or in the abdomen. Keep and watch on the hemodynamics as well as the hemoglobin and hematocrit. Since patient is prone to hypotension, so we need to discontinue any antihypertensive drugs and beta blockers. To maintain hemodynamics, we need to administer fluids, and of those, balanced salt solution are the preferred ones. Albumin have been used to conserve to prevent fluid overload. However, it has shown to be moderately effective. The target blood pressure is systolic more than 100 millimeters of mercury, and mean arterial pressure is more than 70 millimeters of mercury. Usually, diuresis happens in such patients. So, vasopressin plays an important role in stabilizing the hemodynamics. It is usually started at 1 to 2 units per hour. Uh, Continuing in the hemodynamic profile, patients are predisposed to arrhythmias, maybe because of electrolyte disturbances, because of the central dysregulation. So, as routinely managed in other cases, we may use Codron or cardioversion for the maintaining. Important to note is that atropine may not be effective for bradycardia, and we may have to use adrenaline, isoprenaline, or sometimes pacing for the same. Uh, because of suppression or ineffective hypothalamic pituitary axis, we need to supplement methylprednisolone at 15 milligrams per kg once the diagnosis of brain death has been made, and this has to be repeated on the daily basis. Maintain the blood glucose in the range of 80 to 150 milligram per deciliter. You may require an insulin infusion for the same. Thyroid supplementation in the form of 300 to 400 micrograms of levothyroxine has to be administered every 8th hourly. Hypothermia is common, so you need to have an active and passive warmers for the same. We had already discussed about correcting the coagulopathy and correcting an anemia. Antibiotic prophylaxis is not routinely recommended, but once the cultures are positive or clinical suspicion is there, then you can go on for the antibiotics. Nutrition is continued as per the standard ICU protocol. So there is a checklist also provided for facilitation of management of such patients. So goal is body temperature more than 35 degrees centigrades, output of more than 1 ml per kg per hour, and saturation of more than 95%. Maintain a sodium level of between 135 to 145. Blood pressure of the range of mean arterial pressure more than 60 millimeters of mercury. Prevent adequate volume status with the help of CVB of 6 to 8 millimeters of mercury. pH in the normal range of 7.35 to 45, and continuing the nutritional support. So again, what to do in which circumstances? So this checklist uh, 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 available in through the this donors cluster randomized control trial. So it shows that if you have an electrolyte imbalances, then you should correct it, and then we need to observe them 6 hourly. Glycemic control, hemoglobin control, we had already discussed. Temperature and vasopressors, we had already discussed. If saturation is not being maintained, then we may have to adjust the tidal volume to from 6 to 8 ml per kg and PEEP of more than 8 centimeters of water. And special consideration is patients who are on ECMO. So how to go about those for the apnea testing? So we pre-oxygenate them with the 100% oxygen as in other patients. Now ventilation is taken care of by the sweep gas flow rate. So we increase the PCO2 level above 60 millimeters of mercury by reducing the sweep gas flow rate from 0.2 to 1 liters per minute. Patients with VA ECMO, from where to draw and sample. So again, if the patient is cannulated through the right carotid artery or right axillary artery, then we have to take a distal arterial sample from the left upper extremity or from the lower extremity. Those who are cannulated through the femoral artery, then we have to take the sample from the right upper extremity. This is for the VA ECMO. Those who are having cannulations uh, at other side, that is the VV ECMO, then we can have to take the sample again from the distal arterial line only. Wherever the sample we take, we have to ensure that PaCO2 and pH criteria should be matched to certify the brain death. It's not to forget that we have to avoid hypotension during the ECMO as well, and that needs to be supported with IV fluids and vasopressors or inotropes. To summarize, that we know to diagnose the brainstem death, there should be no reversible causes. Second, cranial nerves examination, the important test we had discussed, we need to carry out. Most importantly, we have to carry out an apnea test in the presence of certified doctors, two of them at least, and these tests has to be repeated at an interval of 6 hours. Once the potential organ donor is identified, then a set of protocols are there that involves the transplant coordinators and the counseling of the family members. Once the certification is done, then you have to stabilize the potential donor till the harvesting is done. And the basic goals are systolic blood pressure more than 100 millimeters of mercury, urine output more than 100 ml per hour, PO2 more than 100 mm of Hg, HB more than 10 grams, blood sugar between 80 to 150, sodium levels normally as 135 to 145, and to maintain the normothermia. So, as a famous dialogue in the movie, कि जिंदगी बड़ी होनी चाहिए, लंबी नहीं. So there is no point in pulling on the patient on mechanical ventilation or on inotropic support once the brain death has been certified. So for this, we need to be watchful, and as and when the GCS is not good or there is no reversible components, and patients needs to be tested for the basic cranial nerve functions. So this was all about brainstem death. I hope you got something about it, and I'm ready for the questions. Thank you all. So before I close, I invite you to ICACon, the 6th International and the 16th National Conference of Indian College of Anesthesiologists, to be organized this month at AIIMS Jodhpur and Hindana Hotel. You can Google the same, and I'm available for the further details. Thank you.
Thank you, Dr. Bharat.
Thank
So
you,
we
madam.
all know that the only definitive treatment for a patient with end-stage organ failure is organ transplantation. But there's a wide gap in the number of patients who require transplantation and the number of such surgeries that are happening. So it's very important for identification of brain death and preserving a brain dead organ donor. So both of this can influence the outcome of organ transplantation. Thank you, Dr. Bharat, for covering all important aspects of brain death, from the pathophysiology, testing for brainstem death, the apnea test, all the ancillary tests, and for the management of potential organ donor. Thank you so much, sir.
Thank you, ma'am. Thank you for inviting. And thank you for chairing.
Thank you, Dr. Bharat. It was a truly insightful and enriching session. And so we conclude this, our very first session. So I would like to thank Dr. Shri Priya. Thank you, ma'am, for your time and for your all your time and efforts. Thank you, ma'am, for your insights. So now we proceed to our very interesting long case discussion, which will be moderated by Dr. Sangeeta Khanna, ma'am. Dr. Sangeeta Khanna, she's MD, FICA, FAMF. She's a vice chairperson and affiliated with Medanta Institute of Critical Care and Anesthesiology. She did an observership in lung transplant from Toronto General Hospital. She has been mentor and guide to so many postgraduates of the institute. She's ex-president of ISA Haryana, and she was the organizing secretary of ISACON 2023. She has more than 50 national and international publication and 15 chapters in her record, and her area of interest are transplant surgery, robotic and thoracic surgery. So this is a very interesting case discussion. I welcome you, ma'am, to moderate this session with our residents. Our PG, Dr. Shikha, will be presenting the case, and with her, our senior resident, Dr. Anurati, will be summarizing the case. Welcome, ma'am.
Thank you. Yeah, thank you, Shikha. So,
Good morning.
Yeah, so I think we can start. So we have hello. Yes. So Dr. Shikha is going to present the case. So Dr. Shikha, we can start with your case presentation. And I think we can we'll make it interactive, and I will be asking in questions in between about how it should be in the exam. So
Good morning, ma'am. I would be presenting the case of a 32-year-old male with bilateral staghorn calculi and chronic renal failure grade 3 posted for right PCNL. My patient, Farid, 32 years old male, male by gender and Muslim by religion, and a shopkeeper by occupation residing in Ajmeri Gate, presented with chief complaints of bilateral flank pain since 8 months and pale while voiding urine since 3 months. History of presenting illness. My patient was apparently well 8 months back when he started having bilateral dull aching flank pain, which was persistent and non-radiating, gradually progressive in nature, more pronounced during physical exertion, and also not relieved by routine over-the-counter drugs. Also, about 3 months back, he developed painful micturition associated with burning sensation while voiding, increased frequency of urination, occasional passage of cloudy urine. On further evaluation, he was diagnosed with chronic kidney disease. There was no history of fever, chills, or rigors. No history of any consumption.
Okay. So how do you define chronic kidney disease?
Sorry, ma'am, I'm not able to hear you.
I'm saying, how do we define chronic kidney disease?
As per to KDIGO guidelines, chronic kidney disease is any abnormality in the function or structure of kidney lasting for more than 3 months, which has implications on health.
Okay. And what are the various stages?
Ma'am, chronic kidney disease can be classified into 5 stages based on the glomerular filtration rate, starting from grade 1, where the GFR is more than 90 ml per minute per meter square. Grade 2 being 60 to 90 ml per minute per meter square. Grade 3 being 30 to 60 ml per minute per meter square. Grade 4 being 15 to 30 ml per minute per meter square, and grade 5 being GFR less than 15 ml per minute per meter square.
So chronic kidney disease is when the patient is in which stage? When do you label him as patient having a kidney disease?
And when GFR is less than 60 ml per minute per meter square.
Yeah. So basically stage 3 onwards is when we say that the patient has chronic kidney disease and he needs to be evaluated and taken care of. Anything about the urine proteins in this?
Ma'am, based on the urine proteins, albumin, based on the albumin excretion in 24 hours, we can classify CKD into 3 stages, which is A1, A2, and A3, where there is excretion of more than, less than 30 mg per 24 hours in A1, A2
Per
is
gram
30
of
to
creatinine, yes.
30 to 300 milligram of albumin, and more than 300 is A3.
Yes. So when you actually define CKD, you need to know that the history has to be for 3 months at least. And whatever you're testing, the test should be done at least twice with an interval of 3 months between them. It's only when you do the GFR for twice and an interval of 3 months, then it is defined. And both the times, if you get the same reading or the presence of proteins in the urine on two occasions, at least 3 months apart. So that is important when you label a patient as having CKD. Okay. So your patient has a very short history,
Yes.
right? He has 8 month, only an 8 month
8
history.
months.
Yes.
Ma'am. Yes.
And for 3 months, he's been diagnosed to have CKD.
Yes, ma'am.
Yes. Okay. All right. So now in this, what is the important negative history, or what are the important things? It's a young patient, I know, 32 years old, but what is the important negative history that you would like to take in this patient?
For negative history, we have to rule out the different causes for CKD.
Okay.
I have asked for the history of fever, chills, or rigors to rule out any infectious cause for CKD. Then there is any history of consumption of Ayurvedic medication or nephrotoxic drug. Ayurvedic medication for to rule out any heavy metal toxicity, and nephrotoxic drugs like NSAIDs. Overuse of NSAIDs also can lead to nephrotoxicity. Then history of
Another
hematuria to rule
important thing is to ask for exposure to
ma'am, and
radio contrast dyes.
yes, ma'am.
Okay,
Radio
that is another important cause for, so if the patient has had multiple CT contrast or some other procedures where contrast was needed. So that is another thing that we need to ask for.
Okay.
Yeah.
Then, ma'am, there was no history of hematuria indicating that to rule out glomerular nephritis. Then there is no history of decreased urine output or anuria, indicating the patient has not progressed towards end-stage renal disease. No history of nausea, vomiting, or altered bowel habits to rule out any autonomic gastroparesis, which is
So
a
first,
consequence
okay.
of.
So see, now let's not mix two things. First of all, one history you're taking is to find out the cause.
Yes, ma'am.
Okay. The second history you're taking is to see the effects of this kidney disease on various organs. है ना? ये
Yes,
दो
ma'am.
histories basically हम ले रहे हैं ना?
Yes, ma'am.
ठीक है. So the first part of your history was to identify if there is any aggravating or precipitating cause which could have led to the kidney disease, in which you have ruled out most of your things. In the
Yes, ma'am.
second part, now we will start one by one to see what is the effects of CKD on the various organs. But before that, okay, you'll also let me know when you classify CKD on the basis of urine output, what is it? How is it classified?
CKD on the basis of urine output, it can be classified into 3 parts, where urine output is less than 0.5 ml per kg per hour for less than 6 hours.
Yes.
Then stage 2,
So
where
that is stage 3. So basically what you're talking about is, in the same classification, stage 3, 4, and 5, along with the eGFR, you can also look into the urine output. Okay, yeah. So the first one will be when it is less than 0.5 ml per kg per hour for 6 hours. After that, it will be less than
0.5 ml per kg for more than 12 hours, ma'am.
Yes, and then the
Then
last
less than 0.3 ml per kg per hour for more than 12 hours.
24 hours, or the
Okay.
patient is anuric. Okay, so that is on the basis of the urine output. Now we can now go to the next part of your history taking, where we are going to see what is the effect of this CKD on various organs. And that is all we will be ruling out in taking all the negative histories. That is the important of all the negative histories that we are eliciting. Okay? So we'll go system by system, one by one. Start with any one system that you like.
Ma'am, for cardiac system, we would like to ask for if there is any history of chest pain, palpitations in the patient. Also, if there is any history of dyspnea on exertion, to rule out cardiac causes like increased fluid overload can lead to congestive cardiac failure in these patients. Also, we can rule out for the history of hypertension in these patients, as increased fluid overload can lead to systemic hypertension. Also, we can ask for the meds of the patient to know the general cardiopulmonary reserve of the patient.
So the
These
effect of
patients,
CKD on the cardiac system is, one is the patient can be hypertensive.
yes, ma'am.
Yes, and
Then,
that is
ma'am,
because of the
in fluid over, there is
Fluid
a fluid
overload.
overload, altered renal angiotensin aldosterone
yes. So these are the
system.
two main causes. Hai the second thing the patient can have ischemic heart disease.
Yes, ma'am. It is due to the increased accelerated progression due to the presence of triglycerides. Increased triglycerides
Yes,
in these
very good.
patients
Yes.
can lead to ischemic heart disease, atherosclerosis, which can eventually lead to ischemic heart disease.
Yes, and also hypercalcemia, which can sometimes may be responsible for the calcification or
arrhythmia,
plaques which are present. Yes. So one was hypertension, second is IHD, third you already told that congestive cardiac failure, maybe because of fluid overload or because of some kind of a cardiomyopathy, which may be present in these patients. And finally, arrhythmias, which could be multiple reasons. It could be electrolyte imbalance, it could be fluid overload, it could be metabolic causes. So these are the pronounced 4 effects which you will rule out in the cardiac system. Anything else?
We can also ask for uremic auscultate for pericardial rub present there, which could be in uremic pericarditis patients.
So pericardial effusions which may get infected or something, and he can have a pericarditis. Okay. Then let's come to the next organ.
Ma'am, second, in a respiratory system, patient might have again difficulty in breathing while walking, or may complain of a sharp pain while breathing, which can indicate towards pleuritis. There is also these patients have since there is increased fluid overload in these patients, it would lead to interstitial and alveolar edema, which can lead to ventilation perfusion mismatch in such patients, eventually leading to hypoxemia. So these patients might have difficulty in breathing, or their meds might be less than 4 in these patients.
So the common things that you can get is a patient with fluid overload. He can have a pleural effusion.
Yes, ma'am.
Yeah. Then he can have some kind of an infection, consolidation. They are prone to infections. And
yes, ma'am.
And pulmonary edema, which we've already discussed.
Also, ma'am, these patients have metabolic acidosis. Eventually, to compensate for metabolic acidosis, there might be an increase in respiratory rate. These patients might be hyperventilating and can present with tachypnea.
Yeah, and also all these things can eventually result in high PA pressures in these patients. So what kind of a lung disease do you expect in this patient, restrictive or obstructive? It will generally be restrictive.
Restrictive.
Yeah, because you're talking of interstitial lung disease, repeated infections, increased shunts. So mostly it would be a restrictive kind of a lung disease in these patients. Okay. Next, which next organ?
For gastrointestinal system, we'll ask for if there is any history of nausea, vomiting. Because in these patients, there is autonomic neuropathy, which leads to increased gastric emptying time. And hence they are more...
or decrease?
Delayed gastric emptying time.
Yes, delayed gastric emptying time. Why is it important to know that they can have a delayed gastric emptying time?
Ma'am, they are prone, if these patients have delayed gastric emptying time, so they are prone for aspiration. There is increased risk of aspiration. Would be there in these patients.
Yes. So nausea, vomiting, and altered bowel habits, as you've said. So they may have constipation or diarrhea. Okay, so that is the GI system. Okay, then.
Then, ma'am, in hematological system, these patients might present us with anemia. Pallor might be present in these patients.
Okay. What are the causes of anemia in patients with CKD?
Ma'am, anemia can be due to first increased fluid overload is there, so dilutional anemia would be there. Then there is a decreased lifespan in RBCs due to uremia. Then third, there is a chronic blood loss through gastrointestinal in GI system due to mucosal ulcerations. Then there is there is bone marrow suppression. Sorry, there is bone marrow suppression due to immunocompromised state, leading to anemia and
One main thing.
decreased erythropoietin production is there.
Yes. So there is decreased erythropoietin production in these patients. And also they have low levels of iron and folate. So all these things will result in anemia. Okay. And so how does the body compensate for this anemia?
There would be patient would have tachycardia. In these patients, tachycardia would be there to increase the cardiac output
What
for
else?
these patients.
What else? What happens to your oxygen dissociation curve?
Oxygen dissociation curve shifts towards the right. There is increase in 2-3 DPG.
DPG levels, and which causes the oxygen
shift towards the right.
Yes. So that more oxygen is available to the tissues.
Yes.
Okay. So then next, so we've talked about the heart, we've talked about the lungs, we've talked about the GI, we've talked about the anemia. Other systems?
CNS, ma'am, we can ask CNS if there is any. These patients can have autonomic neuropathy, peripheral neuropathy, or if also it can progress to uremic encephalopathy mostly.
Yeah.
So we can ask for if there is any history of if there is any change in behavior of the patient, altered sensorium is there, or disorientation is there for to rule out uremic encephalopathy. Then in peripheral neuropathy, we can look for if there is any numbness, paresthesias, and muscle twitching is.
Yes. So it is a glove and what is it?
Glove and stalking sensory losses
Distribution,
present
yes.
in these
Yes.
patients.
What are in the central nervous, what are the other things that can happen? He can have uremic encephalopathy. What else that we should keep, especially if the patient is on dialysis?
Ma'am, there can be two syndromes related to dialysis. First would be the dialysis dementia, and second one would be the dialysis disequilibrium syndrome.
Very good. So, क्या होते हैं ये?
Ma'am, dialysis dementia occurs in patients who are who have been on dialysis since months to years. It is actually due to the deposition of aluminium, especially into the basal ganglia.
Yes.
There is deposition of aluminium. So this leads to the change in behavior, altered sensorium to these patients, and can even lead to disorientation. Patient might have might not be able to speak properly. There are other
and the other
behavioral
is
changes.
the dialysis disequilibrium syndrome, है ना?
I mean, dialysis disequilibrium is usually occurs when patients have very high urea levels, or or when there is a first time of dialysis.
Yes, so that sudden change in the urea levels is
rapid excretion of urea leads to dialysis.
Yeah. Very good. So CNS और कौन से organs रह गए? Coagulation.
Ma'am, endocrine system.
Okay, endocrine. हाँ बताओ endocrine में.
Ma'am, there is a decreased production of vitamin D3 in these patients, which leads to decreased calcium absorption, leading to hypocalcemia. Also, there is decreased excretion of phosphates in these patients, leading to hyperphosphatemia. Both hypocalcemia and hyperphosphatemia together leads to secondary hyperparathyroidism in these patients, and which eventually makes them prone. There is decreased osteoblastic activity and increased osteoclastic activity. Therefore, making them prone for bone fractures or eventually leading to renal osteodystrophy.
Yes. So Raised alkaline phosphatase levels is a common finding in these patients. Okay, so we did not have to evaluate if a patient who, on workup has raised ALP that, maybe he has a liver disease. It's a common finding. So we don't need to further work up on these patients. So when you talk of endocrine one, and secondly, what happens is because of the hyperphosphatemia, the phosphate binds also with the calcium, and there is a lot of calcium phosphate deposits which are present that further aggravates the hypocalcemia that is present in these patients. And what else happens?
There is, ma'am, decreased triglyceride, increased triglycerides in the system, leading to accelerated atherosclerosis. Also, there is peripheral insulin resistance in these patients.
Insulin. So the patients are more prone to develop diabetes.
2% all.
Yeah, and also diabetes. So that is the endocrine system. Okay, then the coagulation. What happens to the coagulation?
Coagulation of platelets, there is a decreased adhesion and aggregation present due to decrease in von Willebrand factor and factor 7, which leads to decreased platelet adhesion and aggregation, eventually increasing the bleeding time and clotting times.
And clotting times.
Yes, bleeding time, ma'am. Only bleeding
yes. Time. And what else? One is that they may be hypocoagulant, but on the other side, they are also in a
prone to bleed also.
Prothrombotic stage also. तो दोनों तरफ से होता है. Because of the platelets, they are prone to bleeding, but they are also in a prothrombotic state because of the fibrin. So they are also prone to developing DVT. So we have to look at both the sides. Okay, so we have to tread very carefully when we are treating these patients. And finally, one more metabolic thing that is left out. I think all the other organs are covered. Is the most common finding that you get in all these patients?
Hyperkalemia.
Yes.
Electrolyte imbalance and metabolic
Yes.
acidosis.
And hyperkalemia. And why does this happen?
There is a decreased potassium excretion in these patients, which leads to hyperkalemia.
And what else? What are the other reasons? There is decreased potassium excretion, and along with that, there is decrease in the bicarb regeneration also. So your buffers of the body are also not acting, and that is why. What kind of acidosis do you have? Normal and
high anion gap, ma'am.
High anion gap. Yes. And because to balance this hyperkalemia, the hydrogen also needs to come out. Okay. What are the normal potassium levels in the body?
Ma'am, 3.5 to 5.5 milliequivalent per liter.
And what are the changes that you find when the patient starts developing hyperkalemia? What are the ECG changes that you will have?
Ma'am, it can be divided into mild, moderate, and severe, where mild is 5.5 to 6.5. In 5.5, there would be peak T waves and prolonged PR intervals. Then 5.5 to 7.5 would be defined as moderate, where there would be widening of QRS complexes, prolongation, loss of P wave could also be there, and SC segment depression might be there. Then more than 7.5, it can lead to a sine wave pattern and eventually leading to asystole.
Yeah. Okay. So यहीं पे फिर बात कर लेते हैं. Okay. How will we manage hyperkalemia?
Ma'am, hyperkalemia, we can divide it into 3 parts. First is the membrane stabilization, which we have to focus on, the cardiac membrane stabilization, for which we'll give calcium gluconate, 10 ml of 10% calcium gluconate to be given over 10 minutes. Then second would be, ma'am,
5%. Normally that is available is 5%. Okay, 10 ml of 5%. 500 milligram वाला आता है आजकल, ठीक है?
Then, ma'am, second would be we have to shift the potassium into the cells. For that, we would give injection insulin 10 international units along with 100 ml of D25. And we can also give a nebulization with a salbutamol of 10 to 20 mg in a 4 to 5 ml NS. Then we have then there we could use loop diuretic like furosemide for excretion of potassium into the urine. Also, for in chronic cases, we could also use resins like oxalate. 20 gram in 20% sorbitol has to be given over.
Bind can be used, है ना? और क्या होता है, और क्या यूज कर सकते हो जनरली, और क्या देते हैं हम साथ में? सोडा बाइकार्ब.
Soda bicarbonate.
Yes.
Soda bicarbonate.
ठीक है, ओके, चलो, तो लेट्स मूव अहेड नाउ. So all these things we are going to take in the history, basically to identify if the patient has any end organ damage or any organs which are involved. Okay. So now after you've taken your history, so what is the diagnosis that you've come to in your patient?
Ma'am, my patient is a 32-year-old male.
Okay.
Presented with a bilateral flank pain since 8 months, associated with the increased frequent, which was aggravated on exertion and gradually progressive in nature. Not relieved by the over-the-counter drugs, also associated with increased frequency of urine, which was
Your
also
diagnosis is basically patient with
a
CKD
patient with
bilateral.
CKD renal calculus, bilateral
Most likely.
stagnant calculus.
Yeah.
Most
Okay. I'm
likely,
not going
yes,
into the differential diagnosis and how will you identify that it is a kidney stone and it is not the pain because of some other organ. I think all those things you will have to again do in the history, because otherwise it will become too long if we just continue talking about the differential diagnosis also. So just let's go. Okay, this is the diagnosis that your patient has renal calculi and he is posted for PCNN. Okay, so in the examination, was there any positive finding? Just tell me if there's any positive finding in the examination.
Only pallor was present in the patient.
Okay.
There was no other positive finding.
All right, fine. Okay, fine. Let's move ahead then. Okay. So so when we start you working up this patient, you get the investigations done. All right. So these were the investigations that you got. Hemoglobin was 9, TLC, DLC, platelets. All right. So since we are talking about this, now tell me 2-3 things. What are the sensitive markers for identifying early onset of renal disease?
Proteinuria, ma'am.
Proteinuria. What else? What are the other new markers that are there? Molecules?
EGFR.
EGFR. How do you calculate the EGFR?
Ma'am, we can calculate EGFR from Cockcroft-Gault's equation,
All
which
right.
is 140 minus age into weight divided by 72 and serum creatinine levels, and we add a factor of 0.85 for females.
Okay. All right. And nowadays, is there some other equation also which is used? You have the MDRD, modification of diet in patients in renal disease. Okay. And the latest now is the CKD-EPI. What is the difference between this and the Cockcroft-Gault equation? Is that in place of creatinine, what do they use? They're using cystatin. Okay, and why is cystatin being used? That is why a new marker that is being used these days is the serum cystatin levels. Okay, so any idea why cystatin is preferred over creatinine? Because it is not affected by
produced or it is not
Yes.
produced nor excreted in the body.
Yeah, it is not affected by muscle mass. It is not affected by age. So all those things make it a better marker as compared to creatinine. Okay? So one of the tests these days that is being done is the levels of serum cystatin. What other newer more sensitive markers are available? Especially to
Albumin
diagnose,
creatinine.
especially to diagnose CK, if there is early onset of renal disease in the post-op period. Whether
PMS scans, ma'am.
no blood tests. Some markers, sensitive markers, which are markers of injury, kidney injury. You have NGAL. Suna, nahi suna, aajkal all the papers are using NGAL, no? Creatinine is not a very clear marker, no? So what we are using these days is NGAL and the kidney injury molecule. These are the two which are most commonly used these days, especially patients who are in ICU or patients like CKD who are undergoing major surgery, and whether you want to identify if the patient is developing. Because urine output in the post-op may not always be a reliable marker,
Yes, ma'am.
right? And creatinine also may take time. It's not that immediately it will reflect the increase in creatinine. So most sensitive markers are the NGAL, that is neutrophil. NGAL is neutrophil gelatinase associated lipoprotein, and the other one is your kidney injury molecule 1. So these are the markers which are used these days. So you should know about them, that what are the newer markers that are available to identify kidney disease. Okay.
Yes.
And other than these routine tests, what are the other electrolyte imbalance that you would expect in these patients other than your sodium, potassium, calcium for hand?
Hyperphosphatemia would be present, ma'am.
So
Hypermagnesemia can.
hyperphosphatemia, phosphate levels कितने होते हैं और कब आप बोलते हो कि hyperphosphatemia है?
Ma'am, phosphate levels are normally 2.5 to 4.5 milligram per DL.
Yes. So if it is
When
more
we-
than 4.5, then it requires treatment. So
Yes.
how are you going to treat hyperphosphatemia?
First we have to avoid stop any product which has intake of phosphates like dairy products, dry fruits,
So
nuts.
dietary restrictions.
Then, ma'am, we can use phosphate binders, which can be calcium based or non-calcium based. Calcium based are calcium acetate, and non-calcium based can be sevelamer. And ma'am, we can also for dialysis in these patients to reduce phosphate levels.
Phosphate.
And we can supplement them with since this is due to secondary hyperparathyroidism, we can supplement them with vitamin D3.
Vitamin D. Yes. Yeah. So just a plain vitamin D3 supplementation will also help.
Yes.
Okay, na? And what happens to magnesium?
Ma'am, magnesium levels are also raised. Normal magnesium levels are 1.7 to 2.2 mg per DL.
Yeah. So hypermagnesemia may also be present. Okay, na?
Yes, ma'am.
So these are the basic blood investigations, and obviously you'll do the CT and ultrasound to diagnose that the patient has bilateral renal stones. Since he's a young patient, we will not go into the cardiac, because there is obviously we know that there is a strong association of coronary artery disease or cardiovascular disease in patients with CKD. But he's a young patient, so we really do not have to go into that protocol and the guidelines. So we'll not discuss those guidelines for when will we do advanced cardiac testing. Okay, we'll talk only because it's a young patient. Just tell me which is that one marker which is there in your cardiac scoring, which tells you that the patient's score for CAD is increased.
Creatinine more than 2
Yes.
mg per
Yeah.
DL.
So that is a important marker which is present in the for the risk
I
scoring
see.
systems in patients with CAD. Okay, so you worked up your patient. The patient has ABG is good, bicarbs may be low because of the metabolic acidosis that is present. Okay, so this patient is there in the ward, and he's planned for surgery the next day. So what is the preparation that you're going to do? What are the things that you're going to tell him? And also, how will you identify whether this patient needs a dialysis before surgery, or can I take him up for surgery immediately without any dialysis? So tell me all those things.
Ma'am, firstly, for the indications of dialysis, it can be divided into two parts. First is the clinical part, and second is the based on the lab investigations part. Based on clinical, it can be on 3 points. First is if there is fluid overload, like when there is a cardiac failure, or there is increase in weight of the patient. Second, then there is, ma'am, uremic, if the patient is suggestive of uremic encephalopathy. Third, there is pericarditis is present in these patients.
Good.
These are the clinical ones. Then,
Yes.
ma'am, then the lab findings.
Mm.
If serum potassium is more than 5.5 milliequivalent per liter, we can go for dialysis. Then increase in blood urea nitrogen more than 20 mg percent per day, or increase in serum creatinine 1 mg percent per day can be also an indicator for dialysis.
Or absolute
Abs-
values of serum creatinine more than 6.
More than and potassium more than 7 would be the absolute for
Or present of severe
dialysis.
acidosis again.
Acidosis. Yes.
Okay, so these are the indicators for dialysis. Okay, so now this patient does not need any dialysis. He's there in the ward. You've done the PSC, and now you have to go and consent him and plan him for surgery. So, what are the anesthetic orders that you're going to give him?
First would be the NPO orders. I'll ask for the patient for NPO for 8 hours for solids and 2 hours for liquids. Then written informed consent for general anesthesia would be explained to the patient along with the risk and benefits. Then I'll ask for the continuation of tab amlodipine as it was in the treatment history for the patient on the morning of surgery. I'll ask for serum electrolytes on the morning of surgery, as these patients are more prone for electrolyte dysfunction. So I want to know the baseline on the day of the surgery. Then, ma'am, I'll anti-aspiration prophylaxis. I'll ask them
Is
to.
this what you're doing routinely, or you have just written it?
No, ma'am, we are doing it routinely.
Okay. Okay. I mean, personally, I don't think there's much of a role. Because if the patient is adequately fasting, then there is no role of giving metoclopramide. Especially because patient is in the ward, he may not have a IV cannula or anything. So giving him an injection, and if he's adequately fasting, तो बहुत ज़्यादा फायदा नहीं होता. I mean, if you can, it's your hospital protocol, it's fine. But personally, we don't give it. It's not required. Unless you're talking of a patient who's coming in the emergency, or you're thinking he may be full stomach or he's not adequately fasting.
No, ma'am, angiolysis prophylaxis. I would like to avoid tachycardia or increased BP in these patients. So I would prescribe tab alprazolam 0.25 mg on the night before the surgery, and regular antibiotic and lignocaine sensitivity testing.
Again, are you're doing this as a routine?
Alprazolam, yes, ma'am.
No. Antibiotic and lignocaine sensitivity.
Yes, ma'am. Antibiotic and lignocaine sensitivity we are doing.
For all patients?
Yes, ma'am. We do for all patients.
Okay. All right.
Then,
There's
ma'am,
no role as such. Because most of the studies have shown that despite the sensitivity, the patient may still develop a reaction. And all the patients may not come up, with the sensitivity. So there is no role of, unless you have a patient who is already giving you a history that he's prone to developing, he's in the past had allergies to multiple drugs or something. Otherwise, it's not done these days. Antibiotic and lignocaine sensitivity. Okay. And stent, blood grouping and cross matching. Okay. Anything else? So we would like to add some kind of an H2 blocker or something, maybe give him a ranitidine at the night or in the morning, or whatever, omeprazole or pantoprazole, something. Because he will be prone to nausea and vomiting also, and we are keeping him fasting for long. So give him some kind of a And these days, because of the ERAS protocol, you can always advise them to take some kind of a clear fluid 2 hours before surgery. It will reduce his nausea and vomiting. So a carbohydrate drink if you would like, or an apple juice, or whatever, So that is always preferred, especially it's a young patient who's borderline CKD and not too sick. He will always, giving him something 2 hours before will always be beneficial. So give him some kind of a carbohydrate drink before we take him up for the surgery. Okay, so the next morning the patient comes for surgery, you take him to the OR. So what are you going to do? What is your plan of anesthesia? What are the things that you will keep ready? What drugs you will prepare? What drugs you will avoid?
Ma'am, my plan of anesthesia would be a balanced general anesthesia with controlled mechanical ventilation.
Mhm.
I would prepare induction drugs for general anesthesia and emergency drugs also. The drugs I'll prepare would be, ma'am, injection.
Start with the
midazolam.
monitoring. Monitoring आपने ये लिख दिया सारा. Patient comes in the OR.
Yes.
Okay. So the plan is
We'll
created. Yeah. So
yes,
you ECG, pulse oximeter, non-invasive
pulse
BP, temperature.
yes.
Anything else? One more thing. All of you miss it.
Blood sugar.
No, that's the monitoring you'll do intra-op. No, not when the patient comes to the OR. DVT. Always have your DVT pumps on once the patient is there. It's a bilateral PCNL. It may last long. And again, we've said these patients either may be prothrombotic or you don't know. So, okay. So
Yes.
the pumps, in fact, ideally should be on the moment the patient is on the OT table, not even after induction, before induction. Okay.
Yes.
So DVT pumps attach karoge. After that, you've attached the monitors, you have an IV line access. Okay, so now you're talking about anesthetizing patients. Tell me, what are the drugs that you like? What are the drugs you want to avoid?
Ma'am,
Let's start from induction, from from your opioids.
Ma'am, we would prefer short-acting opioids like fentanyl.
Okay, why will you not use morphine or pethidine?
Ma'am, morphine has morphine metabolizes into morphine 3 glucuronide and morphine 6 glucuronide, of which morphine 6 glucuronide is more potent, has a major renal excretion, and since he's a CKD patient,
Yeah.
TF is prolonged for this.
And pethidine?
Ma'am, for pethidine, there is an increased metabolism of the drug.
No, it gets converted into a metabolite which is active.
Norpethidine, ma'am.
Yeah, and that is nephrotoxic, and hence pethidine is avoided in these patients. Okay.
Yes.
And if you have remifentanil available, then ideally a ultra short acting opioid would be preferred. ठीक है? ये हो गया opioids. Next, coming to induction agents. Any preference? Propofol, anything that you can use anything. Propofol, etomidate, thiopentone. We'll have to rush because we don't have too much time. So I'm just because इसके बाद उसको present भी करना है ना? ठीक है?
Yes.
है ना? ठीक है. फिर आपने ओके मसल रिलैक्सेंस कौन से यूज करेंगे कौन से नहीं करेंगे?
Metrocurium and cisatracurium can be used as they are not excreted by the kidneys. They have Hoffman elimination and hydrolysis by esterases is there. Vecuronium and other depolarizing muscle
Vecuronium can also be used, but what cannot be used?
Pancuronium, ma'am, cannot be used.
Pancuronium and galamine. वो आजकल मिलता भी नहीं, but हाँ, pancuronium should not be used. In your inhalational agents?
Ma'am, inhalational agent, I would prefer isoflurane as an inhalational agent, as it produces least amount of fluorides and least it has a renal excretion of less than 0.2%. So
what are you going to avoid?
Ma'am, I would like to avoid sevoflurane, ma'am. Sevoflurane at low flow anesthesia at 1 to 2 ml per 1 to 2 liter per minute can lead to formation of compound A with soda lime, which has been stated to be nephrotoxic.
ठीक है. And methoxyflurane and enflurane?
Ma'am, methoxyfluorine and methoxyfluorine is also and fluorine are also nephrotoxic, so I would like to avoid.
Because of the increased fluoride levels, that it will result in increased fluoride levels.
Yes.
अगर RSI करना है तो क्या use करोगे?
If the patient's potassium levels are within normal limit, I would prefer succinylcholine. But if the potassium levels are more than 5.5 milliequivalent per liter, I would go for rocuronium.
ठीक है, done. So we've discussed the anesthetic agents. And obviously, if this patient, if there was something that we can do under regional, then we would prefer giving a regional, provided his
INR coagulation profile is
coagulation
within
profile
normal
and platelets are
limits.
normal.
Platelets are in the limits.
Okay, so now we have this position. You have induced your patient. Okay, now we have ventilated. Yes, positioning. What are the important things that you will keep in mind? It's a prone
Ma'am,
position.
yes,
So,
prone for
italic
PCNL, we
prone.
go for prone position. So we have to go first. Before positioning the patient, I would do adequate eye padding of the patient, adequate throat packing of the patient.
Why throat packing?
To prevent any aspiration of
I think that if you have a secured endotracheal tube, why throat pack? कुछ oral थोड़ी कर रहे हो, अच्छे से suction करना होता है.
okay.
Because the moment you put prone and if the patient has a lot of secretions, then it'll all come out, it'll drool. There are chances that when you have tied your tube, the bandage may become loose or because of the secretions,
Yes.
if there is soiling of, the face and all those things can have, skin lacerations or ulcerations and all that can happen. But you don't need to do a throat packing. You have to do a good suction. That is the
But we'll
important
also-
thing before you turn your patient.
We'll also give an anti-Cialis to the patient. The
Not
injection
needed. Why do you want to give?
to dry out the secretion.
Why do you want to do? Afterwards, it's going to give problems to the patient, no? He's not a patient of whom you want to dry the secretions. You just want to once suck them out. That's all.
Okay.
You suck out the throat secretions. You empty his stomach. If there is anything, anyway, he's adequately fasting. तो कुछ होना नहीं चाहिए. At the most, you just leave a suction catheter inside so that if there are any secretions, they will come out and collect in the bag. Okay, so there is no
Yes.
need for giving any anti-silagogue. There is no need to put a throat pack.
Okay.
Okay, yeah.
Yes.
So you intubate the patient, do a good suction, maybe put in a suction catheter. After that, yes, do an good adequate padding for the eyes. Yeah.
I bet we also have to pad the pressure points to prevent any peripheral nerve
Yeah.
injury.
So how do you what are the nerve injuries that we anticipate in this patient? And secondly, where are we going to keep the bolsters?
When the bolsters are either we can put two vertical bolsters along the abdominal wall to leaving our abdomen free. Or we can put two horizontal bolsters, one at the level of pelvis and other at the just
Yes.
below the thorax.
Okay.
To
And
keep
what are
them
the
in.
nerves that we are going to take care of?
Ma'am, there could be brachial plexus injury. There could be ulnar nerve injury. There could be facial nerve injury could also be there. Then
Okay.
ma'am, peroneal nerve and sciatic nerve injuries
Yes.
can
So
also
you
be
have to
there.
take. If you have gel pads, then you use the gel pads to protect all the nerve injuries. We know that you have to adequately use gamzees and rolls to ensure that they are adequately padded. Okay. And obviously, and what else are you going to use? Obviously, you will check the tube it's in place and use active warming devices. Okay, because there is a lot of fluid that it's a PCNL. There is
Yes, ma'am.
continuous
Risk
irrigation
of
of
hypothermia is there in these
yes.
patients.
So, ठीक है?
Adequate warming.
Yes, and use active warming devices.
Yes.
Okay, your bare rubber or something should always be there right from the beginning, and in the afterwards also when they are painting and dripping, start it from that point because there's a lot of body area that is exposed, and the patient will start losing heat immediately. So, ensure that you are adequately warming this patient. ठीक है?
Yes.
And fluids का क्या ख्याल रखना है?
Balance all solution like
How much?
Ringalat or plasma light can be used in these patients. and we have to maintain normal bulimia. We have to avoid any fluid
Separate,
overload in
because
these
there is a lot of
patients.
fluid which is anyway going to be absorbed also because of the irrigation and everything. So the fluids we actually give will be restrictive.
Yes.
ठीक है ना? Okay. And analgesia ठीक है, PCM कर सकते हो, ESP block दे दोगे, very good. Avoid nephrotoxic drugs. One more, we will do, if we have, do a VBG or ABG to see the electrolytes in drop once. And suppose this patient starts bleeding, how are you going to take care? A patient with CKD, how do you treat the bleeding?
Ma'am, first we'll look for the we'll ask for the surgeon about if
pack it.
there is any major vessel has been punctured or there, then we'll also give
You can use
we'll give
transient.
a fluid resuscitation. We'll try to fluid resuscitate the patient, but also we can give colloid
Stop
in
the bleeding. Basically, what we will do, we can use
Tranexam.
tranexamic acid. You can give cryoprecipitate, and what has been found most useful has been desmopressin.
Yes.
Okay, patients with CKD, if they bleed a lot, then desmopressin has a very important role to stop the bleeding. ठीक है? एंड ठीक है, तो ये हो गया, हमने ब्लीडिंग का बात कर लिया, हमने पोजीशन की बात कर लिया, हमने पेन के लिए बात कर लिया, फ्लूइड्स की बात कर ली, हीमोडायनामिक्स मेंटेन करेंगे, ड्रग्स कौन से अवॉइड करेंगे, ये सारा हो गया. एंड यूरिन आउटपुट आल्सो इज समथिंग दैट यू विल मॉनिटर इन दिस पेशेंट.
Yes, ma'am.
ठीक है ना? They can be prone to septicemia, especially. What are the problems that we can have is hypotension, dyslipidemia. Another important thing you can have with PCNL is
Water intoxication can
सब
occur.
कुछ हो सकता है. You can have a pleural puncture. Always
Pleural
remember
puncture, yes.
that there can be a pleural effusion the patient can develop. He can develop high airway pressures. There can be some amount of pneumothorax. So that is a very important thing, that you need to monitor your airway pressures and everything when you're getting a PCNL done, because there can be some amount of fluid also that can go because of the connection between the pleural thoracic and the abdominal cavity.
Yes, ma'am.
ठीक है, तो वो
Yes,
उसका ध्यान रखेंगे. And they can go into bacteremia, especially if it was an infected stone.
impacted stones can.
Yes, infected hai, so they can go into some kind of bacteremia or septicemia. So that is why also it's important to maintain good hemodynamics. And if we find that the patient is developing hypotension, which is not because of hypovolemia, it could be because of bacteremia.
Yes.
ठीक है, and
Yes.
ये सब हो गया. Obviously, prone may he can have optic neuropathy, ischemic neuropathy, so we have to monitor for that. ठीक है, and we will reverse this patient. Then there is also role of using N-acetylcysteine and phenoldiazepam and dopamine, but all of that is just in the literature. In clinical, it has not been found to be of much use as renal protective agents. It's more of maintaining the hemodynamics and maintaining the hypoperfusion to maintain a mean BP between 70. Keep your mean arterial pressure above 70, so your autoregulation is maintained. ठीक है, that is the main thing. Maintain your fluid status and maintain your hemodynamics. Extubate the patient. Look at all these. And the post-op also look out for pleural effusion or any pneumothorax that the patient may develop, especially if he is and bleeding. ठीक है. And monitor your renal functions. Fine. I think good. I think we've covered most of the points. You know, so I think now we can ask Nifty to,
Ma'am, still you can discuss. You have 7 more minutes for your discussion.
Acha, that's for my discussion also. Okay,
Yeah,
I thought
yeah,
it was
ma'am.
the total time.
No, ma'am. SR time is different. These 60 minutes are for your total
Okay,
discussion.
all right. Okay, so now then tell me, what is the rifle scoring?
Sorry, ma'am.
Rifle.
Rifle. Ma'am, rifle is a criteria for acute kidney injury. Rifle stands for, first is the risk, injury, failure, loss, and end-stage renal disease, where risk is for when there is increase in serum creatinine level more than 1.5 times the baseline. Then, ma'am, in injury, there is more than 2 times of
And
rise of
GFR
serum.
or fall in GFR of more than?
25%, ma'am.
Yes.
Fall in GFR is more than 25%. And
And
in ma'am,
urine output is
urine output is less than 0.5 ml per kg per hour for less than 6
6
hours.
hours. Yes. Then
Then
injury.
ma'am, injury, there is more than 2 times increase in the baseline serum creatinine levels, or there is a fall in GFR of more than 50%, and fall in there is a urine output of less than 0.5 ml per kg per hour for more
12.
than 12 hours.
Good.
Then ma'am, failure, there is a increase in serum creatinine more than 3 times, or there is serum creatinine level of 4 milligram per deciliter, along with an acute increase in serum creatinine level of more than 0.5 mg per dl, along, along with urine output being less than 0.3 ml per kg per hour for more than 24 hours, or anuria for more than 12 hours.
And then loss is if the patient has acute renal failure which persists for
More than 4 weeks.
4 weeks. And finally, end stage renal diseases when it is more than
3 months.
3 months. Right. So this is your rifle scoring. Okay.
Right.
In the what kind then इसके अलावा ये बताओ is erythropoietin useful in these patients, or should they be any role of to treat the anemia?
Usually erythropoietin is given in patients where HB is less than 10 milligram per 8 less than 8 where HB is between 6 to 8 milligram per deciliter in these
So
patients.
early erythropoietin has been found to be useful. Okay, it's always in these patients with CKD and having anemia, starting erythropoietin therapy is beneficial because it helps to improve the overall status of the patient. Okay, so we should always initiate it early, and we can accept patients who also have 8 or 9 grams of hemoglobin for surgery. We don't have to wait to optimize and wait till they are more than 10 grams.
Yes.
If they have CKD. Okay, if this patient has a fistula, what are the things that you will keep in mind?
Fistula care has to be taken, has to be done. We do in intraoperatively, we do not have to attach any monitors on the side of the fistula. We have to cover the fistula, mark it with label it as a fistula site to avoid any injection or cannulation at this site. Also, ma'am, when the fistula is made, we have to wait for 4 to 8 weeks for it to become functional for the fistula, for the dialysis to be started from that fistula.
Another important thing which you need to document is that the fistula is functional.
Yes.
Okay, you will mark it, you will take care of it, you will put an adequate role, but before all that, at least palpate and see that it is functional.
Yes.
Because it may happen that the fistula was not working before, and in the post-op, it comes on to you that पहले तो चल रहा था, अब तो काम नहीं कर रहा है. That means you did not maintain the hemodynamics of the patient well. Okay, so always if a patient comes with a fistula, always palpate it, see that you can feel the thrill or the bruit or whatever is there, and mention that yes, fistula function and its location in your file, in your PSC chart, before you take the patient up for surgery. Okay, so always document that, and that is again an important reason of maintaining the hemodynamics so that the patient does not develop hypotension. Okay, is dexmedetomidine a good drug in these patients if you have to use it?
Yes, dexmedetomidine is good for analgesia, amnesia can be there with dexmedetomidine. It does not cause any respiratory depression in these patients.
See, it's not a
Also-
nephrotoxic drug, but ideally it is not a good drug in these patients because it can cause bradycardia and hypotension. And the effect also is prolonged. So you can use it, but ideally it is not a drug of choice. And if you are using it, then you have to ensure that the patient does not develop bradycardia and the hemodynamics are maintained. Because it's an alpha 2 agonist, it may sometimes cause, especially in patients with CKD, a precipitous drop in blood pressure. And the effect has also been found to be prolonged. So ideally, if possible, avoid using it. But or if you are using it, then ensure that patient does not have bradycardia or does not develop hypertension. Okay. So that is why it's not a very good drug to be used in this group of patients. Then इसके अलावा और क्या चीजें थी जो मैंने run through किया था. I think we've covered most of the things. We can. I mean, I'm not discussing about advantages of dialysis in these patients. Advantages of early dialysis, or whether the patient should be taken up for transplant if they have CKD. Obviously, it has been found that early transplant is better than keeping, because of the dialysis associated complications, and they develop more hemodynamic metabolic changes. So if the patient has CKD and is planned, then ideally he should go in for transplant much before, if he has a donor available. Till the time a donor is available, he can undergo dialysis. And I think dialysis is something which is a vast topic, which we cannot talk in this thing. Advantages, disadvantages, types, all those things, various routes in which it is done. So dialysis के बारे में हम इसमें नहीं cover करेंगे. And okay, post dialysis. Suppose the patient was on dialysis, what are the things that you would see before you take him up for surgery?
Dry weight of the patient, we'll look for the dry weight of the patient. We'll look for the serum electrolytes of this patient. Post dialysis, these patients are prone for hypokalemia. Also, these patients post dialysis hypotension is also a common complication in these patients. Then, ma'am,
ideally we will wait for at least 2 to 4 hours, so that the fluid
heparin is
the heparin gets neutralized, and the fluid also gets balanced between the various intravascular extravascular होता है, तो वो भी एक balance हो जाएगा, and we will ask for electrolytes, CBC and coagulation profile before we take them up for surgery. ठीक है? Okay. Thank you, Shikha. I think now we can ask Dr. अनुकृति to go for the. मैं नाम उल्टा तो नहीं कर रही ना शिखा और अनुकृति के बीच?
Good morning, ma'am. I'm Dr. Anuriti Rana, and I will be summarizing managing CKD in a patient with staghorn calculi posted for PCNL surgery. First, we'll discuss what is CKD, what is the effect of CKD and organ system in the body, and the anesthetic management of a patient with CKD. First, we'll discuss about the function of the kidney. The kidney helps to regulate the acid-base balance, the water balance, the electrolyte balance, remove toxins and waste from the kidneys, blood pressure control, erythropoietin production, as well as the vitamin D activation. So what is CKD? It is defined as an abnormality of kidney structure or function present for more than 3 months with the implications for health. Now, chronic kidney disease in India. We have seen because of the challenges that in access to the patient for the care, it has been seen that more than 15% of the patients with advanced CKD are first seen when their estimated GFR is less than 15 ml per minute per 1.73 meters square. Now, what are the causes of chronic renal failure in patients? The most common cause that we have seen in India is diabetic nephropathy, followed by chronic glomerulonephritis, hypertensive nephrosclerosis, IgA nephropathy, chronic pyelonephritis, obstructive uropathy, and connective tissue disorders that includes SLE. So, what are the criteria for CKD? If either of the following is present in the patient for more than 3 months, it is divided into 2 types. First, we'll discuss about the markers of the kidney damage, and after that, we'll discuss decreased GFR. So in the markers of the kidney damage, if we have seen that if the albuminuria is more than 30 milligram per day, there is any urine sediment abnormalities, that is maturia, red cell cast cells, any electrolyte imbalance due to the tubular disorders, abnormalities detected by the histology, structural abnormalities that is seen during imaging, or any history of kidney transplantation in the patient. So in case of decreased GFR, we have seen that the GFR is less than 60 ml per minute per 1.73 meters square. Now, this is the different classifications regarding the acute kidney injury. So here this is divided into 3 stages. Here we'll discuss about the rifle classification, the Aiken classification, which is a modified form of rifle classification, and finally the Kiddgo classification. In the rifle classification, we have seen that in the state when the serum creatinine level is more than 1.5 times, the creatinine is increased more than 1.5 times, and the GFR is decreased by more than 25%. Here, the urine output is less than 0.5 ml per kg per hour, that is for more than 6 hours. In the stage 2, we have seen that the serum creatinine increased to 2 times and the estimated GFR decreases by more than 50%, whereas the urine output remains less than 0.5 ml per kg per hour for more than 12 hours. Where in the stage 3, we have seen that the serum creatinine increased by more than 3 times and the GFR is decreased to more than 75%. And the patient has almost less than 0.3 ml per kg per hour of urine output for more than 24 hours. In the Aiken classification, in the stage 1, we have also seen that the serum creatinine increased by more than 1.5 to 2 times within 48 hours or within 7 days, and the urine output here is less than 0.5 ml per kg per hour for more than 6 hours. Whereas the serum creatinine level in the stage 2, it increases by 2 to 3 times, and the urine output here remains less than 0.5 ml per kg per hour. And in the stage 3, the serum creatinine increases by 3 times, or the patient may need for renal replacement therapy. Here, the urine output remains 0.3 ml per kg per hour for more than 24 hours. And the Kiddgo classification, we have seen that during the stage when the serum creatinine increased for more than increased by 1.5 times to 1.9 times within 7 days. And in the stage 2, we have seen that the serum creatinine increased by 2 to 2.5 times. And in the stage 3, we have seen that the serum creatinine increased by 3 times, or the patient needs for renal replacement therapy. Here, the urine output in the stage 1 remains less than 0.5 ml per kg per hour for more than 6 hours. In the stage 2, it remains for 0.5 ml per kg per hour for more than 12 hours. In the stage 3, it remains for less than 0.3 ml per kg per hour for more than 24 hours, or we can say that the patient is having anuria for more than 12 hours. Now we'll discuss about the stages of the CKD. It is based on the glomerular filtration rate. In the stage 1, it is more than 90 ml per minute per 1.73 meters square, that is normal or high. In the stage 2, it is between 60 to 89 ml per minute per 1.73 meters square, that is mildly decreased. In stage 3, it is 45 to 59, that we consider mildly to moderately decreased. In stage 3, it is 30 to 44, which is moderately to severely decreased. In stage 4, it is 15 to 29, that is severely decreased. And in stage 5, it is less than 15 ml per minute per 1.73 meters square, that we consider it as a state of kidney failure. Now, the albuminuria categories in the patient with CKD has been divided into 3 types. Here it is divided on the basis of albumin excretion rate and the ACR ratio, which is albumin to creatinine ratio. In the A1, we have seen that the albumin AER is less than 30 milligram per day, and the ACR is less than 30 milligram per gram of creatinine. In the A2 criteria, we have seen that the AER is between 30 to 300, and the ACR is also between 30 to 300, which is moderately increased. And in the third A3, we have seen that the AER is more than 300, and the ACR is also more than 300, which is severely increased. Now, what is the clinical manifestation that we see in the patients with CKD? These patients undergo various changes like fluid and electrolyte imbalance, hematological changes, cardiovascular abnormalities, central nervous system abnormalities, respiratory system abnormalities, and gastrointestinal system abnormalities. So in the further slides, we'll discuss about every system. Now, in the cardiovascular system, due to the increase in the sodium water retention and altered renin-angiotensin secretion, these patients are more prone to hypertension. These patients are further due to more prone to chronic heart failure, which is due to the primary cause here is uremic cardiomyopathy, and the secondary is fluid overload. Due to the increase in the triglyceride production and decrease in the triglyceride excretion and decrease in the apoprotein secretion, these patients are more prone to accelerated atherosclerosis. Due to the increase in the urea production, these patients are more prone to uremic pericarditis, followed by cardiac tamponade. These patients, due to the metabolic acidosis and the electrolyte abnormalities, these patients are more prone to hyperkalemia and also hypoglycemia. Now we'll discuss about the hypertension. As we have discussed previously, due to the increase in the plasma volume from sodium and water retention, it has been seen that in 86% of the patients which are suffering from CKD, as compared to the 29% of the general population. So also due to the progressive atrial stiffness, it lead to hypertension, and due to the activation of RAS and sympathetic system, it further progress to hypertension. So which finally leads to the progression of CKD and CVS complications in these patients. Now, what is the BP criteria that we have to maintain in these patients? In the diabetics and in the non-diabetics, it has been divided according to the ACR categories. So we have seen that during the A1 category, we have to keep the systolic BP between less than equal to 40 to 90 millimeters of mercury. Whereas in the A2 and A3 category, we have to keep it between 130 to 180 millimeters of mercury. So in the non-diabetics, the criteria are also similar. In the A1 category, we can keep the BP equal to 140 by 90 millimeters of mercury. And in the A2 and A3 category, we have to keep it less than equal to 130 by 80 millimeters of mercury. Now, what are the changes, hematological changes that we've seen in a patient suffering from chronic renal failure? We have seen that these patients have anemia, which is approximately between 9 to 8 gram per DL, is seen in most of the patient. The reason behind this decrease in the erythropoietin production, GI blood losses, hemodilution, bone marrow suppression. These patients are more prone to platelet dysfunction, that is due to increased bleeding time. So what we have to, while giving regional anesthesia to these patients, we have to consider a proper blood profile, a proper platelet coagulation profile investigation has to be done before taking up these patients. These patients are more prone to leukocytic dysfunctions. So these patients are more prone to increased susceptibility for infections. So due to the increase in the plasma volume, these patients are more prone to interstitial edema, followed by alveolar edema, pleural effusion. And as we'll discuss in the further slides, the patients suffering from chronic renal failure are more prone to metabolic acidosis, which further lead to hyperventilation in these patients to overcome the metabolic acidosis. So what the patient does, it will increase the minute ventilation. The patient will start, it will present as tachypnea. We can see the patient is, the respiratory rates have increased in these patients even in the resting states also. Now we'll discuss about the neurological complications that we see in these patients. These patients are more prone to peripheral neuropathy and autonomic neuropathy. We have seen that these patients have delayed gastric emptying, postural hypotension, silent myocardial ischemia. And if the patient has undergone dialysis, it can present with dialysis dementia or dialysis disequilibrium syndrome. So for the endocrine abnormalities, we have seen that due to the peripheral insulin resistance, these patients are more prone to glucose intolerance. Secondly, hyperparathyroidism is also seen due to the increase in the phosphate production, which further leads to metabolic bony diseases and osteopenic bony problems. Due to the increase in the triglyceride productions, these patients have accelerated atherosclerosis also. Now, in the gastrointestinal system, we have seen that these patients are more prone to nausea, vomiting, anorexia due to the malnutrition, dietary imbalances. Delayed gastric emptying is seen. Hyperacidity is seen. For that, we can give PPIs. Mucosal ulceration is seen, and hemorrhagic adenine ileus is also seen in these patients. Now, due to the decrease in the ammonia excretion and decrease in the bicarbonate production, these patients are more prone to metabolic acidosis. So we have to avoid, a proper evaluation should be done before taking the patient to look out for the metabolic acidosis. These patients are more prone to sodium balance because of the increase use of diuretics to maintain the cardiac function. These patients have also calcium and phosphate derangements. Now we'll discuss about hyperkalemia. It is seen in patients with chronic renal failure. Why it is seen? Because in the patients with CKD, there is decreased excretion of potassium. So what is hyperkalemia is if the potassium levels are increased more than 5.5 milligram per DL. So what are the changes that we see in the ECG of a patient when the potassium level rises? So when it is divided into three stages, mild, moderate, and severe. In the mild, the potassium levels is between 5.5 to 6.5 milligram per liter. And here the changes that we see in the ECG is peak T waves, followed by prolonged PR interval. In the moderate, when the potassium levels are between 6.5 to 8 milligram per liter, what we see in the ECG, there is a loss of P wave, prolonged QRS complexes, ST segment elevation, and ectopic beat escape rhythms. in the severe case where the potassium levels are more than 8 milligranule per liter. So what we see in the ECG is progressive widening of the QRS complexes, sine wave patterns. Patient can go into ventricular fibrillation, asystole, axis deviation, bundle branch blocks, and fascicular blocks. Now, what is the treatment of hyperkalemia? So we can divide into three. What is our goal during if a patient land into hyperkalemia? We have to antagonize the cardiac effects. For that, we can give 5% of calcium gluconate, 10 ml over 3 minutes, and we can repeat it after 5 minutes. So we can also use calcium chloride for circulatory shocks. The effects last for 30 to 60 minutes. We are using this only to stabilize the cardiac membrane. So for the transcellular shift of potassium, we can use 10 units as IV bolus plus 50 grams of dextrose as 50 ml IV bolus. For that, we have to check the blood sugar of the patient also. So here the peak effects lands between 30 to 60 minutes. Now for in chronic patients with CKD, we can use potassium regimals also, that is K-Lite. We can give it orally as well as parectally. For orally, we can give 30 grams in 20% sorbitol, approximately about 50 ml. And parectally, we can give 50 gram in 20% sorbitol, that is 200 ml. So the thing here is we cannot use it in acute treatment because it has a very chronic effect, it's slow acting. It takes, the onset is 2 hours and then it will go, the peak will reach in 6 hours. So the risk here is there is a small risk of bowel necrosis here if we use this K binders, potassium binders. So now we'll discuss about hypocalcemia and hyperphosphatemia. So due to the decrease in the potassium excretion, phosphate excretion, what is seen that there is a calcium phosphate deposition happens in the soft tissue in hearts and kidneys, which further progresses the disease. Phosphate, on the other hand, also binds with the plasma calcium, lead to the decreased bony deposition as well as the uremic bony disease. Further, it leads to the decreased vitamin D production, decreased absorption of calcium from the gut, which further triggers the PTH levels. So it can lead to secondary parathyroid harmonism and further bony problems. The increased absorption of calcium from the bones to increase the serum calcium levels. So how we'll manage hyperphosphatemia in a patient suffering from kidney disease? We can decrease phosphate dietary phosphate. So the high phosphate limit intake foods like dairy, nuts, it has to be taken in limited amounts. So after that, we can also give phosphate binders, which are calcium based as well as non-calcium based. The calcium based are calcium acetate and the non-calcium based is Selvimab. So in case of severe cases, we can also do dialysis. Vitamin D analogs can be given, that is calcitriol, due to suppress the PTH, which we have already discussed in the previous slides. It can lead to secondary hyperparathyroidism. We can also use calcium intake cincillate to use in dialysis patient to reduce the PTH levels. A proper monitoring of serum potassium levels should be done to further manage the hyperphosphatemia. Now, as we have discussed that there is a decrease in the ammonia excretion in these patients and a decrease in the bicarbonate production, which lead to the metabolic acidosis in these patients. So the metabolic acidosis is a very common complication that we have seen in CKD patients, and it presents in more than 30 to 35% of the patient, where the estimated GFR is less than 30 mL per minute per 1.73 meters square. So the acidosis can be further compensated by moderate chronic renal failure patient, and the patient become acidemic and land into hyperkalemia in the post-op period. So this is these things we have to take into consideration while taking up a patient for any surgery. Now, what is the indication of dialysis in these patients? First is the worsening clinical state, that is the overhydrated state, chronic heart failure, increase in hypertension, neurological abnormalities like urinary encephalopathy, pericarditis, and the biochemical things that we have to take into consideration, rising trend of serum potassium, that is 0.5 milligram per day, increase in the serum creatinine level, that is 1 milligram percent per day, increase in the blood urea nitrogen, that is more than 20 milligram percentage per day. So about the dialysis. So if we have to take up a patient for dialysis, the adequacy of the dialysis should be maintained. We have to create a AV fistula. After that, the dialysis should be done at least 12 to 24 hours prior to the surgery. We can use heparin, and these days heparin-free dialysis is also done. If heparin is used, we have to at least wait for 4 hours. The ultrafiltrate is removed. After the removal of the ultrafiltrate, the dry weight of the patient is also taken into consideration. Post dialysis, we have to do all the serum electrolytes, all the CBCs, all the PTILR coagulation profiles should be done. And in these patients, especially which have undergone dialysis, we have to taken care of these problems like coagulopathies, anemia, dyselectrolytemia, as well as the disequilibrium syndrome, dialysis dementia syndrome that is seen in some patients. So we have to take these things into consideration also. Now, this is a slide showing the summary that we already discussed in the previous slides, what happens in a patient with CKD. So it affects all the organ system of the body, which further causes anemia, accumulation of uremic toxins, sympathetic overactivity and RAS activation, inflammation and increased oxidative stress, shared CKD, CVD risk factors, hemostatic abnormality, altered bone mineral metabolism, and sodium and volume overload. So these are the various outcomes that we have, the cardiac outcome that is seen in patients suffering from CKD, which is coronary artery disease, stroke, heart failure, venous thromboembolism, sudden cardiac death, atrial fibrillation, abnormal aortic aneurysm, and peripheral artery disease. Now we'll discuss about PCNL. PCNL, this is a minimally invasive technique, involves extracting renal stones through a very small skin incision that is typically around 1 centimeter in size. So what we do here is it is especially effective for removing very large stone, particularly those that are located near the renal pelvis. So what we do in this PCNL procedure is we will be gaining the percutaneous access to the kidneys and the collecting system from where the stones are disintegrated, usually with ultrasonic or pneumatic lithotripsers. Now, what we do in this procedure, actually, a hollow needle is placed in the collecting system through a fluoroscopy guided procedure. A guide wire is inserted, followed by dilators are passed. After track dilatation, a working sheath is left in place. Nephroscope is inserted to visualize the stone. After the stones are visualized under direct vision, large stones are fragmented by ultrasonic or electrohydraulic probes. And after that, the stones are extracted and a further nephrostomy tube is left to drain the system.
I think if we are running late, then we can
Now,
just,
what is the anesthetic techniques that we follow in this patient? PCNL can be performed in a general regional anesthesia. The positioning that is in the
just one
patient with
second.
PCNL is prone or lateral oblique position.
Can you hear me, Dr. Shivpriya?
So if we do this under regional anesthesia, what are the indications here? If the patient is unfit for general anesthesia or it is a patient preference. So for that case, a proper detailed history coagulation profile should be taken into consideration. In the regional anesthesia technique, we can be using a combined spinal or spinal epidural. So
I'm saying if we are running late on time, we can just talk about things which are, we've missed out,
Okay.
Because we are running overshooting the time, then we can just.
Yes, ma'am. So what is the
कुछ रह गया है उसको बता दो, है ना?
Okay. So the choice of anesthesia here is general balanced anesthesia with endotracheal tube in situ and mechanical ventilation. So these are our anesthetic goals that we face. We have to follow in these patients. As we know, our patient is a known case of CKD, so we have to avoid nephrotoxic drugs. The induction agent choice here is etomidate, followed by we can use fentanyl. For muscle relaxant, we can use atracurium, and the inhale agent we will use isoflurane or desflurane. So this is the diagrammatic representation of prone position. We have to take in, during prone position, we will consider that all the bony prominences are covered. The abdomen should be free. The neck, there is a minimal flexion of the neck, and all the soft tissue should be properly covered. So during prone position, as we have already discussed, the patients are more prone to oculofacial injuries, and from the surgery point of view, these patients are more prone to lung and pleura injury due to the high superior punctures. So what are the things that we have to take into consideration in these patients is, these patients are more for maintaining, we have to monitor the airway pressures, ApCO2 and SpO2 in these patients. And in the post-op period, these patients are more prone to blood loss, hemodilution, and hypothermia due to the increase in the irrigation, a large amount of fluid. So for that, we can prevent it by using warm beer huggers and warm intravenous fluid irrigation. So in the post-op period, the analgesia is maintained by non-opioid, that is paracetamol. Anesthetics are avoided in these patients because as we know, our patient is a known case of CKD. For regional anesthesia, we can give paravertebral blocks, stab blocks, ESP blocks, as well as this chordatus lumborum block. For local anesthesia infiltration, we can give bupivacaine, and for adjuvants, we can use gabapentin and low-dose ketamine. So, ma'am, this is I will be compiling by this. Thank you.
Okay. I think thank you, Dr. Anuruti. I think she has really beautifully compiled the whole session, covering all the important points. And I think that one point that I missed is also now covered, that in the nephrotoxic drugs, the antibiotics, that is your aminoglycosides and amphotericin should be avoided, and also NSAIDs are not the choice of analgesia in this group of patients. And I would just like to summarize and conclude that, see, these patients are very fragile. Most of them, especially the ones who come in CKD 4 and 5. And they do not give you too much of a window when they are at the best state for surgery. So, catching them in that right window period when they are best optimized, we will never always give them, in the best state that we want them to be. But optimizing them and getting them to the best near normal condition that we can get them, and taking them up for surgery is what we should do. And the aim has to be to maintain a good hemodynamics so that the renal perfusion is not compromised further. And we are able to, the other thing is obviously, this bony injury. They are always prone for skin necrosis, some kind of an ulcer, because the skin also becomes quite, prone to tear and all that. So taking care of the skin, the bony prominences, the nerves is extremely important in these patients. Okay. If
Yes,
we
ma'am.
have any questions, we can take them. Otherwise, okay.
So there is one question in the chat box, ma'am. Which one is better, desflurane or isoflurane? I think we have covered during the discussion, but
Yeah.
still, if you want to.
Yeah, you can use whatever is available with you. Both both inhalational agents are equally can be used in patients with CKD.
So that's all, ma'am. Only one question was there. So thank you so much, Dr. Sangeeta, for such a clinically relevant and well-structured case discussion. Your practical insights added a tremendous value, true learning experience for all of us. And I'm sure students must have benefited from this. Thank you so much, ma'am, for we are grateful for your time, your efforts, and the wisdom you shared.
Yeah.
Thank you, Dr. Anuruti, for well summarizing the case. And thank you, Dr. Shikha, for very well presenting the case.
Yeah,
Thank you, ma'am.
Yeah, I think Dr. Shikha and Dr. Anuruti have really worked hard, and they did a good job out of it, and made my job also a bit easier. Thank you so much. Thank you for making me a part.
So now we move on to a quick, short, and crisp quiz session. So we will be displaying a couple of questions. So students, get geared to answer those questions. Can we have display? The quiz questions. So first question is, what are the functions of the hanger yoke assembly? A, orienting and supporting the cylinder. B, providing a gas tight seal. C, ensuring a unidirectional gas flow into the anesthesia machine. And D, all of the above. Second question is, which of the following is not tested for certification of brain death? Oculocephalic reflex, oculovestibular reflex, oculocardiac reflex, and gag reflex. So you will get 60 seconds to answer these questions. So answers to our question is, can we have the first question? Can we have our first question on the display? So answer to the first question answer is D, all of the above functions of the hanger yoke assembly, orienting and supporting the cylinder, providing a gas tight seal and ensuring a unidirectional gas flow into the anesthesia machine. Question number 2. So answer which of the following is not tested? Answer will be oculo cardiac reflex. Others we test for certification of brain death. Now we move on to our next session. For that session, I would like to invite our chairperson, Dr. Sujata Chaudhary. Can we have her CV on the display? So Dr. Sujata Chaudhary, she's additional DGHS, Directorate MOH FW, Ministry, Nirman Bhavan. Her achievement, she's ex-HOD in Safdarjung Hospital and she is faculty at UCMS and GTB Hospital. She was past Vice President of Delhi branch of ISA and she has 30 years of teaching experience and examiner for MD, DNB and DA. Her areas of interest are airway, obstetric, pediatric anesthesia, teaching and training simulation. I welcome you, ma'am, and I hand over the session to you.
Thank you, Shivpriya. Thank you very much. I thank team RML for inviting me for this because
It's our pleasure, ma'am. It's our pleasure.
And this time I have not been asked to discuss a case, but we have a very good person who will be discussing, Dr. Nidhi Bhatia, who is a very experienced clinician and anesthesiologist. Dr. Nidhi Bhatia is a professor at PGIMR Chandigarh, and she has written 20 chapters in books and has 95 publications in various international and national journals. And she is the founder member of Treasurer of Society of Trauma, Anesthesia and Critical Care. Also AOA National Executive Committee member and Special Section Editor for JOACP. She is the Chief Editor of book on acute trauma care and in developing countries, and has won various best paper awards at national and international level. She is a certified AHA, BLS, ACLS, ATLS instructor and NELS master trainer. She has her areas of interest are trauma, obstetric anesthesia, ultrasound guided regional anesthesia, and airway management and resuscitation. So we are going to discuss a very important case. Now, this case, all the postgraduates may not have seen such the correction of kyphoscoliosis as such, but kyphoscoliosis can present in your clinical practice, like a patient with kyphoscoliosis can present to you for cesarean section. And there also you have to keep in mind what are the areas or what are the concerns in such a patient such patient who presents to you for anesthesia. And it is besides the for other surgeries, as I said, the patient can present you can see like in emergency times, you can see this in as for cesarean, and otherwise some of these patients can also present to you for correction of kyphoscoliosis, and which is like patients can present for many like repeat surgery also. So case is otherwise very important from in the clinical practice also, and from the exam point of view, because they can also get a theory question on this particular subject. So Dr. Nidhi Bhatia, I welcome you, and she will be discussing anesthetic consideration in a patient of kyphoscoliosis.
Thank you,
Welcome.
ma'am. Thank you. Very good morning to all of you. So I'll be talking about the anesthetic considerations in patients of kyphoscoliosis. Now we all know that curves are a normal part of the spine's structure of anyone's body. These curves, they serve to distribute the mechanical stress which are incurred during rest and movement. And the normally the spine, it curves anteriorly in the cervical and the lumbar region, which forms the cervical and the lumbar lordosis. And there is a natural posterior curvature to the spine in the thoracic and the sacral region, forming the thoracic and the sacral kyphosis. Now, what is kyphoscoliosis? Kyphoscoliosis describes an abnormal curvature of the spine in both the coronal and the sagittal plane. By kyphosis, we mean there is an increase in the posterior curvature of the spine, which is seen along the sagittal plane. Kyphosis can occur because of postural changes. It can be in the form of a juvenile osteochondrosis of the spine. It could be congenital. It could be because of vitamin D deficiency or post-tuberculosis or post-traumatic. What is scoliosis? Scoliosis is the lateral rotation of the spine to more than 10 degrees, which is accompanied by vertebral rotation. Scoliosis, it affects approximately 2 to 3% of the population, with curves more than 10 degrees seen in approximately 1.5 to 3% of the population, more than 20 degrees, 0.3 to 0.5%, and more than 30 degrees scoliotic curves seen in 0.2 to 0.3% of the patients. Most commonly, these curves are convex to the right, and the scoliosis that requires surgical correction is more common in women. Now, this ratio, it increases with the severity of the curve, with the ratio of girls to boys at 2 to 1 for curves of 10 degrees, and this ratio increases to 10:1 for curves over 30 degrees. So, curves which are more severe, having a more severe form of scoliosis, are more common in girls as compared to boys. Now, how do you classify the scoliotic curves? It is very important that we know about the classification. These curves are normally classified into either structural or non-structural. Now, what is the difference between the two? First, what is non-structural curve? Non-structural curve is also known as functional scoliosis. Now, this is a two-dimensional condition in which the curve is flexible and the vertebrae, they are not rotated. And this curve changes or disappears with positional changes or correction of the underlying problem. So the functional curves are seen whenever there are leg length differences, or there is a pelvic tilt, or muscle spasms, or postural issues. On the other hand, structural scoliosis is of more significance to us because this is a three-dimensional condition involving the abnormal curves in the coronal plane associated with vertebral rotation in the axial plane, and it often changes in the sagittal plane. That is, there is also a front to back curve. Now, because there is vertebral rotation also involved in the structural scoliosis, there may be rib cage deformities, which affects the underlying lung functions, and this type of structural scoliosis lacks normal flexibility and does not correct with bending or lying supine. And so it is these type of structural scoliosis which need surgical correction. Now, this is a screening tool which can be used to detect scoliosis and differentiate between structural and functional scoliosis. This is the Adams forward bend test, in which the patient is asked to stand erect with feet together and knees fully extended, palms touching each other. Then the patient is asked to bend forwards until the back is horizontal. If there is asymmetry of the thoracic or the lumbar spine, which can be detected with the help of a scoliometer, it tells you that the Adams test is positive for the presence of structural scoliosis. And a positive test is also indicated by a rib hump. There can be uneven shoulders or hips, like I said, or the head which is not aligned with the pelvis or the rib hump. Now, since it is the structural scoliosis which would come to us for corrective surgeries, it is important that we further know what are the types of structural scoliosis which may be encountered. This may be idiopathic, which is the commonest type. There may be structural scoliosis, may be neuromuscular, congenital, or it could be because of miscellaneous conditions like neurofibromatosis, mesenchymal disorders, or trauma. Now, idiopathic is seen in 70% of the cases, and it is further, depending upon the age at which it occurs, of three types. Infantile is seen from birth to 3 years of age, juvenile from 4 years to 10 years of age, and adolescent forms are seen beyond 10 years of age. Males are more likely to have infantile or juvenile scoliosis, whereas adolescent scoliosis is more commonly seen in females. And the cause is multifactorial, including there could be abnormalities of collagen, brainstem function, hormones, and growth. Neuromuscular scoliosis occurs because of diseases like cerebral palsy, muscular dystrophies, poliomyelitis, etc., and is associated with significantly increased intraoperative blood loss compared to idiopathic scoliosis. Congenital scoliosis occurs because of congenital anomalies such as hemivertebrae and fused vertebrae or ribs. Now, why is it important for us to know the type of scoliosis? How does it impact us? First, the structural scoliosis is the one which would often require surgical correction. The functional scoliosis does not more often require surgical correction of the spine. The neuromuscular scoliosis, like I said, is associated with significantly increased intraoperative blood loss and a more profound decrease in pulmonary function for any given curve severity. Congenital scoliosis, if present, you have to be wary that it may be associated with other anomalies that may have a major impact on the anesthetic plan. So what are the signs and symptoms of scoliosis? Now, a spine which is affected by scoliosis, it curves to one side, either the right or the left. And because of this curvature, one or both the shoulder blades, they may protrude. The waist may appear uneven with the hips elevated. There may be misshaped rib cage. Then in the back, you can often see a curvature. They can be leg length discrepancy and abnormal gait. Now, how do you assess for the severity of scoliosis? What is the objective method of assessing the severity? The most common measure is by measuring the corpse angle. This is measured in the AP radiograph of in the AP plane radiographs. So how do you measure the corpse angle? For this, you first need to understand three important terms. One is the apex, the end vertebrae, and the neutral vertebrae. Now, the apex, whenever there is a scoliosis, there is a curvature to one side. So what is the apex? Apex is the vertebral body which demonstrates the greatest rotation or furthest deviation from the expected center. So the area where you have the greatest deviation from the center, that point corresponds to the apex. The end vertebra are present on either side of the apex and are the vertebra that are the most tilted towards each other. So the upper and the lower vertebra, which are the most tilted in this curvature, form the end vertebra. And they are important because it is the end vertebra which is used for measuring the corpse angle. The neutral vertebra are present on either side of the apex and are vertebra that demonstrate no rotation. So more often than not, this neutral vertebra would be further away from the end vertebra. So beyond the end vertebra, the vertebra which show normal, which demonstrate no rotation, are the neutral vertebra. So how do you calculate the corpse angle? One is you identify the end vertebra, the upper and the lower one. So you a line is drawn from the bottom of the lowest vertebra, whose bottom tilts towards the concavity of the curve, and from the upper part of the topmost vertebra, which is the most tilted. So you draw these two lines, and from these two lines, perpendiculars are drawn from each of these two lines, and the angle at which these perpendiculars intersect will form your corpse angle. So how is the corpse angle important or relevant? Now, greater the corpse angle, more profound the disturbance in pulmonary function. Surgical treatment is usually recommended for curves which are more than 45 to 50 degrees. And curves more than 60 degrees are usually associated with decreased pulmonary function, with the FEV1 and FVC decreasing with increased thoracic curve severity. So more severe the curve, more the problems associated with the pulmonary functions, and also, these are the curves which would require surgical correction. It is important to remember that scoliosis severity and impairment of pulmonary function, it increases with the greater the number of vertebrae involved, more cephalic the location of the curve, the loss of normal thoracic kyphosis, and long-standing severe curves can be associated with permanent damage to the lung parenchyma, respiratory failure, and cor pulmonale. Now, there are a number of surgical options that are available depending upon the nature and the severity of the scoliosis, varying from just the posterior correction and instrumentation or the anterior correction, or a combined procedure involving both the posterior as well as the anterior instrumentation. Now, what are the anesthetic challenges when these patients come to us? First and foremost, it is important for us to know that the systems which may be involved in patients having scoliosis. Now, respiratory system is commonly involved in patients with thoracic scoliosis, and these patients tend to have a restrictive pattern with a decrease in lung volumes. The greatest reduction is seen in the vital capacity, which is reduced to almost 60 to 80% of the predicted. The total lung capacity, functional residual capacity, inspiratory capacity, and expiratory reserve volume are also decreased. The FEV1 to FVC ratio remains normal. During exercise, the ventilation is adequate, but there is a marked decrease in tidal volume, increase in respiratory rate, and the maximum work capacity decreases. The PFTs are deranged due to abnormal thoracic geometry, leading to a marked decrease in chest wall compliance. In addition, what are the arterial blood gas abnormalities that are seen? There is arterial oxygen desaturation, which is more with the increased severity of the curve. Arterial hypoxemia is mainly due to ventilation perfusion mismatch. There is decrease in the diffusing capacity and the alveolar hypoventilation. Both of these contribute. Then severe long-standing scoliosis is associated with marked ventilation perfusion mismatch, alveolar hypoventilation, and CO2 retention. So if not surgically treated, it may lead to respiratory failure. The slope of the ventilatory response to carbon dioxide may also be decreased in patients with scoliosis. And despite normal pulmonary function testing at rest, during maximal exercise, patients with mild to moderate scoliosis may exhibit a significantly decreased ventilatory capacity and reduced exercise tolerance. How is the cardiovascular system affected? Now, it is important to keep in mind that 60% of the deaths in patients with scoliosis, more so severe scoliosis, is either due to respiratory failure or right-sided heart failure. Now, right ventricular failure is commonly due to right ventricular hypertrophy following elevated pulmonary vascular resistance and pulmonary hypertension. Now, why is this pulmonary vascular resistance increased? It is because of hypoxemia, which leads to pulmonary vasoconstriction and increase in pulmonary vascular resistance with increase in PA pressures. In addition, chronic hypoxemia may lead to irreversible increases in pulmonary pressures, leading to pulmonary arterial hypertension. Further, the chest wall deformity, which happens along with scoliosis, compresses the lung regions, increasing vascular resistance. And scoliosis, if it occurs in the first 6 years of life, it results in impaired growth of pulmonary vascular bed because of chest wall deformity. In addition, you need to keep in mind the associated conditions that may be present with scoliosis, which in turn have cardiovascular abnormalities, of which mitral valve prolapse is the most common. Patients may have congenital heart disease, and associated conditions like Marfan syndrome or the muscular dystrophies that are present may have cardiovascular abnormalities. So how do you preoperatively evaluate and prepare these patients? First and foremost, the history is very important. It is important to know at what age did the scoliosis start. This is important because the lung, it continues to grow and develop from birth till 8 years of age, and the alveoli also increase up to 4 years of age. So development of any significant thoracic scoliosis during this phase of rapid growth significantly impairs your lung development. Then you need, in addition to the age, you need to assess the patient's cardiopulmonary function, the patient's exercise tolerance, because it is the cardiac and the respiratory system which are the most involved. So you have to look out for the pulmonary and cardiovascular symptoms. In addition to the general physical examination, it is important to do a detailed cardiovascular and respiratory system evaluation. In addition to that, neurological evaluation is mandatory, as patients with pre-existing neurological deficits are at increased risk for developing spinal cord injury during scoliosis surgery. It is also important to document your pre-op neurological function in order to avoid confusion about post-operative neurological complications. Now, it is important to know the scoliotic curve characteristics. First and foremost, it is important when you are doing the examination of the patient to know the location of the scoliotic curve, because thoracic scoliosis is associated with pulmonary functional abnormalities. Cervical scoliosis may be associated with difficulties in airway management. Severity of the scoliosis is important to know, because curves more than 60 degrees, thoracic curves more than 60 degrees produce significant decrease in pulmonary function, and curves more than 100 degrees are associated with significant impairment in gas exchange. Then important to know the direction in which the scoliotic curve is there, because if it's a left thoracic convexity, then you have to keep a high index of suspicion for underlying conditions and congenital anomalies. Fourth, is important to know the etiology. Underlying conditions such as muscular dystrophy or cerebral palsy will influence anesthetic management. So what are the pre-op investigations that you need in these patients? You need all your routine investigations, routine biochemistry, chest X-ray, ECG because of the cardiovascular involvement. Echocardiography is mandatory, especially if you have severe scoliosis. If the history physical examination suggests decreased pulmonary reserve, then standard pulmonary function testing, including blood gas analysis, spirometry, should be considered. Now, when we decide upon the anesthetic management of the patient, it is important to keep in mind our perioperative concern, of which first and foremost is the intraoperative blood loss. These surgeries are complex and they are prolonged surgeries. So, and depending upon the degree of scoliosis, at times the blood loss may be significant. So the blood loss mainly depends upon the procedure, the operative type, the number of segments that are fused, the degree of Cobb's angle, and the need for osteotomies. So if more than 6 segments are fused and the degree of Cobb's angle is more than 50, they may be associated with increased blood loss to the tune of 15 to 25 ml per kg. Extensive procedures like combined anterior-posterior spine fusions, instrumentations into the pelvis may be associated with blood loss to the tune of 75 ml per kg. There are various techniques which we can follow to reduce this blood loss. One is these patients are placed in prone position. You have to do careful positioning and minimize intra-abdominal pressures. Then antifibrinolytic drugs like tranexamic acid can be used. At times, the surgeons may request you to give hypotensive anesthesia. However, whenever you're embarking upon giving hypotensive anesthesia, it is important to keep in mind that this may also compromise spinal cord blood flow after spine distraction and may interfere with neuromonitoring signals, particularly MEPS. So the other things that can be done is, where facilities are available, isovolemic hemodilution and autologous blood donation. The second important concern is the prone positioning, because prone positioning is associated with a number of problems, including the problems with the airway management, the endotracheal tube getting kinked or dislodged. Then the position of the neck may be hyperextended, hyperflexed. Abdominal pressures need to be kept in mind. There may be injuries to the nerves, to the vessels. So all these things need to be kept in mind. The arms should be abducted to less than 90 degrees. Pressure points should be adequately padded. There should be a soft head pillow, taking care not to exert pressure on the eyes. Then the chest and the abdomen should be supported away from the bed, and the abdominal pressures need to be kept under control. Another important thing is you should minimize pooling of blood in the peripheries. So where possible, every effort should be made to minimize this pooling. Then the neurological injuries are our other concern. It could be because of direct injury due to the instrumentation that is happening. It could be because of spinal cord distraction, intraoperative hypotension, or it could be because of blood loss. Then spinal cord monitoring has to be done in these cases. You have to keep in mind, especially in prolonged surgeries, the third space losses, hypothermia, at times lung isolation may be needed depending upon the level of surgery, and there is always a risk of venous air embolism. So what monitoring is required and what lines are needed? You often require 2 widebore intravenous lines. Standard ASM monitoring is mandatory, which includes your ECG, NIBP, SpO2, end-tidal CO2, and airway pressures need to be monitored. In addition, invasive blood pressure lines are mandatory, especially where you are planning hypotensive anesthesia. Then neuromuscular monitoring and BIS monitoring should be done. Urine output and temperature should be monitored. And you need to take care while positioning the patient and take care not to always keep the patient warm and prevent hypothermia. Now, important in these patients is spinal cord monitoring. At times, the surgeons, especially when a lot of instrumentation is involved in severe scoliosis, spinal cord monitoring becomes mandatory. So, wake-up test was the gold standard, which was done initially, but now it has been replaced by motor evoked potentials. Then, now commonly done is the somatosensory evoked potential, which evaluates the posterior portion of the cord, and the motor evoked potential, which checks for the integrity of the interior portion of the spinal cord or the motor spinal cord. Now, intraoperative wake-up test may still be required if your somatosensory evoked potential and motor evoked potentials become abnormal during the surgical procedure. So how do we go do and interpret these tests? Now, somatosensory evoked potential, it mainly checks for the dorsal column. Whenever a peripheral nerve is stimulated, basically this sensory stimulus, it goes through the dorsal ganglion and the dorsal column to the somatosensory cortex. So for somatosensory evoked potential, repeated electrical stimuli are applied to a peripheral nerve, most commonly the posterior tibial nerve, and the evoked response is measured over the cerebral cortex and subcortical regions using standard electroencephalograms scalp electrodes. So normally the typical SSP trace appears like this. There is a latent period. The latent period signifies the time from where the impulse is generated, from where you trigger the peripheral nerve to where you get a impulse or a trace. So this latency, it determines your conduction velocity of the nerve, and the amplitude, normal amplitude of the SSP trace is 1 to 3 MV, and this amplitude mainly determines the function of the nerve fibers. So latency determines the conduction, amplitude determines the function. Now, how do you come to know that there has been a surgical injury or ischemia to the cord? One, there would be an increase in latency and to the tune of 10 to 15% or more. Or there may be a decrease in the amplitude of greater than 50%, or there may be a complete loss of evoked potential. So if any one or more of these is present, it means there has been an injury or ischemia. Now, motor evoked potential is mainly for checking the anterior motor spinal cord or the corticospinal tract, the integrity of this. Now for this is elicited by transosseous electrical stimulation of the motor cortex. So here the motor cortex is stimulated using scalp electrodes or by stimulation of the anterior columns using epidural electrodes. So once you stimulate the motor cortex, there is conduction of these stimuli through this motor pathways or the corticospinal tract. And how do you monitor this? It is monitored as a peripheral nerve impulse. A peripheral nerve impulse is generated and there are electromyographic signals or there will be limb movements. So you check for these to see the response, and this is how motor evoked potentials are measured. So this is a picture showing how various electrodes are placed on the scalp, on the lower and the upper limbs to check for the somatosensory and the motor evoked potentials. Now, how does our anesthesia affect the somatosensory and motor evoked potentials? All of the inhalational agents, they cause a decrease in amplitude and an increase in latency. Etomidate causes an increase in the amplitude. Ketamine also causes an increase in amplitude. Opioids, propofol and dexmedetomidine, they do not affect the amplitude or the latency. So they have the least effect, the opioids, propofol and dexmedetomidine. In addition, the intermediate duration neuromuscular blockers like rocuronium, vecuronium, these can be used for intubation when baseline neuromonitoring is not needed before positioning. However, it is important to keep in mind that for SSCP monitoring, though there may be no restriction to the neuromuscular blockers that you use, however, if you're planning on doing a motor evoked potential, then the neuromuscular blocking agents should not be used because they hamper the evaluation of the motor pathways. So whenever you administer anesthesia to these patients, it is preferable to administer opioids by continuous infusion rather than by intermittent doses and maintain a stable anesthetic before and during periods of monitoring. So like I mentioned, the opioids, your dexmedetomidine, propofol, these are safe because they do not to a great extent hamper or affect the evoked potentials. The evoked potentials are also affected by a decrease in arterial pressures, hypoxia, hypocarbia, hypothermia, and anemia. So what do you do whenever there is abnormal evoked potential? One is ensure adequate oxygen delivery, ensure good mean arterial pressures and spinal cord perfusion. Hypovolemia and anemia should be corrected. Arterial oxygen tension, PCO2 should be within normal limits. The surgeon should be asked to correct too much distraction or surgical trespass with instrumentation. If the abnormality persists despite your corrective action, then a wake-up test should be considered to determine if the instrumentation should be adjusted or removed. So how do you do a wake-up test? The wake-up test mainly checks for the integrity of the spinal motor pathways. This is performed by lightening the depth of anesthesia sufficiently to allow the patient to follow commands. The patient is first instructed to squeeze the anesthesiologist's hand, confirming that he or she is responsive, and then asked to move his or her feet and toes. If the patient is able to squeeze the hands but unable to move the feet, the amount of spine distraction is reduced until a safe degree of correction is achieved. Now, the complications with the wake-up test is the patients may get accidentally extubated because you lighten the depth of anesthesia. There may be recall of events. There may be myocardial ischemia, self-injury, dislodgement of instrumentation or intravenous accesses, and air embolism. So the anesthetic technique that we embark upon, or the anesthetic technique of choice, and this is a total intravenous anesthesia, because our goal is to provide an anesthetic that is suitable for spinal cord monitoring while providing analgesia and amnesia. So general anesthesia with TIVA and minimal MAC inhalational agents is preferred. So you can combine a low dose potent inhalational agent in 50% oxygen with propofol infusion and opioid-based intravenous anesthetic. Dexmedetomidine can be used as an adjunct in TIVA. Muscle relaxants can be given initially at the time of intubation, but then should be avoided, especially if you are planning on doing somatosensory and motor evoked potentials. And if being used, they should be titrated to a constant train of 4, because the neuromuscular blockade significantly affects the intensity of motor response. Succinylcholine should be avoided in patients with muscle disorders. How do you post-operatively manage these patients? Now, post-operatively, the criteria for extubation is like for any other patient with a vital capacity greater than 10 mL per kg, tidal volume greater than 3 to 6 ml per kg, patient having a spontaneous respiratory rate of less than 30 and a negative inspiratory force greater than 30. Indications for postoperative ventilatory support include patients with severe restrictive lung defects, severe gas exchange abnormalities, including carbon dioxide retention, and patients with muscular dystrophies or severe cerebral palsies. Postoperative care, in addition to your routine general care, it involves aggressive pulmonary toilet, including incentive spirometry. The patients should be monitored in either an ICU or a high dependency unit for the initial 24 to 48 hours. Now, a very important component of post-operative recovery of the patient is providing a very good post-operative analgesia. Multimodal analgesia should generally be provided, which includes your intravenous patient-controlled analgesia, in which intravenous opioids can be given. You can use intrathecal opioids before wound closure. Then regional blocks can also be given. The complications that you need to keep in mind when embarking upon patients coming for scoliotic surgery is: one is wound infection, then pulmonary complications including pneumothorax, atelectasis, pleural effusion, and hemothorax. Neurological injuries can happen, thoracic duct injuries can happen, and there can be ileus. So to conclude, kyphoscoliosis involves various organ systems, and anesthesia is often needed for corrective orthopedic surgery. A detailed pre-anesthetic assessment and optimization of respiratory and cardiovascular systems is important. And our considerations include monitoring, temperature management, fluid balance maintenance, appropriate positioning, maintaining spinal cord integrity by adequate monitoring, and blood conservation. Our postoperative concerns include the intensive care management of these patients, respiratory care, and pain therapy. Thank you.
Thank you, Nidhi, for covering the topic so well. You covered almost all the aspects, and it is very important to understand the cardiac and pulmonary involvement in these patients, which can be there in the pre-operative period itself. And it is of concern to us as anesthesiologists. There may be already a compromise of pulmonary system because of the, especially in the congenital or kyphoscoliosis, where the corrective surgery is to be done.
Yes.
So, Dr. Nidhi has covered the topic very well, and it is important to understand there are very special concerns for this particular surgery. One is the surgery is done in the prone position. The prone position itself has its own set of problems for the anesthesiologist. So, the special care which needs to be taken during prone position is besides taking the care of airway and securing the airway very well to avoid accidental extubation or and other than this, the problems of prone position are like the neurological injuries can occur, pooling of blood. The position of the surgery is such that you need to take care of this thing, and that is why it is important to understand and take care of these things in the intraoperative period. Other than the prone position, the things which you discuss, the blood loss which is there during this procedure, you anticipate a good amount of blood loss. So for this, you need to be prepared. So you need to have blood in hand, and many times you can go for techniques like autologous transfusion in the planned way. In the pre-operative period itself, it can be planned. And other than this, the problems of prone surgery we were discussing, there can be pressure on the eyes, which can lead to post-operative blindness, which is mentioned as one of the complications because of the optic neuropathy which can occur. And the important aspects like what anesthetic agents you need. The main concern which is there is if the surgeon wants to use the test like to check the somatosensory and motor evoked potential. So there are special concerns for this. You need to prepare the patient well in advance in the pre-operative period. You need to inform the patient that a wake-up test will be done, and this is what is expected to know that what all he'll be asked to do. And then when intraoperative is being done, to be very careful because it can lead to various complications, because sudden movement of the patient can bring in the that can cause further complication, neurological complications, or they can. So one needs to be careful with this. So these are the special concerns of this particular surgery. So for the corrective surgery, yes, you have to go for general anesthesia, and the concerns you have to keep in mind, the concerns, the pre-operative concerns like pulmonary complications, pulmonary involvement, which is already there, and which can further compromise the safety of the patient intraoperatively. So taking care of the anesthetic agents which you choose, and you will have to modify your technique depending on the what surgical test or the intraoperative test the surgeon wants to do. So accordingly, and the monitoring is very important in this particular patient. So besides going for your routine monitoring, and as I said, pulmonary involvement is there, you need to be careful with the oxygenation also of the patient also. And as the pulmonary compromise is already there, so this can cause further problems in the patients because of the prone position, and also post-operative risk of post-operative complications would be higher in such patients. So I think if there are any questions in the chat box, Shipriya, we can know that. And
no, ma'am, there are no questions in the chat box.
so I thank Dr. Nidhi and the team Appec for discussing, and the students will have more clarity about the subjects and understanding of the subjects. Thank you very much.
Thank you so much, ma'am. And
Thank you so
I'm
much,
really
ma'am.
grateful to Team Appec for having me here. Thank you so much. Thank you, ma'am.
Thank you so much, ma'am,
Thanks.
for sharing your wisdom and thoughtful insights. Thank you so much for your time and efforts. Thank you, Dr. Nidhi. It was a rather very enriching and insightful session. Your clarity and your deep clinical knowledge really made it understandable and memorable. Thank you, Dr. Nidhi. Thank you, Dr. Sujata, ma'am. So we conclude this session here, and we move forward for our next very interesting long case discussion, for which I would like to invite our chairperson, our moderator, Dr. Namita Arora, ma'am. She is Professor of Anesthesiology, Department of Anesthesia, AB Wims and Dr. RML Hospital. And her areas of interest are difficult airway, pediatric anesthesia, and ATLS training. And with her, our residents, Dr. Srinath and Dr. Shikha will be there for presenting the case. I welcome you, ma'am.
Thank you. Thank you, Dr. Shipriya. So let's start. Dr. Srinath Pillai, who is the final year postgraduate in our department, he will be presenting a case of benign prostatic hypertrophy posted for TUI. You can start your case.
Yes, ma'am.
Thank you, ma'am. Ma'am, my patient is a 74-year-old male. He's a farmer by profession, a resident from Agra. He presented to our hospital with the chief complaints of increased frequency of micturition for the last 2 years, dribbling of urine for the last 2 years, and feeling of incomplete bladder emptying for the last 6 months. Informant is the patient, and history seems to be reliable. My patient was apparently well 2 years back when he started experiencing increased frequency of micturition. This was gradual in onset and progressively increasing up to 12 to 14 times in a day without increasing water intake. The increase in frequency was more pronounced in night, and he had to wake up 4 to 5 times in night. Dribbling of urine during micturition was gradual in onset, progressively increasing, and associated with difficulty in initiation of micturition, hesitancy, and poor stream of urine. Feeling of incomplete bladder emptying for the last six months. He had complaints of lower abdominal fullness and urge to go again. There is no history of fever, pain, pus or bloody discharge, burning sensation during urination. No
So
history
why
of...
did you take this history, Dr. Srinath?
Yes, ma'am. Ma'am, my patient, I have taken this history to rule out any urinary tract infection or any other active infections.
Okay, because these patients are prone to like incomplete bladder evacuation. They will have stasis of urine and are more prone to infection.
Yes, ma'am. No history of pain in flanks. No history of loss of appetite or weight loss. No history of acute retention of urine or previous catheterization.
Why is this history important? Loss of weight, appetite, and acute retention.
Yes, ma'am. I have taken this history to rule out any neoplastic etiology.
Okay,
Like
very good. Yes.
prostate. Yes.
And acute retention of urine.
Yes, ma'am.
Are these patients prone to this?
Yes, ma'am. Patients of benign prostatic hypertrophy are more prone to have acute retention of urine, and this obstructive uropathy can cause back pressure and cause renal symptoms, and hence to rule out that I have taken this history now.
Yeah, and if patient has had any recent acute retention or catheterization, he is more prone to infection, and also
yes, ma'am.
there may be hyperemia of the prostate and the bladder, right?
Yes.
Okay. Go on.
Patient was advised tablet tamsulosin 0.4 milligram BD for the last 1 year. He had mild improvement in his symptoms initially, but now it doesn't seem to be helpful.
So what is tamsulosin?
Ma'am, tamsulosin is a selective alpha-1A receptor antagonist. It acts on the smooth muscles of the prostate and causes relaxation of the smooth muscles of prostate, relieving the symptoms of obstruction.
Yes, very good. So it doesn't seem to be helping because now the prostate seems to have increased further in size.
Yes,
and it seems to have now become a structural obstruction. Okay.
Ma'am, my patient is a known case of hypertension for the last 2 years on tablet amlodipine 5 milligram BD. He has no associated history of chest pain, headache, difficulty in breathing on lying down, any swelling in feet, loss of consciousness, or visual disturbances. Patient
This history is related to the end organ changes associated with hypertension.
Yes, ma'am. Patient had a history of pulmonary tuberculosis 8 years back, for which he got treated for 8 months and is currently asymptomatic. No history suggestive of ischemic heart disease or diabetes mellitus. No history of thyroid disorder, seizure disorder, or stroke. There is no history of any allergy or no significant family history. My patient is currently on tablet amlodipine 5 milligram BD for the last 2 years, tablet tamsulosin 0.4 milligram BD for the last 1 year. Coming to personal history, ma'am, my patient is having disturbed sleep due to increased night frequency of micturition. He's having a normal mixed diet, normal bowel habits. He's a non-smoker with occasional use of alcohol, no tobacco chewing, and its meds are more than 4.
So
No.
he has got good exercise tolerance, good functional capacity.
Yes, ma'am. No history of any chronic illness or malignancies in the family. No history of any psychiatric illness in the family. There is history of open right inguinal hernioplasty 12 years ago under subarachnoid block, which was uneven. Yes, ma'am. Coming to examination, patient was conscious, cooperative, and oriented to time, place, and person. He is well built and nourished. He has a height of 160 centimeter, weight of 66 kilogram, and a BMI of 25.7 kilogram per meter square. He has no pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema. JVP was not raised. My patient had a pulse rate of 70 per minute, which was regular, normal in volume, character, no radial radiofemoral delay. His BP was 148 by 90 mmHg taken in supine position in left arm. His SpO2 was 98% on room air. He was afebrile. Respiratory rate was 14 per minute. His breath holding time was 28 seconds. The spine examination was within normal limit with no tenderness at any point.
Okay, you specially examined the spine.
Yes,
You
ma'am.
have written that interspinal spaces were normal, but you also examined for tenderness.
Yes,
Why
ma'am.
did you do that?
Yes, ma'am. Ma'am, since my patient is a case of benign prostatic hypertrophy, there are increased chance that there may be a neoplastic etiology also. To rule out any vertebral skeletal mets, I have taken the history of tenderness at any point of the spine.
So, prostatic carcinoma, if present, metastasizes very early on to the spine. That is why you
Yes.
elicited tenderness. Very good. Next.
Ma'am, my patient has a mouth opening of more than 3 fingers, finger breadths. He is edentulous and no artificial dentures were seen. All other parameters of airway examination were within normal limits. Coming to respiratory system, the respiratory system examination was within a normal limits. No abnormal findings were there. His CVS examination was also within normal limits. On perabdominal
It is, I urge the postgraduates to do a very detailed systemic examination because he's a geriatric patient. Patients coming for TURP are geriatric patients, so they will have age-related changes, so should do a detailed systemic examination. Okay, go on.
Yes, ma'am. Ma'am, the perabdominal examination was also within normal limit and there were no abnormal findings in the CNS examination.
Okay. So what is your provisional diagnosis after having taken a detailed history and examination?
Yes, ma'am. Based upon my history and examination, my patient is most probably a case of benign prostatic hypertrophy.
Okay. Why do you say that?
Ma'am, my patient has complained of dribbling of. Ma'am, my patient has complained of increased frequency of micturition, dribbling of urine, and a sense of incomplete bladder. And he is a elderly age group. He comes under the elderly age group. So, and he doesn't show any signs of. He doesn't have any flank pain. He doesn't have any signs of urinary tract infection, nor any signs of any neoplastic etiology.
So these are typical symptoms that occur in a male patient with advancing age, and so the first diagnosis would be benign prostatic hypertrophy. Very good. So, can you briefly describe the anatomy of the prostate, which may help us to understand the etiopathogenesis?
Yes, ma'am. Ma'am, prostate is a male accessory reproductive gland which is situated around the prostatic urethra. It usually weighs around 20 grams. It is divided into 5 lobes: the anterior, posterior, median, the right, and the left lateral lobes. The prostatic blood supply is by the inferior vesicular artery, middle rectal artery, and the internal pudendal artery. The venous drainage is by the prostatic venous plexus or the Santorini's plexus. Coming to nerve supply, the sympathetic nerve supply of the prostate is via the spinal level T11 to L2 via the inferior hypogastric plexus. The parasympathetic supply is by the S2, S3, S4. The afferent pain fibers from the prostate and the prostatic urethra are also by S2, S3, S4. And the pain from the hyperdistended bladder is by the spinal level T11 to L2.
Okay, you are especially mentioning distended bladder because of the procedure which may cause bladder distension.
Yes, ma'am.
Anything peculiar about the venous plexus of the prostate?
Yes, ma'am. The venous prostatic plexus or the Santorini's plexus are located between the true capsule and the false capsule, and they have direct valvulus connection to the Batsen's plexus or the paravertebral venous plexus. So any metastatic cell or debris can directly go into vertebrae.
And also that prostate has two capsules, a true and a false capsule, and this plexus is lying between the two capsules, isn't it?
Yes,
and when they are performing TURP, any breach in the capsule can expose this venous plexus, and this can increase the amount of fluid, that is irrigation fluid, that is absorbed into the system, right?
Yes.
It should not be breached.
Yes, ma'am.
Very good. Okay, so you mentioned that medical therapy was tried first for this patient, and this patient was put on tamsulosin. Any
ma'am.
other group of drugs that you know of which the patients are tried upon?
Yes, ma'am. Other than selective alpha-1 receptor antagonist, we also have 5-alpha reductase inhibitors like finasteride. They prevent the conversion of testosterone to dihydrotestosterone, hence decreasing the proliferation and proliferation of the prostatic tissue, hence relieving the symptoms.
Yeah. So it may not actually directly relieve, but it can reduce the progression of the disease because it is going to reduce the growth of prostatic tissue.
Yes, ma'am.
Unlike the previous drug, which was reducing the spasm, relaxing the smooth muscle and relieving the symptoms, this can halt the progression or reduce the progression. Okay?
Yes.
Okay. So coming on to this patient has come with a diagnosis, right? Most often these patients come with diagnosis. They've already had a ultrasonography, and we know they come with the weight of the prostate mentioned in the ultrasound report, and they come for TURP. How will you investigate this patient further?
Yes, yes. Ma'am, in this patient, I would like to get the following investigations done. I would like to have a complete blood count, the baseline hemoglobin value to rule out any nutritional anemia as this patient is of geriatric age group. I would like to have a total leukocyte count to rule out any active infection or urinary tract infection. I would like to have a platelet count. I would like to do a kidney function test for the baseline levels of urea, creatinine, and baseline serum electrolyte values of sodium and potassium. I would like to have done a random blood
So why is it important? Why is KFT important? Have you ever seen a TURP patient with deranged KFT?
Ma'am, due to the obstructive symptoms due to the hypertrophic prostate, there can be back pressure which can lead to renal symptoms. So hence, baseline KFTs have to be done now.
So these patients may actually come with deranged KFT.
Yes, ma'am.
Okay. What about why sodium potassium?
Yes,
if they have one normal, like this patient has normal sodium and potassium, still you would want to, patient is fine, eating well, you would still want to do electrolytes?
Yes, ma'am. I would like to do the baseline serum electrolytes level because, ma'am, during the TURP procedure, the patient is prone to have hypervolemia and hyponatremia. So I would like to have a baseline serum sodium levels. And also these patients are prone to renal diseases, renal symptoms. Hence, I would like to do the serum electrolytes.
Okay.
I would like
What
to.
are the tests?
Yes, ma'am. I would like to do random blood sugar, liver function test. I would like to do a blood grouping and cross matching. I would like to do the viral marker scan, the urine routine and microscopy, urine culture sensitivity, chest X-ray, ECG, 2D echo, and USG abdomen.
Very good. In this patient, although there is no problem, no cardiac symptoms or suggestive of any cardiac disease, but you would like to have a normal baseline ECG, and being old patient, you would definitely want to have a baseline 2D echo.
Yes, ma'am.
And chest X-ray, why in this patient?
Ma'am, my patient is having a past history of pulmonary tuberculosis 8 years back. So I would like to rule out any sequelae of the infection.
Very good. Okay. So your patient, as we can see, has had all the investigations and they are all within normal limits, right?
Yes, ma'am.
Okay. So now you have to give the pre-operative orders for the patient. What orders would you write for this patient?
Yes, ma'am. For my patient, I would like to give the following orders. NPO orders of 8 hours for solids and 2 hours for clear liquids. Written informed consent. While taking the written informed consent, I will explain about the surgical procedure, the anesthetic procedure, the risk involved in the procedure, the risk of hemorrhage, and about the risk of TURP syndrome and etc. to the patient. And I will make the I will make and I would counsel the patient that the procedure would be painless. I would.
Yes. And okay, go on.
Yes, sir. And I would put up order to continue the antihypertensive medications till the morning of surgery.
Yes.
I would advise tablet alprazolam 0.25 milligram on the night, one day prior to surgery, and on the morning of surgery. Tablet pantoprazole 40 milligram on the night before surgery and on the morning of surgery. Blood grouping and cross matching. Antibiotic sensitivity testing. Yes, ma'am.
Very good. It's quite a comprehensively you have mentioned. And it's important for you to explain the possible symptoms of TURP syndrome and tell the patient that he is going to be kept conscious, he is going to be conscious throughout the procedure, that you are going to be with him all the time, reassure him he'll not have pain, and explain that if he feels any of these symptoms, he should immediately inform. Okay.
Yes,
so before starting, please tell me what are the anesthetic concerns in this patient that you're worried about?
Yes, ma'am. My patient is of elderly age group, so he may be having multiple comorbidities and all the complications associated with it. He's at increased risk of having deep vein thrombosis, increased risk of having hypothermia. My patient is at risk of developing TURP syndrome. And my this procedure is done under lithotomy position, so he will is likely to develop any complication due to the position also.
Yes. So all these are the anesthetic concerns. So keeping these concerns in mind, whether it is related to the procedure or the age of patient or the comorbidities, you would plan your anesthesia. So what would be your plan of anesthesia and the goals?
Yes, ma'am.
First the goals and then the plan.
Yes, ma'am. Ma'am, the goals of anesthesia for this patient would be to achieve hemodynamic stability, to obtain adequate level of blockade, to ensure safe and proper positioning, to prevent hypothermia, prevention and early recognition of TURP syndrome, and post-operative analgesia.
So what will be your plan of anesthesia keeping these goals in mind?
Ma'am, my plan would be central neuraxial blockade, specifically subarachnoid blockade.
Okay. Not general anesthesia.
No, ma'am. I
No.
would like to go with
Okay.
no,
And
ma'am.
not even epidural.
No, ma'am. I would like to go with subarachnoid block, ma'am. Ma'am,
Because it's a short procedure.
yes, ma'am. Ma'am, it's a short procedure, and I would also like to I would also like my patient to be awake and communicate, conscious oriented. So I can early recognize and prevent the TURP syndrome. And it will also help me in early detection of any bladder trauma or bladder perforation. And the subarachnoid block also ensures proper analgesia for the acute postoperative pain, and the recovery from the anesthesia is also faster.
Yes, and the blood loss is less,
Yes,
right?
yes.
And also the risk of DVT is less. All
Yes.
there is, you told that because of old age, there is risk of DVT. That is also much less in patients who receive spinal anesthesia compared to the ones done under general anesthesia.
Yes.
Okay. So you are planning spinal anesthesia. Okay.
Yes.
You have kept all the things ready in the OT. What all monitoring will you set up for this patient?
Yes, ma'am. Ma'am, for this patient, I would like to connect pulse oximetry, ECG, non-invasive BP monitoring. I would like to get a baseline blood sugar value. I would also connect temperature monitor, and I would also monitor the duration of the procedure.
Okay. And temperature, did you say you would also set up a temperature? Okay.
Temperature.
Oh, so once you have set up all this, you would like to start the case, and you would not like to preload the patient, right?
No, ma'am. I would prefer to not preload the patient, ma'am. As
Yes.
yes, ma'am. As during the procedure.
As the procedure itself will cause some hypervolemia because of absorption of fluid.
Yes, ma'am.
Okay. And as it is, old patients are very prone to hypervolemia,
Yes,
right?
yes.
And increase in preload can decompensate these patients. Okay.
Yes.
So what level of block would you like to achieve in this patient?
Ma'am, I would like to achieve a level of T10 in this patient, ma'am.
Okay. Any specific reason why T10 and why not higher, why not lower?
Ma'am, at T10 level, the sensation of the over-distended bladder can be blocked as the sensations are carried by T11 to L2 spinal root segments, ma'am. And above T10 level, then the signs as symptoms of bladder perforations can be masked, ma'am.
Okay. Yeah. So would not like to be higher than T10.
Yes, ma'am.
Very good. Okay. So you were mentioning about the irrigating fluid.
Yes,
In
ma'am.
TURP, what exactly is done?
Ma'am, TURP is transurethral resection of prostate, in which benign hypertrophic prostatic tissue is resected by a movable cutting wire cautery loop via a urethroscope. During the procedure, the bladder is continuously irrigated with the irrigation fluid for better view and also to wash out the blood and debris. The procedure usually takes 30 to 90 minutes, and it is done in the lithotomy position.
So what should be an ideal irrigating fluid?
Ma'am, ideal irrigation fluid should be non-electrolytic, transparent, non-toxic, isoosmolar, not readily absorbable, non-metabolizable, and it should be inexpensive.
Non-electrolyte, because electrocautery is being used and you don't want the current to be transmitted.
Yes,
okay.
ma'am.
You don't want it to be toxic, easily metabolizable, because it is going to be absorbed in the body. Again,
Yes.
non-toxic, and you want it to be isoosmolar, because when it is absorbed in the body, it should not cause It should
Uh,
not cause hypoosmolality of the plasma, because that will push the fluid into the interstitium and cause symptoms of water fluid over. Okay.
Yes.
So, as your table is showing, these are the usual irrigation fluids that are being used, right?
Yes, ma'am. Yes, ma'am.
Okay. What is being used in your institute?
Ma'am, in our institute, glycine 1.5% is used, ma'am, as irrigation fluid.
Okay, I can see that its osmolality is 220.
Yes, ma'am.
So is that less or same as plasma?
Ma'am, glycine 1.5% is an hypoosmolar solution, ma'am.
Okay.
The
So
osmolar,
why is hypoosmolar used?
ma'am, for better transparency, ma'am, for better view.
Okay. Okay. If we try to make it isoosmolar, then the visibility decreases because the viscosity increases.
Yes.
Okay. So I urge the postgraduates to know this table, and it is important for you to understand the pros and cons of using these different irrigation fluids. Okay. So the procedure has started, right?
Yes, ma'am.
What are you worried about most in this patient when this TURP is being done?
Ma'am, during the procedure, due to the irrigation of the bladder, there is increased risk of absorption of the irrigation fluid into the system, causing hypervolemia and hypoosmolarity, which can lead to TURP.
Because this is continuously irrigated, there is continuous cutting and coagulation of prostatic tissue and continuous irrigation. Most of it comes out, but some of it does get absorbed, right?
Yes,
So
ma'am.
what are the factors on which this absorption of irrigation fluid depends on?
Yes, ma'am. Ma'am, there's a rule of 60, ma'am. At a time, only 60 gram of the prostatic tissue maximum should be resected. The height of the hanging of the irrigation fluid should be no
So
more.
you mean to say if the prostate size is more than 60, it is
Yes.
advisable to do a two-stage prostatic.
Yes,
Okay. Okay.
Yes.
Then next.
The height of the irrigation fluid should be no more than 60 centimeters from the level of the pubic symphysis, ma'am.
What happens if it is higher?
Ma'am, if it is higher than 60 centimeter, then the hydrostatic pressure would be more than 60 centimeters of waters, which can increase the absorption of the irrigation fluid via the venous plexus.
Yeah, because the pressure would be more the hydrostatic pressure, and it will push the fluid into the circulation.
Yes, ma'am.
Okay. Okay. What else?
Duration of the procedure should not be more than 60 minutes, ma'am. Care should be taken that the capsule is not injured or ruptured during the procedure. And
Very good.
the mean arterial pressure of the patient should be maintained.
Because if the mean arterial pressure goes down, then the pressure gradient is more towards absorption, and then it will cause more absorption and likely symptoms. Okay.
Yes. Yes, ma'am.
Okay. So you told me that fluid is absorbed. Is there any rough estimate as to how much fluid is getting absorbed?
Yes, ma'am. Ma'am, 10 to 30 ml of fluid may get absorbed per minute of resection of prostate, ma'am.
Okay, so you mean to say if the resection is lasting for 60 minutes, there can be absorption of 600 to 1800 ml of fluid in the circulation, which can be a big amount considering that these are geriatric patients and can decompensate. Okay, so if so much of fluid is indeed absorbed, what will be the signs that you are looking for in the patient?
Yes, ma'am. Ma'am, this increased absorption of fluid can lead to hypervolemia, hypoosmolarity, and hyponatremia. Ma'am, the initial signs, initial symptoms would be restlessness and confusion by the patient. The patient may also develop hypertension followed by hypotension. There will be bradycardia. There will be hypothermia, it can also lead to pulmonary edema and gradual loss in the saturation of oxygen, gradual decrease in the saturation.
Why do you think all these symptoms are appearing in the patient?
Ma'am, due to water intoxication and hypoosmolarity.
Okay, so this hypoosmolality, what does it cause? It causes fluid to go from plasma into the interstitial. And once it goes into the interstitial tissues, it may cause cerebral edema. And when there is cerebral edema, there is restlessness, confusion, drowsiness, there may be seizures, or there may be initially headache. Okay. And like you said, there can be hypertension, there can be bradycardia. Of course, worsening will cause seizures and coma if you fail to recognize these symptoms. Okay,
Yes,
so what is it that concerns you as far as sodium level is concerned?
Yes, ma'am. The normal serum sodium level is 135 to 145 milliequivalents per liter. The symptoms of hyponatremia usually don't arise till the sodium levels drop below 120 milliequivalents per liter.
Okay, so coming to this, you said there is hypoosmolality and hypervolemia.
Yes,
You
ma'am.
see these patients, patient is undergoing TURP, you find that patient is suddenly become restless, he's having he's looking confused, complain of headache, there is some reduction in the saturation. What will you do immediately?
Yes, ma'am. I would immediately ask the surgeon to stop the procedure. I would stop the irrigation fluid and I would stop the IV fluids also and regulate the flow of the IV fluids. I would give supplement the patient with oxygen. I would send blood samples for baseline serum electrolyte levels, sodium levels. I will if the symptoms persist, and I would also like to administer IV diuretic agents like furosemide.
Very good. So if you do take these measures, most often the diuretic will suffice and will help to get rid of the excess fluid that is absorbed and the symptoms may subside. And it is very important, like you said, you will be doing monitoring and you will be also keeping track of the time, the cutting time. And it is important that when half the time is over, you should inform the surgeon that 30 minutes are over so that he has fair idea about where he's going. Especially an inexperienced surgeon can get carried away and continue to cut. Okay?
Yes.
So the sodium levels you will see. What do you expect to see in sodium levels? What kind of hyponatremia is it?
Ma'am, this is dilutional hyponatremia, hypervolemic hyponatremia.
Yes. So it is a relative hyponatremia because of absorption of free water, isn't it? So the sodium is not being lost, but it is relative hyponatremia.
Yes, ma'am.
So once you give diuretic, once the free water is getting excreted, the sodium levels may actually normalize.
Yes.
Okay. But if sodium level does not normalize, can you enumerate what are the different levels and what are the usual symptoms that may occur?
Yes, ma'am. Ma'am, if the sodium levels goes below 120 milliequivalents per liter, the patient would show symptoms like restlessness and confusion, and there would be on the ECG monitoring there would be wide QRS complexes. If the sodium level falls below 150 milliequivalents per liter, then the patient can have nausea and somnolence, and there would be wide QRS complexes, ST elevations, and T wave inversion. And if the sodium levels fall below 110 milliequivalents per liter, then it can lead to seizures and finally to coma. And on ECG, there will be ventricular tachycardia and fibrillations.
Very okay. So if this happens, if the patient does not improve while maintaining monitoring, you may have to put an advanced airway. You may have to initiate intermittent positive pressure ventilation, right? if the pulmonary edema is severe, you may have to give PEEP with IPPV, okay, till such time that the condition improves, right?
Yes,
So your treatment will depend on the extent of absorption and extent of signs and symptoms that you find, okay?
Yes,
And about sodium correction, if you find a level, say 110, will you correct it fast because it's likely to cause more and more symptoms?
Yes, ma'am. No, ma'am.
You will correct it fast?
Rapid correction of sodium levels are not advised, ma'am. We should give at the maximum of 100 ml of 3% sodium chloride per at 1 hour. And in 24 hours, maximum of 8 to 10 milliequivalents per liter of correction should be done. Not more than that.
If you do
Otherwise,
fast correction, what is it likely to do?
ma'am, it can lead to central pontine hemolysis, myelinosis, ma'am. Central pontine
Myelinosis.
Yes, ma'am.
Yes, yes, which is a irreversible condition.
Yes, ma'am.
Okay, so fast correction is absolutely not to be done. You will cause more harm to the patient than good. Okay. So that was about treatment of hypervolemia and hyponatremia.
Yes, ma'am.
Another complication you said was blood loss.
Yes, ma'am.
Right. Okay. So what about blood loss? How much blood loss is expected in such patients?
Ma'am, calculation of blood loss is difficult in a TURP procedure due to the continuous irrigation of bladder with the irrigation fluid. But we can approximate the blood loss based upon the weight of the resected prostate as 2 to 5 ml per gram of the resected prostate. 20 to 50 ml per gram of the resected tissue, and also 2 to 5 ml of the resection time per minute, 2 to 5 ml per minute of the resection. Yes.
Yes. So when you find that kind of blood loss, that is why again the amount of tissue resected or the time should be restricted.
Yes.
Okay. Anyway, this blood loss can be reduced.
Yes, ma'am. We can reduce this blood loss by restricting the resection time, by restricting the amount of prostate tissue that is resected at a single go. We can also restrict the blood loss by preventing any injury to the capsule of the prostate.
Yes, that is by the surgeon. If especially if it's an inexperienced surgeon or a surgeon who is doing his initial TURPs, you have to be very vigilant and make sure that he is being warned about not injuring or not violating the capsule of the prostate gland. Okay.
Yes.
And also, can you give tranexamic acid? Does it help?
Yes, ma'am. If the patient is having borderline hemoglobin and if the size of the prostate is large, then we can consider pre-op infusion of tranexamic acid.
Okay. Any contribution of the prostatic tissue, plasminogen, or anything to do with that in blood loss?
Yes, ma'am. Ma'am, there is inhibition of the conversion of plasminogen to plasmin, and which can lead to
More blood loss.
Blood loss. Yes, ma'am.
Yes, and in fact can contribute to it. So coming to this, coagulopathy is also one of the complications which may occur, which again can be because of dilutional coagulopathy or can be because of contribution by the prostatic tissue.
Yes, ma'am.
Or
hypothermia, ma'am.
Or hypothermia. Very okay. What other complications we can have? Hypothermia.
Yes, ma'am. Ma'am, there can be bladder perforation. Bladder perforation can be both can be extraperitoneal or intraperitoneal. In TURP, most commonly the risk are high for extraperitoneal bladder rupture. If there is extraperitoneal bladder rupture, the patient may complain of abdominal discomfort suprapubic pain or inguinal pain. If the bladder rupture is intraperitoneal, then there would be referred pain to the shoulder of the patient. There can
It's
be
because of, it is because of the diaphragmatic irritation.
Yes,
Isn't
ma'am.
it because of the urine and the irrigation fluid having entered the peritoneal cavity?
Yes, ma'am.
Isn't it?
Yes, ma'am.
Okay. Okay. Then hypothermia is very common in these patients because of the
Yes, ma'am.
less insulation in these old patients. So
Yes.
you can prevent hypothermia also. How
Yes.
can you prevent?
Yes, ma'am. We can prevent hypothermia by ensuring that the irrigation fluid is not cold. The IV fluid that we have administered is not is properly warm. The patient should be properly covered. The OT temperatures must be maintained.
So you mentioned that of all the irrigation fluids, glycine is what is being used. It's supposedly very close to ideal. But in
Yes.
spite of that, it can have some complications.
Yes, ma'am.
Can you enumerate some of the complications because of glycine?
Yes, ma'am. Ma'am, glycine is an inhibitory neurotransmitter. It can lead to transient blindness in the patient if because of the increased absorption of glycine into the system. It can also cause, ma'am, glycine is metabolized in the liver into ammonia, glycolic acid, and oxalates. This ammonia can lead to hyperammonemia, which can manifest as CNS symptoms. This oxalates can combine with calcium, forming calcium oxalate crystals, which can accumulate in the kidney, causing renal symptoms, and it can also lead to hypocalcemia.
Okay. About this blindness, something very, very typical about the glycine-induced blindness.
It's a transient blindness, ma'am. The treatment is reassurance to the patient that it is spontaneously, the patient will recover, ma'am.
How does it recover?
Ma'am, as the glycine levels decrease, the patient's symptoms will improve.
Yeah, because it's an inhibitory neurotransmitter. Once the metabolization of glycine occurs, the blood levels decrease, and hence the blindness recovers within 24 hours.
Yes.
Okay. Coming to, can there be septicemia?
Yes, ma'am. Ma'am, due to the obstructive urinary symptoms, these patients are more prone to have urinary tract infections. And if the patient is having an active urinary tract infection, then they are more prone to have perioperative septicemia.
Yeah, that is why it is very important. The surgeons are also particular. In fact, quite a few patients are catheterized when they come, when they are planned. And so with an indwelling catheter, they are very prone to infections. They have to make sure that there is no infection in the urine. Urine culture is sterile, because when they do instrumentation, this can cause bacteremia and subsequently septicemia.
Yes, ma'am.
Okay. And hemolysis is also common in these patients, again, because of free water absorption and hemolysis and its subsequent complications.
Hyperkalemia.
Right? Okay. So what about the type of TORP? There is, what type of diathermy is used?
Yes, ma'am. Ma'am, monopolar pottery and bipolar pottery are can be used, ma'am. But while using monopolar pottery, then a non-electrolytic irrigation fluid should be used, like glycine.
Because there is only a single point where the current is introduced into the bladder, and it is then transmitted. It is then transmitted through the fluid. But when
Yes.
Bipolar is used, the arc through which the current is passed is only between the 2 points of the pottery, and
Yes.
hence any even a electrolyte transmitting fluid can be used for irrigation. Okay.
Yes.
Okay. What about post-operative care of these patients?
Yes, ma'am. Ma'am, after the procedure, a triple lumen urinary catheter is inserted and the bladder irrigation is continued for post-op 24 hours. So the patient should be under monitoring in the post-op area also. Pulse oximetry.
Can TURP syndrome occur later?
Yes, ma'am. Due to the continuous irrigation of the bladder, which is continued in the post-op period also, patient can have TURP syndrome in the post-op 24 hours also.
Very good.
Pulse oximetry, ECG.
Monitoring standard has to be maintained, isn't it?
Yes, ma'am. Yes,
Same monitoring standard has to be maintained. Okay,
Yes.
what else?
Yes, ma'am. If the patient has shown any symptoms of TURP in the intraoperative period, then the monitoring should be continued in the post-op period also. Repeated serum electrolyte levels should be checked. Post-op hemoglobin levels should be checked, ma'am. And the patient should be and normothermia of the patient should be ensured, and post-op pain relief also should be ensured.
Yes, and patient may have continuous bleeding also when there is irrigation. So in fact, patient's hematocrit is checked and also the hematocrit of the returning fluid.
Yes, ma'am.
Isn't it?
Yes,
Can
ma'am.
be checked.
Yes,
And
ma'am.
accordingly, blood replenishment can be done
Yes, ma'am.
post-operative.
Yes, ma'am.
Okay. Can general anesthesia be given to these patients? When is it indicated?
Yes, ma'am. If the patient is having reduced cardiopulmonary reserve, then we can consider general anesthesia, ma'am.
Yes. Where the risk of regional spinal anesthesia is more than general anesthesia, right? Like absolutely borderline cardiorespiratory reserve, very poor lung function, very poor cardiac function, low ejection fraction. These patients should be given general anesthesia because it is much easier to manage. And then, of course, you have to be equally vigilant in recognizing fluid absorption in these patients, right?
Yes, ma'am.
Is there any other type of procedure other than the standard TURP which has come up, which can reduce all these complications?
Yes, ma'am. Laser resection of prostate has come up, ma'am. It has reduced the risk of hemorrhage, reduced the use of the irrigation fluid, but it has also associated risks such as proper eye protection wear should be made. Eye protection wear should be worn by the team members to prevent irreversible eye damage.
Yes. Yes. Very good. Another thing I want to say is that these patients very often present with acute urinary obstruction and they are catheterized. And their KFT, if initially deranged because of back pressure changes, take a few weeks to settle to normal after catheterization. So a lot of patients, when they present with acute obstruction, are catheterized and then sent back home. And their urine is then monitored for any possible infection. The deranged KFT is monitored for returning to normal. And only once all this happens, that these patients are then posted for TUR.
Yes, ma'am.
I think we have covered most of the points. Dr. Shivpriya, are there any questions in the chat box?
No, ma'am, there are no questions yet.
Okay. Okay, I think Dr. Shrikant has very well answered all possible queries that will come up in the examination. TURP can come as a short case. It can come as a long case. So I urge the postgraduate students to know the physiological changes due to old age should be very well known to them. They all need to know how to do a detailed systemic examination. Again, and whenever there is any, you may have patients of TURP with diabetes, you may have patients with CAD, patients with hypertension. Here, this was a straightforward case with controlled hypertension. So any other case you have to, then it is important to also know the latest guidelines in case the patient is on any anticoagulants, because this patient is going to be done under spinal anesthesia. So know the latest guidelines for patients who are on anticoagulants. I think I can now pass it over to Dr. Shikha. She's a senior resident in our department, and she will now present and summarize the case and highlight the salient features. Over to you, Dr. Shikha.
Thank you, ma'am. Good afternoon, everyone. I'm Dr. Shikha Singh, working as a senior resident in the Department of Anesthesia. I'm going to present a topic of BPH and TURP surgery. Anatomy of prostate. Prostate is inverted cone in shape, weighs around 15 to 20 grams, and it is encircling the prostatic urethra. It consists of 5 lobes, median to lateral, anterior, and posterior. In BPH, there is enlargement of median and the posterior lobe, which causes compression of the urethra and produces the obstructive features of BPH. It consists of 2 capsules as shown in the figure, true capsule and the false capsule. And venous plexus is located in between the 2 capsules. During the surgery, surgeon removed the prostate without the capsule. If there is any breach in the capsule, it increases the risk of venous plexus injury, which in result causes increased absorption of the irrigating fluid and increases the incidence of TURP syndrome. Nerve supply of the prostate comes from both sympathetic as well as parasympathetic system. Sympathetic supply is from the level of T12 to L2, and parasympathetic supply is from S2, S3, and S4. Nerve supply of the bladder, sympathetic comes from T10 to L2 and parasympathetic from S2, S3, and S4. For adequate level of anesthesia, T10 level should be achieved so as to prevent any pain, abdominal pain from the overdistension of the bladder, as in there is absorption of irrigation fluid during TURP surgery. Geriatric patient has certain physiological changes occurring with the age. Like in cardiovascular system, there is reduced beta receptor sensitivity, reduced cardiac compliance. So these patients have are more prone for bradycardia during the stressful situations like surgery, and their BP is labile. In respiratory system, they can have reduced chest wall compliance, increased residual volume, which can result into VQ mismatch and risk of hypoxia. They have reduced GFR, therefore reduced clearance of the drug. So they are more sensitive to nephrotoxic drugs. Reduction in the hepatic blood flow results into decreased metabolism of the drugs and increased half-life of drug. Therefore, less frequent dosing of drugs is required. Patients are more prone for, they have increased sensitivity to both IV as well as inhalational anesthetic agents. In history taking, we take the history related to the prostate, as there is enlargement of the prostate, which is compressing the urethra. There can be obstructive features like dribbling of urine, poor stream of urine, sensation of incomplete emptying of the bladder. As patients are in old age, there can be multiple comorbidities and systemic involvement. So history should be taken pertaining to that. Chest pain, palpitation, shortness of breath should be history of all the symptoms should be taken. Then disorientation to time, place, person, difficulty in speech and memory loss. Functional status assessment is to be done by assessing the best of the meds of the patient. These patients can have multiple comorbidities and on multiple drug therapy. So history must be taken regarding that. On general physical examination, pallor is particularly important. As geriatric patients have chronic nutritional deficiencies, they are prone for anemia of chronic diseases. Pedal edema should be looked upon. They are on long-term diuretic therapy, and because of the restricted intake due to obstructive features, these patients are prone for dehydration. On airway examination, patient can be edentulous, which can make the difficult Bergen mass. Then artificial dentures can be present, which should be removed prior to the surgery if it is removable. Detailed systemic examination is to be done because of the certain physiological changes which occur with age, as already discussed. So CVS, respiratory, CNS, and per abdomen examination is to be done. Per rectal examination is done by the surgeons. Routine investigations like CBC, RPS, LFT, KFT, serum electrolytes, chest X-ray, ECG, and blood grouping cross-matching should be done. Urine RM and urine CS is particularly important as these patients are prone for recurrent UTIs. Depending upon the cardiopulmonary reserves, if it is reduced, echo and PFT is to be done, and coagulation profile. BPH is an age-related benign prostatic enlargement that produces the urinary symptoms. It can be managed either medically or with the surgical management. In medical management, we have alpha blockers and the 5-alpha reductase inhibitors. Alpha blockers act by relaxing the smooth muscles in the prostate and the bladder neck, which will relieve the obstructive features. Example is tamsulosin. Side effects, it can lead to orthostatic hypotension and dizziness. 5-alpha reductase inhibitors prevent the conversion of the testosterone to dihydrotestosterone, which is required for the growth of prostate. Example, finasteride. Side effect is decreased libido and erectile dysfunctions. Surgical management, we have TURP surgery, which could be monopolar, bipolar, laser TURP, and open prostatectomy. Open prostatectomy is no longer done. Laser TURP is a newer advancement. We have to optimize any pre-existing conditions like diabetes, hypertension, CAD, COPD. We have to provide instruction regarding continuation or discontinuation of the drugs, like our patient is on antihypertensive, antibiotic prophylaxis to prevent an urinary infection, and arrange blood. Preoperative orders consist of NPO, written informed consent, instructions regarding ongoing medication, blood grouping cross-matching, morning serum electrolytes, anxiolytis, and pantoprazole. Morning serum electrolytes are important as to get a baseline value of the sodium, as this patient are prone for hyponatremia during the TURP surgery. Anesthetic considerations can be age-related, as these are geriatric patients. They can have multiple comorbidities and their complications, and they are prone to develop DVT. Procedure-related like bleeding, TURP syndrome, bladder perforation, hypothermia, as thermoregulatory mechanism is impaired in the old age, and continuous irrigating fluid is used, which can result into hypothermia, irrigation fluid-related complication, and transient bacterial ischemia. Position-related, patient is positioned in the lithotomy position, which increases the chances of compressive neuropathies and pressure injuries at the pressure point. Therefore, adequate padding should be done at all the pressure points. There are chances of hip dislocations. During lithotomy, both the legs of the patient should be raised simultaneously. And as the legs are raised, there are chances of increased venous return. Sudden increase in venous return can cause cardiac overload. Goals of anesthesia is to provide the hemodynamic stability, proper positioning, adequate level of blockade, prevent and recognize early signs and symptoms of TURP syndrome or bladder perforation, prevent any hypothermia, and provide adequate post-op analgesia. Spinal subarachnoid blockade is preferred over GA as the patient is awake. So early signs and symptoms of TURP syndrome could be detected. Early detection of any bladder perforation, reduced blood loss, post-op analgesia, reduced incidence of DVT, and low cost. T10 level of blockade should be achieved to prevent any pain from bladder over distension due to absorption of the irrigation fluid, but it should not be above it because signs of bladder perforation can be masked. Monitoring consists of saturation, pulse oximetry, ECG, and NIBP. Mentation is particularly important because early symptom of the TURP syndrome is confusion and dizziness, nausea, vomiting, which could be detected early. Then temperature is particularly important as these patients are prone to hypothermia, blood loss, serum sodium because of the risk of hyponatremia, and ET CO2 monitoring if GA is done.
In TURP, a resectoscope is inserted through the urethra and there is a section of prostate done using electrocautery and continuous irrigation of bladder is done with the irrigating fluid. Properties of ideal irrigating fluid are it should be transparent, non-electrolytic, non-toxic, isosmolar, not readily absorbable, inexpensive, and not metabolized. Glycine 1.5% is most commonly used. It is hypotonic in nature, so there is risk of TURP syndrome. Other than that, sorbitol, mannitol, urea, sterile water, normal saline can be used. Normal saline is isotonic in nature, so it has minimal risk of causing TURP syndrome, but it is conductive, therefore monopolar TURP cannot be done. Factors affecting the irrigating fluid, rule of 60. Larger the size of prostate resected, more will be the venous plexus is open, more will be the absorption of irrigation fluid. Height of the irrigating fluid above the level of pubic symphysis, not more than 60 centimeters, and resection time should not be more than 60 minutes. If prostate is large, it has to be done in a staged procedure. Violation of the prostatic capsule. If there is sudden decrease in MAP, it can also increase the pressure gradient and more absorption of the irrigation fluid and vascularity of the prostate. Irrigation fluid enters into the circulation through the open prostatic venous sinuses. Average rate of absorption is 20 ml per minute of resection time. Amount of fluid absorption can be calculated using a formula which is shown on the slide. Patient presents with delusional hyponatremia or hypervolemic hyponatremia because of the absorption of large volume of irrigating fluid, which can present with signs and symptoms as shown in the slide. TURP syndrome, there is rapid absorption of the irrigation fluid. It can occur within 15 minutes of the resection, or it can occur up to 24 hours in the postoperative period as well. There is absorption of large volume of fluid, which can cause fluid overload, water intoxication, delusional hyponatremia, hyposmolarity. Because glycine is more commonly used, it can produce ammonia as a metabolite and cause hyperammonemia and hemolysis. TURP, there are signs and symptoms. In cardiovascular systems, initially there will be absorption of large amount of fluid. So that will result into hypertension with reflex bradycardia. But eventually patient will end up in cardiovascular collapse and hypotension. ECG changes like white QRS, ST elevation, and ventricular arrhythmias can happen because of hyponatremia. Patient can present with tachypnea or decreasing oxygen saturation because of pulmonary edema. Neurological features, earliest is the altered sensorium and mental confusion. Other than that, transient ischemic blindness can happen due to hyposmolarity and hyponatremia. Most commonly used is glycine. Glycine can produce ammonia as a metabolite leading to hyperammonemia. Oxalate, which is excreted into the urine, can produce renal failure, and glycolic acid, which can produce acidosis. Treatment of TURP syndrome is we have to stop the surgeon, stop the irrigation fluid, minimum intravascular fluid, IV fluid should be administered. Baseline sample should be sent for the serum sodium values. If serum sodium is more than 120 milliculant per liter, we have to give the loop diuretics. If it becomes less than 120 milliculents per liter, then hypertonic saline is to be given. Rate of correction should not be more than 100 ml per hour, as faster correction could lead to central pontine myelinosis. And the goal of treatment is to bring the sodium values till 120 milliculant per liter. It is difficult to estimate the blood loss because of the continuous use of irrigation fluid, but rough estimation can be done on the basis of resection time and amount of tissue resected. It is 2 to 5 ml per minute of resection time and 20 to 50 ml per gram of the resected tissue. Another complication is bladder perforation. It can be either because of surgical instrumentation or over distension of the bladder by the irrigation fluid. It could be extraperitoneal or intraperitoneal in nature. Extraperitoneal earliest sign is decreased return of irrigation fluid. It can cause nausea, vomiting, abdominal pain, but pain will be in lower abdomen below the umbilicus level. In intraperitoneal, there could be reverse shoulder pain due to diaphragmatic irritation. It is treated either with the open surgery or percutaneous drainage of the abdomen. Glycine is most commonly used. It is an inhibitory neurotransmitter in the retina, so it can produce transient blindness. Counseling of the patient should be done that it is transient. ECG changes like T-wave inversion and depression with raised CKMP, but without any MI, acute MI. Since glycine is metabolized to produce the ammonia, it can cause hyperammonemia, ammonemia, which can cause nausea and vomiting. If it is for prolonged period, it can even produce coma up to 10 to 12 hours. Laser TURP is a newer technique where light energy is used to coagulate or vaporize the prostatic tissue. Holmium laser enucleation of prostate is a new gold standard treatment. In PVP technique, photo-selective vaporization of prostatic tissue, KTP laser is used, which causes decrease in the wavelength. And this reduced wavelength is better absorbed by the hemoglobin and blood-rich tissue like prostate, and there will be less dissipation into the surrounding tissue. Advantages, since it uses the isosmolar fluid, so there will be less chances of TURP syndrome, reduced bleeding, and decreased hospital stay. Thank you.
Thank you, Dr. Shikha. I think Dr. Shikha and Dr. Sheena, you did really well. You answered all the questions. Your preparation was very good and you stuck to the time. If there are no questions to be answered, I think I hand over to Dr. Shivpriya.
Thank you so much, ma'am, for such a clinically relevant and well-structured case discussion, and your clarity and depth of knowledge. I am a big fan of which. So it made the whole discussion very enriching and insightful. Thank you so much, ma'am, for your valuable time, efforts, and sharing your wisdom. And thank you, Dr. Shikha, for very well summarizing the case. Thank you, ma'am. And thank you, Dr. Srinath, for presenting the case. So we conclude this session here and move forward to our
postgraduate exam.
Yes, ma'am. So we move forward to our very interesting next session. So for which I would like to invite our chairperson, Dr. Arvind Arya. Dr. Arvind Arya, he's HOD in Neuroanesthesia and Critical Care in IHBS Institute, Delhi. And he has more than 40 national and international publication in his record. And he was Vice President ISA Delhi, ex-ISNCC GC member, NABH coordinator and assessor. And he was IMA EDB executive member. He has won Medical Association Young Jewel Award in 2010, 12 and 14. And IMA Excellence Award 2018, 20, 21, 22, 23, 24 and 25. And he has got Certificate of Excellence from Delhi Medical Association 2016, 22, 23 and 25. And Award of Excellence for Distinguished Services from ISA Delhi Chapter 2018, 20, 22. He has organized various national conferences and workshops and completed more than community-based resuscitation training programs. So that's a lot of achievements, Dr. Arvind. I congratulate you, and we are honored to have you as our chairperson for this session. I welcome you, sir, and hand over the session to you.
Thank you, Dr. Shivpriya, for kind introduction of me. And I am really thankful to Dr. Dirja ma'am, Dr. Akhilesh, and you and whole team of the RML for organizing wonderful Appec 2025. And I am seeing you for last so many years. You are doing such a wonderful. And last session was such a beautiful. They have organized, structured everything so nice, and it's important discussions about the benign prostate hypertrophy and the management. Now we are coming to the neuroanesthesia part and such, and we are having a very important topic. As we know, in India, we are having more than 10 lakh people having the road traffic and head injuries cases each year. And it is very sorry and it is quite painful to have more than 2 lakh deaths because of the traumatic brain injuries in India each year. Globally, we are the highest and we have to reduce. And the main reason is that because the golden period where the patient should be reached at the center to have the best management in early 2 hours, which is not possible in India. So this is a very important topic, and for discussion on it, and we have so many guidelines about the brain traumatic injury, like brain trauma foundation guidelines. And Dr. Suzili is Nang Suzili is along with us, and she's a faculty in RML. Can we have some introduction of her? Yeah, Dr. Nang Sujil is professor in the Department of Anesthesia at ABYMS and the Dr. RML Hospital. And her area of interest are neuroanesthesia, pediatric anesthesia, and critical care. So over to you, Dr. Nang Sujili, to have discussion and topic and cover this topic.
Good afternoon, sir.
Good afternoon, everyone. My topic for today is traumatic brain injury. Traumatic brain injury is defined as a blow or penetrating injury to the head that disrupts the function of the brain. It is a leading cause of death and disability, particularly in younger populations. Risk factors include motor vehicle accidents, falls, sports injuries, and violence. Alcohol consumption is another significant contributing factor in many TBI cases. Coming to the pathophysiology of traumatic brain injury, the injury may be primary or secondary. The primary injury occurs during impact, resulting in skull fractures, concussion, brain contusion, intracranial hematoma, or diffuse axonal injury. Secondary injury develops within minutes, hours, or days after the initial trauma and includes a cascade of damaging events like inflammation, cerebral edema, excitotoxicity, tissue ischemia, intracranial hypertension. These processes can lead to further neuronal damage, cell death, and increased intracranial pressure, resulting in secondary injuries. Secondary insults resulting from the primary injury may be early or delayed. Hypoxia in the early period occur due to aspiration, apnea, pneumothorax, pulmonary contusion, neurogenic pulmonary edema, and in the delayed period may occur due to ARDS, pneumonia, transfusion-related lung injury, etc. Causes of hypotension are spinal cord injury, hemorrhage, hemothorax, myocardial dysfunction, cardiac tamponade, etc. Other secondary insults which may occur due to the primary injury are hypercarbia, hypocarbia, hyperglycemia, seizures, vasospasm, intracranial hypertension. Pre-hospital management should focus on reducing the burden of secondary injury and timely transport for definitive care. Treatment should begin at the site of the accident following an established algorithm like ATLS that prioritizes circulation, airway, and breathing. Patients should be promptly transported to specialized trauma centers with 24 hours radiological imaging, operating room availability, and prompt neurosurgical care. In the emergency department, the patient's neurologic status should be assessed and other injuries ruled out. All traumatic brain injury patients are assumed to have a full stomach. Depending on the patient's level of consciousness and neurologic status, tracheal intubation should be done to prevent aspiration and to ensure adequate ventilation to avoid hypoxia and hypercarbia. Cervical alignment with inline stabilization without traction is recommended during emergency intubation. Removal of the anterior portion of the cervical collar after manual inline stabilization should be done to improve mouth opening for laryngoscopy. When facial fractures and soft tissue edema prevent direct visualization of the larynx, video laryngoscope, fiber optic intubation, intubation with an illuminated stylet, or intubating laryngeal mask airway may be attempted. In severe facial or laryngeal injuries, cricothyrotomy may be required. Avoid nasotracheal intubations in suspected basal skull fracture, severe facial fractures, or bleeding diathesis. The focused neurological assessment of patients with TBI is performed using the Glasgow Coma Scale, which defines neurologic impairment in terms of eye opening, speech, and motor function. The maximum score is 15, and based on the score, traumatic brain injury is classified as mild when GCS is 13 to 15, moderate when GCS is 9 to 12, and severe if GCS is 8 or less. Prognosis after TBI depends on the type of lesion, age of the patient, severity of the injury based on GCS. Lower the GCS, higher the mortality. Older patients have poorer outcome after traumatic brain injury. Another important neurological assessment is the pupillary examination. It can indicate the severity and location of the brain injury and also indicate increased intracranial pressure or other serious complications. Look for the size and shape of the pupil, reactivity to light, and whether it's unilateral or bilateral. Pupillary abnormalities along with neurological deficits have a poor prognosis. The mainstay of traumatic brain injury management in the emergency is ongoing resuscitation with focus on minimizing secondary insults, assessment of extracranial injuries, and rapid performance of necessary imaging and laboratory investigations in preparation for surgery or admission to the intensive care unit. In patients with mild TBI, they are mostly asymptomatic and few require neurosurgical intervention. In cases of moderate TBI, emergency CT scanning should be done and patients admitted for observation with serial neurologic examinations. In cases of severe TBI, these patients require advanced trauma life support and stabilization in the emergency department, followed by CT scanning of the head and cervical spine and often surgical management. After complete history and neurologic examination, full diagnostic evaluation should be done. CT scan is the mainstay of imaging in TBI since it is quick and accurate in detecting both primary and secondary injuries. A spiral CT of the head and craniocervical junction should be done. Indications for CT in minor TBI, according to the Canadian rule, are patients with high risk for neurological intervention, that is, patients with GCS score of less than 15 at 2 hours after injury, patients with suspected open or depressed skull fracture, or presence of any sign of basal skull fracture. Patients with vomiting episodes of more than or equal to 2, or patient's age more than or equal to 65 years. CT scan should also be done in patients with minor TBI if patient has amnesia lasting for more than 30 minutes and the mechanism of injury is high risk. Magnetic resonance imaging is sensitive for the detection of axonal injury. The different types of brain lesions in TBI are extradural hematoma, subdural hematoma, intracerebral hematoma or hemorrhage, subarachnoid hemorrhage, and skull fractures. Depressed skull fracture should be elevated and debrided within 24 hours to minimize infection. Patients with EDH present with altered sensorium, lucid interval, and neurological deterioration. EDH should be evacuated if symptomatic or thickness exceeding 1 cm or volume over 30 cc regardless of GCS score. Subdural hematoma may be acute if symptoms appear within 72 hours, subacute if symptoms appear between 3 to 15 days, or chronic if symptoms appear after 15 days. Surgery is indicated if SDH is greater than 1 cm thickness or associated with a midline shift of greater than 5 mm, or the patients have GCS of less than 8 or with declining neurological status. In intracerebral hematomas, symptoms may range from minimal neurologic deficits to deep coma depending on the part of the brain affected. Surgery is indicated with neurologic deterioration or refractory intracranial hypertension or mass effect. Coming to the management of TBI, with reference to the latest Brain Trauma Foundation guidelines, that is the 4th edition, it is recommended to maintain a systolic blood pressure of more than or equal to 100 mm mercury for patients between 50 to 69 years old and more than or equal to 110 mm mercury for patients 15 to 49 years or more than 70 years old. Cerebral perfusion pressure should be maintained between 60 and 70 mm mercury. Jugular venous saturation of less than 50% should be avoided to prevent cerebral ischemia. Ventilation strategy in TBI should target on preventing hypoxia and hypercarbia. Hyperventilation is recommended as a temporizing measure for the reduction of elevated ICP. Prolonged prophylactic hyperventilation with PaCO2 less than 25 mm mercury is not recommended. Hyperventilation during the first 24 hours after TBI should be avoided. If hyperventilation is used, jugular venous oxygen saturation or brain tissue oxygenation should be monitored. Early short-term prophylactic hypothermia is not recommended in patients with diffuse injury. Hyperthermia should be aggressively treated. Prophylactic use of phenytoin or valproate is not recommended for preventing late post-traumatic seizures. Phenytoin is recommended to decrease the incidence of early post-traumatic seizures when benefits outweigh the risk. The use of steroids is not recommended in TBI. High-dose barbiturates are recommended to control elevated ICP refractory to maximal medical and surgical treatment. Glycemic control. While hyperglycemia is commonly seen in patients with TBI, intensive glycemic control may increase the risk of hypoglycemia. It is recommended to maintain glucose levels below 180 mg per deciliter while avoiding hypoglycemia. ICP should be monitored in all patients with TBI if GCS is less than 8 after resuscitation and an abnormal CT scan. ICP monitoring should be done in patients with severe TBI with a normal CT scan if two or more of the following are present. That is, age more than 40 years, patients with unilateral or bilateral motor posturing, or with systolic blood pressure of less than 90 mm mercury. Guidelines recommend treating ICP if it is more than 22 mm mercury. ICP management. The primary goal in management of ICP is to maintain adequate cerebral perfusion pressure and prevent secondary brain injury. Management involves a stepwise approach starting with conservative measures. Initial steps, that is Tier 0 intervention, includes tracheal intubation and mechanical ventilation, elevation of the head by 30 to 45 degrees, adequate analgesia and sedation, and fever prevention. Tier 1 intervention include maintaining PaCO2 at lower end of normal, that is 35 to 38 mm mercury, osmotherapy with mannitol or hypertonic saline, drainage of CSF, and consider anti-seizure prophylaxis for 1 week. Tier 2 interventions include mild hypocapnia, neuromuscular paralysis, assess cerebral autoregulation, and raise cerebral perfusion pressure with fluid boluses, vasopressors, and or inotropes to lower ICP when autoregulation is intact. And Tier 3 interventions include barbiturate coma, secondary decompressive craniectomy, and mild hypothermia, that is temperature of 35 to 36 degrees Celsius using active cooling. Anesthetic management of patients with TBI is a continuation of the initial resuscitation, including airway management, fluid and electrolyte balance, and ICP control. A focused pre-anesthesia assessment should include airway, including cervical spine, breathing, circulation, associated injuries, and neurologic status of the patient, that is ABCDE approach, along with detailed history of pre-existing chronic illness, circumstances and timing of the injury, duration of unconsciousness, and associated alcohol or drug use. Goals of anesthesia are to optimize cerebral perfusion and oxygenation, prevent secondary damage, and control ICP. The choice of anesthetic agents should depend on patient condition, taking into consideration neuropharmacological effects of anesthetic agents. Thiopentone, propofol, and etomidate reduce CMRO2 and cause cerebral vasoconstriction, leading to reduction in cerebral blood flow, cerebral blood volume, and ICP. Succinylcholine should preferably be avoided, and if unavoidable, give defasciculating dose of non-depolarizing muscle relaxant. Inhaled anesthetic agents decrease CMRO2 but have intrinsic cerebral vasodilatory effects. Nitrous oxide increases CMRO2, causes cerebral vasodilatation and increase ICP, so should be avoided. With controlled ventilation, opioids have no direct effects on cerebral hemodynamics. Ventilation should be adjusted to ensure adequate oxygenation, that is a PO2 of more than 60 mm mercury and normocarbia, that is PSO2 35 to 45 mm mercury. Systolic blood pressure should be maintained at more than or equal to 100 to 110 mm mercury. Hypotension should be managed with glucose-free isotonic crystalloid fluids, blood transfusion, and inotropic and vasopressor drugs when necessary. Hypertension, tachycardia, ECG abnormalities, and fatal arrhythmias are commonly seen in TBI due to sympathetic surge. Severe intracranial hypertension precipitates reflex arterial hypertension and bradycardia known as the Cushing stride. Acute reduction in blood pressure in these patients can aggravate cerebral ischemia by reducing the cerebral perfusion pressure. Adequate analgesic and sedative is important before starting antihypertensive therapy in these patients. Intraoperative cerebral swelling should be managed with adequate analgesia, anesthesia, and neuromuscular blockade, and consider TIVA if using inhalational agents. Adjust ventilation to maintain cerebral oxygenation and prevent hypercarbia. Head elevation of 30° or more to facilitate cerebral venous drainage and avoid neck flexion or rotation. Hyperosmolar therapy with mannitol or hypertonic saline and CSF drainage. If extubation is planned, emergence should be smooth, avoid coughing or bucking on the endotracheal tube, and postoperative ICU management involves continued neuromonitoring, analgesia and sedation, ventilation, ICP management, and early detection and management of complications. Traumatic brain injuries can lead to a wide range of multi-system sequelae impacting not only the brain but also other body systems. These can manifest as cognitive, emotional, behavioral, and physical impairments as well as other systemic complications. Cardiopulmonary complications are aspiration pneumonia, airway obstruction, hypoxemia, shock, ARDS, neurogenic pulmonary edema, and myocardial dysfunction. Hematologic complications may be DIC, anemia, etc. Endocrine problems are pituitary dysfunction like diabetes insipidus, syndrome of inappropriate antidiuretic hormone secretion. Metabolic may be non-ketotic, hyperosmolar, hyperglycemic coma, and GI problems like stress, ulcer, hemorrhage, and others like infection, sepsis, etc. The functional outcomes of patients following brain injury is assessed using the Glasgow Outcome Scale, which categorizes patients into 5 outcome categories. These are dead, vegetative state, severe disability, moderate disability, and good recovery. To conclude, good functional outcome following traumatic brain injury requires prompt protocol-based resuscitation with focus on minimizing secondary insults, rapid transport and assessment of intracranial and extracranial injuries, rapid imaging and surgery, ICP control, and a vigorous intensive care management. Thank you for your patient hearing and best wishes for your exams.
Thank you, Dr. Sujali, for covering this very extensively. And this is a very important topic. And my take for this discussion is that as a postgraduate students, we should know about what is the ICP monitoring, what are the methods, because these days invasive ICP monitoring is still a gold standard, and there are other non-invasive method of the ICP monitoring like optic nerve sheath diameters and other things are very important to know. Secondly is the management of the ICP. So usually asked in the exams is the about the mannitol and the hypertonic saline. What is the significance of the electrolytes, particularly in the traumatic brain injury, and how to go for these things. Thirdly is the management in the acute phase, in the early golden hours up to the 4 hours. So stabilizing of the hemodynamics, airway control, and the control of the hemorrhage, along with the other important parameters, is very necessary. So if we are having any question in the chat box.
Not Dr. Arvind. There are no questions till now.
Okay. So thank you, Dr. Sujali, for covering this topic. We can conclude this session.
Thank you so much, sir.
Thank you.
Thank
Dr.
you,
Shipriya?
Dr. Arvind.
Yeah. So
Yes,
it's
sir.
lunchtime right now.
Yeah. Yeah, take lunch break. But before that, I would like to announce that link for the quiz is open now. So students can attempt the quiz and it will be available both on the platform as well as on the WhatsApp group. And thank you so much, Dr. Arvind and Dr. Sujali. Wonderful, fantastic presentation. And let's
Thank
take
you,
a
Dr.
break
Shipriya. Thank
for lunch now and resume our session at 2:15 p.m. So you were saying something?
Thank you so much. That's all. That's all. Thank you. And thank you, Dr. Nirja, and
Thank
whole
you.
team of
Thank you.
RML
Thank you.
for organizing.
Thank you.
Thank you.
Our pleasure, sir. Thank you. So we'll take a break and we will resume our session at 2:15 p.m. Thank you so much. Welcome back, everyone. I hope you all had a good lunch and back with alert minds, open charts, and that classic anesthetic focus. So let's resume our session and move forward to post-lunch. Very amazing sessions we have. So let me welcome the chairperson for our next session. Chairpersons for our next session is Dr. Monica Tandana. She is Director, Professor and Head, Department of Anesthesia and Intensive Care at GB Pant Institute of Postgraduate Medical Education and Research, New Delhi. She's been examiner and thesis assessor for DM, DNB, PDF examination in neuroanesthesia and neurocritical care. She has got 16 book chapters and co-editor of a book, more than 16 publications at a credit. She's a section editor in Journal of Neuroanesthesia and Critical Care and reviewer of Indian Journal of Neurosurgery. She's member of Education Committee, ISNAC. Her areas of interest are neuroanesthesia and neurocritical care. I welcome you, ma'am.
Thank you so much for the kind introduction.
And our next chairperson for this session is Dr. Pragati Ganju. She's Director Professor, Neuroanesthesia, Department of Anesthesia and Intensive Care at GB Pant Institute of Postgraduate Medical Education and Research, New Delhi. Her achievement, she's President of Indian Society of Neuroanesthesia and Critical Care. And she has got Lifetime Achievement Award of Delhi Neurological Association. Her areas of interest is neuroanesthesia and neurocritical care. I welcome you, ma'am. So I would like to ask Dr. Monica, ma'am, to go ahead with our next session. And please introduce our speaker.
Thank you so much. The first talk for today's session, exclusive neuroanesthesia session, is on intracranial aneurysms. One of the most common pathologies, almost second to intracranial tumors that we get, and the bread and butter of endovascular neurosurgeons now. And now to present this topic, we have a very, very seasoned neuroanesthetist, Dr. Kiran Kiro. Dr. Kiran is a professor in neuroanesthesiology and critical care at GB Pant Hospital. And she has over nearly 2 decades of experience. I think the most apt person to take this talk for you. Over to you, Dr. Kiran.
Can we have Dr. Kiran's presentation, please?
Hello, everyone. I'll be taking a very important topic on neurovascular emergencies, that is the anesthetic considerations for intracranial aneurysm surgeries. What are aneurysms? These are localized dilatation of the artery from the mechanical stress of the turbulent blood flow, which are typically seen at the branching points. And this occurs because the tunica media and tunica adventitia is relatively less in the intracranial arteries. These are responsible for neurovascular emergencies, responding 95% of non-traumatic hemorrhagic stroke occur because of aneurysms. And these usually affect the younger working age group. And despite of so much advances made in the neurosciences till date, these are yet a cause of significant morbidity and mortality and a major burden in the present scenario. Let us see how they can be classified. They can be classified on the basis of location as the anterior circulation aneurysm. As you can see, the anterior circulation aneurysms are more common as compared to posterior circulation. They can involve the anterior communicating artery, the middle cerebral artery, the posterior communicating artery. And the posterior circulation aneurysm, which are relatively less, can be involving the basilar artery or the vertebral artery below. They can also be classified as saccular, fusiform, or dissecting, and even on the basis of size, they can be small, large, or giant. And it has been seen that with increasing age, hyperventilation, positive family history, substance abuse, other risk factors, women are comparatively affected much more than the men, and the risk is 1.24 times higher. There are certain conditions that are frequently found to be associated with cerebral aneurysm, and these are the syndromes that have been included here. A patient with intracranial aneurysm would typically present to you with a history of acute onset severe headache, also called as thunderclap headache, and the patient would give you a typical sentence saying that this was the worst headache of their life. Apart from that, there can be signs and symptoms in the form of nausea, vomiting, photophobia, neck stiffness, hydrocephalus, along with the others. If the clot burden is high, then the patient can have seizures. If the ICP is raised, then the patient can be comatose and they can be hypertensive at the time of presentation. At the same time, the patient can also be having focal deficit and mass effect depending upon the presence of hematoma or a large aneurysm which can lead into plan. So when a patient comes to you with intracranial aneurysm, the typical battery of tests that you have to undertake starts with non-contrast CT. You're looking for the hematoma, hydrocephalus, infarct, whether there are any blood in the cisterns or in the fissures. If the NCCT is inconclusive, you'll have to do a lumbar puncture, which is highly sensitive and often can be observed within 12 hours. Usually, lumbar puncture is not required these days. The NCCT serves the purpose. After that, you have to look for the cerebrovascular anatomy if the NCCT comes positive for SCH. You have to look for the source of bleeding, the aneurysmal details, and for that, you either take up the patient for CT angio, MR angio, or digital subtraction angiography. Among the three modalities, the DSC is said to be the gold standard. I have shared here the CT images of patients with aneurysmal subarachnoid hemorrhage, and as you can see in this particular section, many a times the area of bleed can also help you delineate which particular intracerebral vessel artery is getting involved. Like you can see, there is blood in the sylvian fissure. So as the MCA lies here, this could be an MCA aneurysm. Here you see there is blood in the basal cistern, so this could be a PCOM or a basilar artery aneurysm. There is blood in the interhemispheric fissure, so this could be an ACA or an ACOM aneurysm. Here you see a CT angio image, and over here you can see a MC aneurysm. This is how an MR angio would look, and as you can see, the parent trunk, the dome of the aneurysm, the neck, and how it all would look. This is a typical digital subtraction angiography image, and here you can see this is an MCA, this is the basilar artery, and that is how the cerebral aneurysm looks. Now, whenever we talk about intracranial aneurysm and the presence or absence of SH, the neurosurgeons, neurocritical care, and the neuroanesthesia people will always communicate about the grading of the SH. And the purpose of this grading is that it helps you to accurately prognosticate, helps you to accurately share the information about the patient's clinical status. It will help you in decision making. And the common scores that we use are the Hunt and Hess grade, the WFNS, and the Fisher grade. The scoring has been designed in a manner that as the grade increases, the neurological status, the patient's clinical condition, the bleed and all are also increasing. So it has been observed that with good pre-intervention neurological status and minimal intracranial background imaging, a patient would be classified into the low grade, and when a patient is having low grade, the outcome is found to be better. So in short, lower the grade, better the outcome. So first among these the scoring systems we commonly use is the modified Hunt and Hess grade. This is a clinical grading. Now comes your WFNS grading, which involves the Glasgow coma and the motor deficit based grading. Another is your Fisher grading, which talks about the presence or absence of blood in the CT scan. And the value of Fisher grade is such that it will help you in assessing the risk of vasospasm and delayed ischemic neurological deficit. Now, this is how a Fisher grading typically looks. Here you can see no bleed, so this is grade 1. This was minimal bleed, so this is grade 2. More than 1 millimeter thickness, grade 3. Bleed into the intraparenchyma, into ventricles, so this is grade 4. The complications associated with subarachnoid hemorrhage can be divided as intracranial and systemic complications. Intracranial can be rebleeding, vasospasm, hydrocephalus. Hematoma can expand, lead to rise in ICP. The patient can have seizures. Systemic can be the form of MI, arrhythmia, pulmonary edema, electrolyte imbalance can be there, gastric hemorrhage, or renal dysfunction. The highlighted ones are the ones which are specific to intracranial subarachnoid hemorrhage. So these are the ones I'll be particularly drilling. First is your vasospasm. This is observed within 3 to 21 days of the acute phase and most common cause of death in severe disability. Pathophysiology would be that it has been observed that blood and its breakdown products enter the intracranial arterial wall, causing vasoconstriction. There are various inflammatory markers that are involved, microthrombosis are occurring. Along with that, there is an entity called cortical spreading depolarizer that is also implicated in the pathophysiology of vasospasm. When we talk about vasospasm, you need to know that there are three entities we talk about. There could be clinical vasospasm, which is patient would be having confusion, decreased level of consciousness, or focal neurological deficit. A patient can also, then another term is radiographic vasospasm, wherein there would be arterial narrowing, there would be decreased blood flow, and often along with that, which is observed in the cerebral angiography images. Then the third term we use is symptomatic vasospasm, wherein the clinical vasospasm corresponds to the region of vasospasm seen in angiography, and these are the ones that are our target area. These are ones that would require aggressive management. For diagnosis, you would the tools available to you, of course, the clinical, the TSA, and then the transcranial Doppler. This is a very handy tool that we routinely use in a neurocritical care setup, and this helps us in identifying the vasospasm. Along with that, other modalities are also there. For management, first and foremost, you have to rule out the other causes which can present in this manner. And as per the recent guidelines, it is recommended that maintain euvolemia, normal circulating blood volume. Nowadays, there is no role of triple H therapy, and then the best treatment frequently advised, the most popular treatment over here for vasospasm is nimodipine 60 milligram administered 4 times a day to all patients of aneurysmal SCH for 21 days from the day of hemorrhage. This is on the basis of BAM trial, and this is the only high-level evidence available to us when it comes to management of aneurysmal subarachnoid hemorrhage patients. Other complications would be cardiac involvement. The patient usually after an SH can have a sudden catecholamine surge. This leads to an increase in systemic and pulmonary blood pressure, resulting in neurogenic stunned myocardium. The patient would have sudden chest pain, dyspnea, hypoxemia, and many a times such patients land up into cardiology emergency. And on investigation, it is observed that the cardiac enzymes levels are elevated, but they are much less as compared to the patient having a typical classical MI. So if you do a CT scan for these patients, they will help to identify that okay, these are not typical MI cases; these are actually an SCH case occurring because of an aneurysmal rupture, which has led to increased catecholamine surge and the cardiac sequelae occurring because of that. ECG changes are also observed, and at times the patient can have dilated cardiomyopathy, and the typical cardiomyopathy, Takotsubo cardiomyopathy, is seen where there is apical sparing. Management of these patients involves supportive. You have to maintain euvolemia. Catecholamine support has to be continued till the patient's condition improves. Then, along with that, the pulmonary complications can also occur because of catecholamine surge, metabolic and pituitary complications. For treatment, remember that ruptured aneurysm should be treated as early as possible, preferably within 24 hours of onset. And for that, the patient can either be taken for an intracranial, can be undertaken for craniotomy and clipping, wherein the clip is applied at the neck of the aneurysm and it is obliterated, or an endovascular route can be used, wherein coil is filled into the aneurysm to block it, or maybe if the neck is wide, then the neurosurgeon or neurointerventionist would like to fill the aneurysm with coil and put a stent, or probably another modality is they can use a flow diver. This is how all they do the definitive treatment of aneurysms, intracranial aneurysms. How do they differ? Now, if a patient has to go craniotomy and aneurysmal clipping, the benefits are that they would cause almost complete occlusion of the neck and simultaneous removal of any tumor that is present. These are relatively less costly. Large lesions, if a patient is young, they are having concurrent hematoma. Of course, they would removal of hematoma would help you in possibly decreasing the incidence or the likelihood of patient going into vasospasm. Then MC aneurysms, they are relatively superficial lesions, easy to locate and clip. So MCA are preferred, surgeons usually prefer to do a clipping rather than coiling. And endovascular aneurysmal coiling is preferred in elderly patients, those who are having comorbidity. Nowadays, the high-income countries are shifting more and more towards the coiling procedures. PC aneurysms, the posterior circulation aneurysms, typically have to be undertaken, managed through endovascular coiling. The benefit of this particular technique is that it is less invasive, they are quicker, the recovery time is faster. So now we have talked about what these lesions are, how they present, how to diagnose. Now let us see how we manage these patients when they come to us for surgery. Of course, the clinical history has to be taken, the routine investigations have to be taken, and after that, the definitive ones are that you have to look at the CT scan, then the cerebral angiography to look at the aneurysm details. If required, you have to do an echocardiography as well. In the pre-op, all preoperative medications have to be continued. Nimodipine has to be continued. Antihypertensive drugs as standard. If the patient is having a good grade aneurysm, you can even think of giving a mild anxiolytic. Patient who has to undergo interventional radiology procedure and coiling has to be started on anticoagulants as per guidelines. The goals of anesthetic goals for these patients are that you have to avoid aneurysm rupture, prevent any rapid fluctuation in intracranial pressure, maintain CPP and cerebral oxygenation, which is standard, reduce the brain bulk, provide neuroprotection, give a rapid and smooth emergence, and facilitate neurological examination whenever feasible. Now, there are two important terms I would like you to remember, that is the transmural pressure and the cerebral perfusion pressure. These are derived from the same variables but represent opposite physiological rules. You know what is CPP? Transmural pressure is the pressure within the aneurysm. So remember that if a patient is having an unruptured aneurysm or is a good grade aneurysm, then ICP is often normal. And if you cause a rise in mean arterial pressure, this would lead to rise in transmural pressure. Then there is a risk of rupture or a re-rupture of the aneurysm. And if the patient is having a poor grade aneurysm with an intracranial hypertension, then obviously you want the cerebral perfusion pressure to be maintained at any cost. So herein you would want the mean arterial pressure to be maintained so that there is adequacy of cerebral perfusion pressure. That means when it comes to TM, good grade aneurysm, you do not want the transmural pressure to rise, so you do not want a rise in the mean arterial pressure. Whereas in a case of poor grade aneurysm, you want the cerebral perfusion pressure to be maintained, so you do not want the mean arterial pressure to fall. So in case of unruptured aneurysm, aim for systolic blood pressure less than or equal to the patient's normal systolic blood pressure. In case of ruptured aneurysm with suspected or known intracranial hypertension, avoid treating passive hypertension. If the patient is having very high blood pressure, then probably a gradual reduction in blood pressure has to be considered. Remember, there is no rule of permissive hypertension in endovascular surgeries. Along with that, judicious dose of opioids. Of course, you do not want the BP to rise and fall. So accordingly, you have to titrate your drugs. Blunt your noxious stimuli, laryngoscopy, pin fixation, they have to be taken care of. And CO2 management principles, remember, avoid hypercapnia, avoid hypercap. Among the choice of drugs, I would say both can be used, but Tiva is often considered ideal because of its superior cerebrovascular hemodynamics. It minimally interferes with the intraoperative neurophysiological monitoring, and it is a more efficient modality when it comes to burst suppression. You have to prevent hyperglycemia, hypohypothermia, as well as dyselectrolysis. Brain relaxation techniques are standard as usual. Let us see what should be your anesthesia management protocol. Among the monitoring techniques, the mandatory ones are the standard. You can also go for ICP monitoring, depending upon the patient's condition, CVP monitoring, depth of anesthesia monitoring. For titration, you can use bisentropy, and IUNM if the surgeon is asking. For induction, if the patient is stable, you go for hemodynamically stable, you go for propofol and thiopurine. If the patient is hemodynamically unstable, then etomidate is your choice. Narcotics, fentanyl, boluses is what we usually prefer. Among the neuromuscular blocking drugs, any of the intermediate acting, non-depolarizing, But in case of emergency cases, RSI, rocuronium or succinylcholine may be considered. For maintenance, if the ICP is high, there is large amount of hemorrhage, TIVA with propofol narcotics injection. And if the ICP is normal, volatile or TIVA, either of the two can be considered. Again, when it comes to ventilation, good grade aneurysm, PaCO2 target is 30 to 32 mm of mercury. Poor grade aneurysm, moderate hyperventilation as a temporal measure may be considered. Intravenous fluids are standard. In case of tracheotomy and in the case of tracheotomy and aneurysm clipping procedures, there is a step called temporary clipping. Temporary clipping is often applied on the proximal to the aneurysm to facilitate dissection, approach the area of interest and make the aneurysm slack. And many a times it is done to also control the bleeding if the aneurysm ruptures. Now, whenever temporary clipping is applied, the patient runs a risk of ischemia in the concerned arterial territory. Usually, the safe duration recommended is around 10 minutes. However, if there is a requirement of a longer duration of temporary clipping, then the patient is at high risk of ischemia and infarction. So, whenever you're instituting a longer clipping time, you have to use for neuroprotective measures like barbiturate, citomidate, mannitol, antioxidants. But remember, the recent guidelines also say that the conclusive evidence is not there, and studies at present are showing conflicting results. Many a times, if the anatomy of the aneurysm is precarious, the surgeon is not able to apply the temporary clip, then they do ask you for flow arrest, which is a transient profound hypotension, and this is done by administration of adenosine inhibitors. Then during the surgery, aneurysm can rupture, can be pre-dissection, many times at the time of intubation. However, we haven't yet seen such a scenario. They can be during dissection or clip application, incidence risk ratio lying almost similar. If there is a small leak, then probably a transient hypertension will be helpful in controlling the bleeding as it provides a bloodless feel to the surgeon. But if there is a forthright rupture, then the target would depend upon what the hemodynamic status of the patient is at that point of time. The patient is hemodynamically stable, has good reserve, and then probably a short duration of hypotension or a flow arrest can be given to facilitate the surgery. However, once the patient becomes hemodynamically unstable, then the patient is hypovolemic, then your target becomes the cerebral perfusion pressure. Patient has to be resuscitated, so ensure that your cerebral perfusion pressure is being maintained at all times. In the post-op period, remember, when it comes to a good grade SAH, aneurysmal SAH, and there has been uneventful intraoperative course, you can consider on-table extubation, but avoid any cuffing, bucking on the ET tube, avoid blood pressure fluctuations. If the patient is having poor grade SAH or intraoperatively there have been significant hemodynamic events, then probably you may consider giving patient to undertake for elective ventilation. During this time, vital charting, blood sugar, electrolyte management, these are standard. Start nimodipine, and prophylactic antibiotics and anti-seizure measures have to be given. Neuromonitoring, CT scan has to be done in the post-op, TCD monitoring again to look for vasospasm and its resolution. If the patient develops cerebral vasospasm, invasive blood pressure monitoring has to be done, fluid status monitoring, titration of fluid, use of vasopressors to maintain the blood pressure. The patient develop systemic sequelae, as I had mentioned earlier, then you have to watch these patients and manage accordingly. Appropriate corrective measures has to be taken. Surgeon should be informed if there is any surgical intervention required, like hydrocephalus develops in such scenario. Now let's look at another technique when it comes to aneurysmal subarachnoid hemorrhage. The other modality, as I previously mentioned, is the endovascular pointing. These are undertaken in neuroradiology suits, and they have their own set of unique challenges for an anesthesiologist because they are away from your ICU, they are at a place distant from your OT settings. The help is usually far off, and then you might not have the optimal arrangement of your machines, your drugs, and so you need to be ready beforehand. You need to have your backup plan ready. The goals of anesthesia over here are a little different. You would want to have a safe transportation of the patient. You would also have to maintain immobility. You need to remember that these patients have to give an anticoagulants with the endovascular procedures. Then you have to be ready with a backup plan for management of intracranial catastrophes. And many times the surgeon would ask you to, reverse the patient immediately so that they're able to evaluate the patient. So a rapid recovery plan has to be made, and because these are interventional procedures, you're doing it under radiation exposure, so protection has to be kept for yourself as well as for the patient in this regard. If the patient is having a good grade aneurysm or an unruptured aneurysm, or it is just a diagnostic DNA, a sedation is safe and feasible option. However, if the patient is having a poor grade aneurysm or the patient is uncooperative, irritable, then in those scenarios, you would prefer the general anesthesia. Choice of anesthesia, the basic principles are same as your clipping procedures. Standard ASA monitoring, and along with that, you would also need to have an invasive arterial blood pressure monitoring by putting a radial artery cannulation, or probably you can take a side port from the femoral sheath that has been introduced by the neurointerventionist, and you need to do a beat-to-beat monitoring of the blood pressure. All noxious stimuli have to be removed, and just remember one important thing, that the surgeon might say, the person doing the procedure would say that this is a small DSA procedure, or I just need to look and I'll come out, so I don't need to catheterize the patient. But many a times these do continue for a long duration of, and the patient is flushed with a lot of fluids. So urinary catheterization is an important thing that you have to remember in these patients. The procedures that usually are undertaken are, as I said, DSA, coiling, then they try to look for vasospasm and intraarterial therapy for vasospasm. Preoperative workup is same, but along with that, remember that you need to take the history of allergy to contrast media, history of protamine. The patient will be exposed to protamine, so need to find out if the patient is having allergy to shellfish, if the patient has taken antiplatelet therapy, which would be required for stent or flow diverter placement. Then, as I said, radiation exposure is there, so you need to wear lead aprons, thyroid shields have to be worn. If the patient is, pregnancy has to be excluded in women of the childbearing age. If such a situation is there, then shield has to be applied. Adequate measures have to be taken to prevent hypothermia. This is how a typical neurointervention suit looks like. The complications observed in these patients can be rupture of aneurysm, thromboembolism, coil migration. So your important steps to remember in such a catastrophe is that you immediately call for assistance, communicate with the neuroradiologist, secure the airway, hyperventilate the patient, and determine whether the problem is hemorrhagic or occlusive. If the patient is hemorrhagic, having a hemorrhagic complication, this would be seen in the DSA screen in the form of contrast extravasation from the vessel, the fluoroscopy image. If the patient is conscious, he might complain of sudden headache, nausea, and vomiting. In case of anesthetized patient, what you would see is sudden bradycardia and hypertension. So management is arterial pressure should be controlled immediately by deepening anesthesia and by use of antihypertensive like labetalol. Heparin should be reversed with protamine. Patients on antiplatelet drugs require platelet transfusion for reversal, and consider CT and EVD placement if there is a risk of hydrocephalus, or probably the ICP is rising because of the large amount of blood extravasation. Next complication is your occlusive complication arising because of arterial thrombosis, emboli, vasospasm, misplaced catheter or coils. Management is increase the collateral flow by increasing the blood pressure by 30 to 40% from the baseline. IV aspirin. Then the misplaced catheter or coil has to be removed after thrombectomy, followed by thrombectomy if indicated. The standard measures of head up, hyperventilation, mannitol, and if this does not help, probably a surgery may be planned. So I would like to summarize this by saying that critical aspects of cerebral aneurysm surgery are important for neuroanesthetists or anybody who's managing the patient. All the anesthetists who are managing these patients, we are supposed to know what are the critical aspects of management of these patients, which include maintenance of cerebral perfusion pressure and preventing rebleeding of aneurysm. You need to stabilize the life-threatening conditions patient has to. You need to identify first what are the causes which can lead to life-threatening complications, minimize neurological injury, obliterate the aneurysm. For obliteration of aneurysm, you can use either clipping or endovascular coiling. And for post-operative care, besides the standard post-operative measures that you take, you have to specifically target your management towards identification of vasospasm, aggressive management of symptomatic vasospasm, or delayed skin. Thank you so much.
Yeah, thank you so much, Dr. Kiran. That was a very lucid, comprehensive presentation, tailored to the need of exam-going postgraduate students. Otherwise, this can be a discussion that can go on for hours together. It's this thing, but I think it was beautifully summed up for the EGPG students. Do we have any questions in the chat box? No.
No, ma'am, not yet.
No. I think then I think we have exceeded our time. I will hand over to the next chairperson, Dr. Pragati Banju. Thank you so much for having me over.
Thank you, ma'am.
Hello, friends. We'll be moving on to the next lecture now, and that's on anesthetic implications for posterior fossa surgery. Now, before we start this, we need to know why the management has picked up this topic. You know, there's so many topics in neurosurgery and neuroanesthesia, but like the vascular lesions, posterior fossa lesions are extremely challenging for both the neurosurgeon and the anesthetist because of its location. Number one, it's in the close to the brainstem, you know, so the word brainstem makes you nervous, you know, and you know that you have to put in extra efforts for your anesthesia, like the surgeons have to do it very meticulously. Second thing is that it often occurs in children. So the challenges of pediatric anesthesia, very small children also come out with the posterior fossa tumors, big tumors, which are attached to the brainstem. So pediatric challenges also add on to it. And the third most important challenge is because they are adherent to the brainstem, the surgeons may not be able to take it out, the entire thing, or they may manipulate close to the brainstem. So the extended ICU period also comes in the domain of the neuroanesthetist or any anesthetist for that matter. I would like to tell the residents, when you move out into bigger hospitals, you'll be posted in the ICUs where the anesthesia is done, but the implications of this surgery and anesthesia continue in the ICU. So all these three aspects makes it extremely challenging, and I think it's important for you guys to get apprised of this very, very important condition right away when you are doing your post-graduation. So now I'll call upon the next speaker, Dr. Anupama. May I have her CV, please? Dr. Anupama Gil Sharma. Yeah. So Professor Anupama is a professor at RML Hospital, and I believe, though I haven't met you personally, or maybe, but I don't know if I think you are working full time in neuro anesthesia, yeah. And your achievements are ATLS, BCLS, CCLS instructor. You're a DNB examiner in critical care, which is an important component of this talk. And you have various publications in national and international journal, and you are interested in critical care, difficult airway, and regional blocks. So over to you, Anupama, and let's have a very good lecture on this very, very challenging topic.
Thank you. I welcome on behalf of the Appec 2025. I'm fortunate to have been given this topic, which is a very important topic for the postgraduates to learn. And many of the questions are coming from posterior fossa surgeries, and I'm lucky to have got this topic. And it is not only the postgraduates who are benefiting from the program. We are also time and again get to revise our topics. So without wasting further time, I would like to continue with my talk. This anatomy of the lung is the one which of the skull is in the anterior fossa, middle fossa, and posterior fossa. So of importance here is that there is the posterior fossa is a rigid compartment in which there is tightly, compactly placed structures are there, because the compression of which there can be sort of signs and symptoms come early. There's a lesion in the posterior fossa. So here you can see a posterior fossa tumor seen or a radiological image, and here on the diagrammatic image on the right. So the brainstem, cerebellum, all these are there in the posterior fossa. It is a small rigid compartment. It is a deeply seated fossa. And the contents of the fossa are the midbrain, pons, medulla, cerebellum, fourth ventricle, and important cranial nerves from cranial nerve 3rd to cranial nerve 12. Anatomical considerations are the vascular lesions or the tumors which arise from this needs to be decompressed. They are important cranial nerves and the structures which are vital for control of airway and CVS in the brainstem. And they are all contained with a small space in the posterior fossa. Hydrocephalus from obstruction of the ventricular outflow is a common cause of increasing in the ICP. So these are the boundaries of the posterior fossa. Anteriorly, as you can see, there is a dorsum cellular basilar portion of the occipital bone, which is there. Laterally is the temporal bone, the mastoid and the petrosal compartment. Superiorly is the dura mater or the tentorium cerebelli, and posterior inferiorly is the occipital bone. The foramen magnum is the largest opening in the posterior fossa, and through which the important brainstem and other important vascular structures and nerves arise. So any kind of tumor or swelling in this area would lead to a major hemodynamic compromise and cranial nerve compression symptoms to the patient. So the various lesions can be of various types. It can be neoplastic, vascular lesions like aneurysms and AV malformations, developmental abnormalities, including the CVJ abnormalities, or cavernous malformations, or hematomas, which can be traumatic, spontaneous, or various kind of infections. In adults, the metastasis is common, or it can also be a region for the primary tumor, like a meningioma or a facial nerve schwannoma, or a clavial tumor, or a arachnoid tumor. Aneurysms and hematomas can also rise from this area. Pediatric population, most of the tumors which are there in children arise, and 2/3 of them are in the posterior fossa, and it can be a malignant or non-malignant. It can be gastrocytoma, medulloblastoma, or choroid plexus gliomas. AP malformations and Arnold-Chiari malformations can also be there. So the symptoms with which a typical neurosurgery patient of tumor present, and specifically in the posterior fossa, they present early as compared to other tumors, because the compression symptoms come early. Earlier symptoms can be non-specific, and then it can progress to headache and vomiting, and balance and coordination problems like difficult walking, unsteady gait, and clumsiness. There can be problems with the vision, hearing, facial expression because of the various cranial nerves which are involved in this particular segment. There is a drowsiness, nystagmus, seizures. So as I said, there's non-specific symptoms initially, listlessness, headache. And when these don't go away with the conventional measures, is the time when the patient seeks the medical help, and then on neurological investigations, it is diagnosed usually. And the hydrocephalus, which is secondary to the obstruction of the CSF flow in the aqueduct in the sylvius points, leads to the diagnosis. Truncal ataxia, wide-based gait are common. Now we come on to the part which is more relevant for us as an anesthesiologist. So the various positions are the ones which are also asked in the exams, and it is also a very important topic to learn practically. So because these are not the normal positions in which we cater the patient to in the surgery, the position can be supine, prone, lateral, semilateral, or sitting. There is various aids or supports which help us to attain these positions. So a pin head holder, a radiolucent pin head hold, horseshoe shapes headrest, Wilson type frame, or a Relton Hall frames are the ones which the support system that we use to attain these positions. The supine position is the one which we are all very used to, very comfortable with. So very limited number of tumors can be operated in this particular position. And here, only the patient is in the supine position. Only the head is turned to the contralateral side. to provide access to the surgeon. A roll or a pad is placed below the ipsilateral shoulder so that the brachial plexus on that side is not stretched. Head is elevated to facilitate the venous drainage. There is easy position and respiratory and serious physiology is maintained. So here you can see the patient is supine with the head tilted to the contralateral side. One should avoid extreme rotation of the neck because then the jugular vein would be compressed and would hamper the venous drainage, and the advantage of head elevation would be lost. Also, thinking of the endotracheal fluid can occur, and so anything more than 90 degrees should be avoided. All the pressure points, elbow, wrist, and heel, these are the pressure points in the supine position. You can see the elbows, iliculon, thoracic coccyx, sacrum, and scapula, calcaneum. All these should be well supported, as we generally also do. Next important position is the prone position. Prone position is the one which gives a very good access to the surgeons if they're operating on the fourth ventricle or a CV junction tumor or spinal structures. And with the help of the gravity, it is good for us also because all these secretions are blood secretion or they do out of the airway. So at least that aspect is taken care of. But it is good for good blood and CSF drainage also, reduce venous congestion for surgeons. And the incidence of air embolism is fairly less as compared to the sitting position or the park bench position. And as you all know, in refractory hypoxemia also we use the prone position, so improved VQ mismatch here. So patient gets a better ventilation here. How to attend in position after secure induction, the patient is made to be. So one thing is we need a good trained personnel to attain these positions, because any kind of little bit of not handling the airway or not handling the cervical spine or the wounds properly can lead to catastrophic event in the patient. So the patient is placed head down, face down, and one can use a Mayfield head clamp or a prone headrest. A horseshoe-shaped headrest can be used for children who are less than 3 years. More than 3 years, a Mayfield pin head clamp can be used, but that is all surgeon's preference. The arms are padded in position by the side or tucked on the arm holes. Chest and pelvis are supported with the bolster so that the abdominal areas and the respiration is free. Eyes, nose, and airway are carefully padded. Airway stick is very nicely secured. These are the various frames that we use. So you can see on the left side is the Mayfield pin system, and on the right side is the horseshoe-shaped support which is used for the in the prone position. And from the center, the tube comes out, and it's a nice foam which can support the supraorbital region, and the secretions are rolling down. And lower down, you can see the Delton Hall frame which supports the abdomen and the thorax so that the abdomen is free for the and is not compressed. And these are the various pressure points which should be taken care of. So you can see clavicle, shoulder in the females. The breast region is also should be padded. Elbows and anterior pelvic bones, knee, patella, all these should be well padded and taken care of. And DVT pumps can be put. The disadvantages of prone position are also there. One very important disadvantage is that our access to the airway is difficult, and in the case of emergency, it is not a position in which we will be able to secure the airway. So it takes some time to make the patient supine or lateral. And also for surgeons, if the patient has a difficult stiffness in the neck, so they should check the patient in the pre-op position, the pre-op, so that whether the access to the area that they're going to operate will be there in the prone position also. So one has to look at the neck movements or the stiffness in the preoperative time, and how much of, or the patient may be having some cervical disorder or a cervical spondylosis, that so he can end up into having a cervical more damage to the spinal cord. So one should carefully choose this position if it is there. And there are a lot of reports of ophthalmic eye injuries in terms of ischemic optic neuropathy, central retinal artery occlusion. If these areas in the eye are not padded properly, supraorbital neuropraxia, permanent and temporary ophthalmoplegia can occur. So there are direct pressure injuries and then indirect pressure injuries. When there are indirect pressure injuries, could be because of the venous pooling or the fluid accumulation in the dependent area. So that can lead to macroglossia and the oropharyngeal swelling. Then there is mediastinal compression can add to severe hypotension because of the compression of the right ventricle. So because of the prone position of the patient, there can also be visceral ischemia to the organs underlying. So there can be hepatic ischemia, and then there can be limb compartment syndrome of the limbs and the abdominalis. And this is the most, as I have already discussed, this is a difficult position for us, just in case we end up handling the airway for some reason. The disadvantages of prone position are also because of the direct pressure injuries that it has on the structures which are bearing the pressure. The skin necrosis can occur at ears, breasts, and other dependent areas. There can be contact dermatitis. There can be tracheal compression if the padding is not done adequately. There can be salivary gland swelling, shoulder dislocation, and other airway issues. So here you can see that a patient, when he is made from supine to prone, one has to give importance to the pressure points and the chest and the pelvis. So in the intermammary line, the bolster is placed, another one is placed at the level of the pubic bones, so that the abdomen at the level of navel is free, and the intrathoracic and intra-abdominal pressures do not hamper the venous drainage and do not add up to the ischemia of the visceral organs and do not increase the intrathoracic pressures or peak airway pressures, and the ventilation is not halted. And similarly, the eye should be supported, the head should be supported so that there is no ischemic optic neuropathy or blindness in the forehead. Physiologically, as we have already discussed, it is a good position respiratory-wise because it improves your lung mechanics. There's a better ventilation perfusion mismatch, better lung mechanics, less atelectasis. It can lead to some amount of increased cardiac output. So if there's a patient who is an elderly patient with the probably congestive heart failure or a diastolic dysfunction, this position can add some amount of stress to the heart, can increase the cardiac output. There's a possible reduction in RV afterload, increasing the venous return, increasing the CVP. So one should take all these physiologies of the patient, age of the patient also into account when choosing a prone position. Here you can see that if the bolsters are not properly padded, then the intra-abdominal pressure, intrathoracic pressure can increase. Some amount is definitely increased because of the position itself, but we can avoid the precipitous increase and they transmit to the sacral venous plexus and the vertebral venous plexus, and because of which can be congestion in the jugular vein. So the advantage of head-up position venous drainage can be lost, and it can flood up the surgical area also, and increase lot of blood loss is also one thing which has to be very careful in posterior fossa surgeries. So good amount of blood cross-match should also be made available. So this is the importance of the position for both surgeon side and anesthesia side. Another important position is sitting position. This is one of the positions which most of us are dreaded because of the complications that can land us up to. Very important is venous air embolism. We'll shortly discuss about it. So here the patient is made to sit up in the sitting position. Head is supported with the pins, and one has to know that this position should be made gradually with a good amount of personnel who are expert in getting this position. So once the patient is made supine, and then gradually he is made to get into a sitting position, securing the endotracheal tube, the connections, the electrodes, the monitoring, the IV lines, the catheters, all these should be supported. The knees should not be very much flat so that they do not hamper the abdominal compression should not happen. The sciatic nerve should not be compressed in the posterior. So this position is used for deep-rooted midline structures of posteriorly third and fourth ventricles or supracervicular space occupying lesions, CP angle tumors and pineal gland tumors. So patient head is secured in a 3-pin head holder. Legs, thigh-high compression stockings can be used. They would facilitate in venous drainage also, and they would decrease the risk of DVT. Avoid excess flexion of the knees towards the chest so that there is no hampering of the respiration and no stretch on the sciatic nerve. Elbows are supported by the pillows or the pads. 1-inch space should be maintained between the chin and the chest so that extreme flexion of the cervical spine posteriorly is avoided, and there are less chances of dislodgement of the endotracheal tube also. Avoid a large area of bite block placement that could add to pectoglossia and the post-op. Excessive neck rotation should be avoided. All the bony prominences should be padded. Our legs should be freed of pressure at the level of common perineal nerve, that is lateral to the head of the fibula. Various advantages are also there. One is for the surgeon, very good surgical exposure for them. And for us, we have a good visual monitoring and access to the airway, face, and extremities, and a visual observation of the motor responses of the cranial nerves can also be there. So that way, that is good. The airway pressures are lower as compared to prone position. Ventilation is good, and we have a good access to the invasive lines also. So the visual access to the airway and other monitoring device for us is good. But more important is the disadvantage of the venous air embolism risk is the highest in position. So it can go up to 40 to 45% patients increase as compared to a supine position or a lateral position. There are increased chances of pneumoencephalus, that is the air entrapped into the cranial cavity. There is a potential for hemodynamic instability because of various reasons, blood loss, embolism, tube can get dislodged. Sciatic nerve injury, facial swelling, tongue swelling if the neck is hyperextended or is hyperflexed or rotated, and there can be a damage to the cervical spine and causing quadriplegia just because of the position itself. So one needs to be very careful. Physiologically, there is an increase in the vascular resistance and SVR, decrease in the cardiac output and venous return. Dysrhythmias can occur in elderly patients and patients who have a altered cardiac status, where there is a low EF or who are CAD patients. One should be very careful in making them sitting, and it should be attained in a gradual manner, not rapidly. And adequate time should be given to monitor and stabilize the patient and before handing it over to the surgeon. Hypovolemia is more as compared here because of the decreased perfusion of the upper lung. So not as good as a prone position. But although the incidence of post-pulmonary complications are less, absolute contraindication here would be a right to left shunt, because then the venous air embolism would be devastating. Ventricular ejaculation, or a patient who already has a severe ischemia, and because of the sitting position where the gradient between the heart and the brain is high, the chances of severe ischemia, venous air embolism are high. Patent foramen ovale, right to left heart shunt, uncontrolled hypertension, cachexic patients, severe autonomic neuropathy, which can add to the hemodynamic instability because of the surgery itself. These are some of the relative contraindications. Then we come to the next position, which is also very much discussed in the exam, and you can get it as a question also, the park bench position. In this, it is a slight modification of the lateral position. So here, as you can see, there is a 10 to 15 degree elevation from the lateral position. And here the head is flexed until the chin is about 1 centimeter from the sternum and rotated contralaterally to the side of the lesion, and flexed 30 degree laterally towards the contralateral shoulder, so as to increase the angle between the atlas and the foramen magnum. The shoulder contralateral to the lesion is supported by the roll in the axilla, as you can see here. And there is the ipsilateral shoulder is rolled forward and it is pulled down with the tape. The pendant arm is also held in a place with the help of a sling in the Mayfield attachment. As you can see, the shoulder tape is stretching the shoulder down so that it doesn't come in the way of the surgery also, and gives a good position to the patient. And just the brachial plexus should not be stretched here. Adequate rolls should be placed between the legs, the pillow is put, and the various pressure points are also adequately taped. Advantage of this position is a good surgical access to posterior fossa. It's a standard approach for CP angle tumor. Modified park benches when the elevation is 30 degree, because it can decrease the risk, reducing the risk of venous air embolism. It can be used for both lateral and midline lesions, allowing rapid positioning and access to more axial structures. The disadvantages of the park bench position is the risk of the brachial plexus injury is still there. As you can see here, the park bench position, so there is a gradient between the mean arterial pressure and the pressure at the level of the brain and the heart. So this can add to the venous embolism. So one should be very careful in maintaining this position and very vigilant during the surgery. Lateral position can again have a risk of brachial plexus injury, and there is tracheal tube can get kinked in this way. Then we have the lateral position. The advantage here is the approach. It has a good approach to the temporal. The risk of brachial plexus injury, eye injury, suprascapular nerve injury is still there. Potential pressure points in lateral position can be scapular, ribs, iliac crest, greater trochanter, lateral knee, lateral malleolus, and medial malleolus. Various advantages that we have already discussed. These advantages can be peripheral nerve injuries and ventilation perfusion mismatch. Now we move on to the special considerations. One of them most important is the venous air embolism, paradoxical air embolism, and brainstem manipulation. Venous air embolism occurs because of the side position of the sinuses which is there. The confluence of the sinuses, they get confluence. Confluence occurs in the left and right sigmoid sinus, and they eventually drain into the internal jugular veins, which lead the posterior fossa. When pressure within an open vessel where the surgeon is operating becomes subatmospheric, it can lead to venous nerve embolism. Incidence is less than 12%, can go up to 76% in sitting position when the surgical site is above the heart. When the vessels open and they cannot collapse, major sinuses like bridging and epidural veins can lead to venous air embolism. So it can be massive or it can be a slow entrainment of the air vessels, of the air bubbles. More common is a slow entrainment of air. Very important for the postgraduates to know that the vascular obstruction which occurs in the embolism causes an increase in the dead space ventilation. So what we will see on the monitor is a rapid decrease in the end-tidal carbon dioxide. But simultaneously, there is an increase in the CO2 tension. Both of these features are because of venous air embolism. So CO2 would drop down, but there is an increase in the CO2. EtCO2 would drop down, but PCO2 on the arterial sample would be increased. Why this is happening? Because there is a obstruction to the right ventricular outflow tract, and that would lead to an increase in the dead space ventilation. Okay. So the pulmonary outflow is obstructed by the embolism. So there is also hypoxemia. So there can be, in children, it is of more devastating as compared to adults. So there can be fast entrainment or slow entrainment. Fast entrainment would cause the vortex of air to land up between the SVC, RA, RV, causing severe impediment of the heart, causing cardiac arrest also, rapid decrease in cardiac output and BP. But more common is a stream of small air bubbles which slowly lodge themselves into the pulmonary capillaries and causing a functional decrease into the total amount of capillary blood in the lung, increasing the pulmonary artery pressure and CVP, and increasing the alveolar dead space ventilation, ultimately leading to right ventricular failure and hemodynamic instability. Sensitivity-wise, transesophageal has the highest. Echo has the highest sensitivity, but it may not be possible for us to all the time use it. If you have it and you are expert in it, one should use it. We more commonly rely on end-tidal carbon dioxide, which has a moderate sensitivity. This is a echo of the venous air embolism. You can see the massive air bubble in the center. Prevention of venous air embolism is by using the Trendelenburg position, leg elevation, minimized so that the gradient between the surgical field and right heart is minimized. The hydration should be just adequate, not overhydrated, not underhydrated. And treatment is to prevent the further air entrainment. We should ask the surgeon to stop and compress the jugular vein so that the further entering of the air is stopped, and change the position, patient position. Make him supine as early as possible. Reduce the gradient between the heart and the brain. Relieve the obstruction. So most of us would have placed a CVP line. So one should try to aspirate the air and in the Durand position if possible. Discontinued nitrous supportive therapy with 100% oxygen inotropic support CPR. This is the Durand position. Not very much possible when the patient is in a sitting position to get him into it. Is a head low right up position with an attempt that the air which is lodged into the right ventricular output tract would disperse into the lower part and would disperse into the bubble. So that the massive hemodynamic instability which is occurring because of the embolism can be taken care of. I have personally witnessed a venous embolism during my PG time, and we were able to save the patient by putting the patient in this position and aspirating. So lucky enough, you can get it, you can save the patient's life. Complications of venous embolism can be delayed also. There can be dysrhythmia, hypercarbia, pulmonary hypertension, persistent pulmonary edema. Paroxysmal air embolism is when the air is moving on from the right side to the left side of the circulation with the help of a patent VSD or a PF, a patent foramen valve. So there is an overwhelming of the pulmonary filter, and if there's a patient who has a PF or a VSD, that can cause this. Even a small amount of air can lead to PA, paroxysmal air embolism. So notify the surgeon, lower the head, aspirate the catheter, discontinue nitrous, give 100% oxygen, and give all the supportive treatment. The vein should be used a correctly placed tubular catheter. If it is there, is the best to aspirate the air, but you can, or the subclavian line also can be used. A multi-orifice catheter should be placed within 2 centimeters of the SVC atrial junction, or if it is a single orifice catheter, 3 centimeters above the SVC. Quickly going on to the anesthetic technique, these are our goals as in neurosurgery: maintain stable intracranial pressure, maintain stable perfusion pressure, do neurophysiological monitoring as needed, pre-op assessment, thorough evaluation of neurological and cardiorespiratory status, evaluate the cranial nerves and cerebellar dysfunction, evaluate the airway. Routine measures for elevated ICP should be taken in the pre-op to decrease, and pre-medication can be given with benzodiazepine 60 minutes prior to surgery. Narcotic to be avoided if the patient has a space occupying lesion in the fourth ventricle. Lab investigations, apart from routine, if the patient is planned for a sitting position to go, may or may not be, may be advised if you have a high suspicion of a VSD or a patent foramen valve in that patient. The most hemodynamic instability occurs at the induction of patient positioning or embolism, or severe bleeding is one which can occur. So good amount of blood product should be reserved. Post-op ventilation also should also be reserved in the pre-op. No one particular technique is superior to other. Nitrous oxide is avoided nowadays, and also because of venous embolism risk. And special care should be given to the positioning and kinking. A suction catheter should be passed freely if there's any obstruction to the tube. Mild hyperventilation is desirable. Artery line should be zeroed at the level of external auditory meatus. Compression stockings can be used. Apart from the intraoperative routine monitoring, one can monitor for the venous embolism by nasopharyngeal stethoscope on a precordial Doppler. Neurological monitoring with EEG, SSCPs, these auditory potential EMGs can be used. Cranial nerve injury is significant. Risk is there in CP angle, so one sometimes can use intraoperative stimulation, direct stimulation of the cranial nerve. So muscle relaxants and those other anesthetics can be altered accordingly. Cardiovascular reflexes can occur intra because surgeon is operating very near to the vital brainstem centers. So more commonly is hypertension with bradycardia because an opening of the dura, poorly irrigating fluid can all cause bradycardia. You can alert the surgeon. Usually it's very temporary by removing the stimulus. It is self-correcting. But if needed, short-acting titrable drugs like glycopyrrolate or atropine can be used in worse cases. All of us want a prompt, smooth emergence without popping up on your patient sometime, but many of the time this is not possible because of the patient condition and the kind of surgery itself. Feasibility of extubation would also depend upon his basic neurological impairment course and how much brain edema risk is there in post-op. Even if sometimes extubation is not planned, quick post-operative neurological evaluation can be done with the tube in situ, and calf nerve blocks can be given for pain management. Delayed awakening can have a lot of reasons. One of them could be pneumoencephalus, or there's an injury to the basilar artery, brainstem compression, or infarction. So it is always wise to have an imaging of the brainstem in the post-op to rule out these complications. Long-term complications patient can become dependent on on the ventilator because of the surgery-induced dysfunction or major cranial nerve dysfunction. Residual difficulty in swallowing, vocalizing can be there. Respiratory pattern can remain erratic for a long time. Facial edema, tongue edema can be there. This is an example of a picture of macroglossia because of the prone position, because of extreme head flexion. So secure the airway, remove the compression, drain the fluid, steroids can be used. The laryngeal nerve can get fancied between the cuff and the tracheal rings if not taken care of. Hypertension is very common in the post-op. Any untoward neurological complication can occur. Also, paradoxical embolism can be taken care with the hyperbaric oxygen. Pneumoencephalus is when the air is retained into the cranial cavity. Usually it resolves on its own, but it can also lead to something like a tension pneumothorax, which can present a tension pneumoencephalus, which can present as a confusion, headache, convulsion. If the patient fails to regain consciousness despite a good surgery, this is one of the differential diagnosis. CT is the investigation of choice. So in the end, to summarize, posterior fossa surgery patients are to be evaluated very well in the pre-op, in the brainstem and cranial nerve dysfunction. The features of ICP perioperatively should be monitored and treated. The patient should be planned according to the position which is proposed by the surgeon, because every position has a lot of implications. Evaluate the risk of venous air embolism and paradoxical air embolism. Posterior fossa tumors can sometimes bleed a lot, so you plan your hydration status and your blood products in advance. Plan for intraoperative central nervous system monitoring as discussed with the surgeon if the patient has a major risk of damage to the cranial nerves or important vital structure near the brainstem. So with this, I conclude my talk. These are my references. I wish you all the best for your exam. I hope I have done justice to the topic. Thank you so much.
Thank you so much, Anupama, for a very detailed and extensive presentation of this very difficult topic. I don't see any questions in the chat box, but I just want to say that
No, ma'am.
there are.
Not-
I tried to see
No,
though.
ma'am.
No, there are no questions here. So just want to add one thing, because we are anyway we exceeded. I mean, we are going a bit late. So I just want to add here for the students that sometimes you may get reverse questions like craniotomy in sitting position. The question would be like that. So you have to associate that they probably, depending on the examiner in their center, whether they're doing prone position or they're doing sitting position. So some, like in our institute, we're doing all cases, most of the cases, I won't say all, in the sitting position. So I would want to know from suppose I'm the examiner, I would like to know about sitting. So please do it and learn the benefits also, and try to go into detail. And there the examiner may want you to talk about posterior fossa tumors, but the question could be rephrased in a different way. So and the answers were all in Anupama's slides, so you just have to go through them and pick up your important salient features for your pre-op, your intra-op travel through this case, and the post-op. The post-op is also important, especially the first few days. Thank you so much,
Thank you,
for
ma'am.
inviting me. Yeah.
Thank you so much, ma'am.
Yeah.
So posterior fossa,
Thank you,
thank you,
ma'am.
ma'am. I hope I've done justice, ma'am. Posterior fossa is one case. If it comes, if you know the correct answer, they're very few
Yeah, that's
straightforward
true.
questions, and you can gain marks over there.
This is actually a very good question to have, because there's so
Yes,
much,
ma'am.
like I say, पिटारे में बहुत माल है इसके अंदर, you can speak on a lot of things.
Lots of
So
things are there.
you'll never be short of answer if you learn, if you read all this. So
Yes,
thank
ma'am.
you, Anupama. Thank you so
Thank you
much.
so much, ma'am.
Thank you so much, ma'am, for your wonderful insights. And thank you, Dr. Anupama, for
Thank you,
brilliant.
Dr. Shakriya. Thank you so much.
So we would move forward to now our next case discussion. This is a short case discussion. Will be chaired by Dr. Anshu Gupta. Dr. Anshu Gupta is a professor anesthesia in Lady Hardinge Medical College, and she has received President Appreciation Award by ISA Delhi in 2021 and received second prize in Yuvacon 2021 for literary achievements. She is a BCLS and CCLS instructor. She's faculty in various ultrasound guided nerve block and airway workshop. And she has done her fellowship in regional anesthesia, IDRA in 2019. Her areas of interest are ultrasound guided nerve blocks and resuscitation and airway. I welcome you, Dr. Anshu. And I hand over the session to you. You need to unmute yourself, Dr. Anshu. You are on the mute mode.
Yeah. Good evening. Am I audible?
Yeah.
Yeah.
Yes,
And am
now
I
you're audible.
visible too? I hope.
Yes, very well visible.
So let's start with our short case of squint surgery. A child with a squint surgery. Dr. Arvind will present with the history. Since it's a short case, so I would like to highlight here that history and examination has to be in brief. Dr. Arvind, you may start.
Yes, ma'am. Ma'am, my patient. Yes, ma'am. Ma'am, I am presenting a case of Rahul, 3-year-old male, resident of Sector 10, Dwarka, Delhi. He belongs to socio-economic status of middle class. Informant was mother. The patient presented with chief complaints of impaired downward gaze in the left eye since 8 months of age. History of presenting illness. Informant is mother. Patient started experiencing difficulty in gaze downward with left eye, which was intermittent and gradually progressive. It eventually became persistent. There was slight depression of the chin also. Past history, there is no significant past history. There is no history of trauma, head injury, or trauma to the eye. There is no history of impaired visual acuity or diplopia.
Yes, Dr. Arvind, you may continue. Hello? I cannot hear you, Dr. Arvind. Can you hear me? Hello? 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 Dr. Arvind, can you hear me? Hello? Dr. Arvind, I think you are mute.
Ma'am, am I audible, ma'am?
Yes, you are audible. You were mute, I think. Yes. Please start with the history.
Ma'am, I am presenting a case of Rahul, 3-year-old male, resident of Sector 10, Dwarka, Delhi. He belongs to a class of middle class of socio-economic status. Informant was mother. Chief complaint was impaired downward gaze in the left eye since 8 months of age. Informant was mother. The history of presenting illness is patient started experiencing difficulty in downward gaze with left eye. It was intermittent and gradually progressive. It eventually became persistent. There is slight depression of chin also. Past history, there is no significant past history. There is no history of trauma, head injury, or trauma to the eye. There is no history of impaired visual acuity or diplopia. There is no history of any ocular surgery or anesthetic exposure in the past. There
Why
is
do
no
you
history
ask
of
history
fever.
of previous anesthetic exposure?
Ma'am, will get the history of any oculocardiac reflex or post-operative nausea or vomiting or malignant hyperthermia in the past if it has been.
Yes,
So
so
we
these
ruled
are
out.
associated with oculocardiac reflex, and it is earlier it was thought that they are associated with malignant hyperthermia, but now it is not so. So still it is important to know about the history of previous anesthetic exposure, so we can know about malignant hyperthermia or any exposure to other agents in the past. And succinylcholine is more now considered to be associated with malignant hyperthermia.
There is no history of fever, URI, or skin lesions. There is no history of vomiting or seizures. There is no history of excessive
Why do you
lactation.
ask history of vomiting in the past?
Ma'am, vomiting and seizures are associated with any mass, any intracranial mass which may be present, and to rule out hydrocephalus, which may be associated with any other congenital syndromes, if may.
And also, if there is past history of vomiting, so then there are more, there is preponderance for post-op nausea vomiting also.
Yes. There is no history of drooping of eyelids. There is no history of bluish
Why
discoloration.
drooping of eyelids you have asked?
Ma'am, drooping of eyelid is associated with myasthenia gravis and any other fibrosis if already present in the eye.
Okay.
Ma'am, there is no history of bluish discoloration of face, which was aggravated by crying. There is no history of shortness of breath.
Why have you asked history of bluish discoloration or shortness of breath?
Ma'am, Ma'am, this history is taken to rule out any congenital heart defect, to rule out any congenital heart defects.
Because these patients are associated with congenital syndromes.
Yes,
Which syndromes are associated?
Ma'am, syndromes which are associated are Appec syndrome, Crouzon syndrome, Down syndrome, and vectoral anomalies are also associated. Golden
What
heart syndrome
happens
is
in
also.
these syndromes? Appert syndrome, what is there?
Ma'am, in Appec syndrome, there is craniosynostosis along with strabismus. There is acrocephaly. Plus, ma'am, there is present of syndactyly and cleft lip and palate.
And
Ma'am, there is
congenital heart defects.
And congenital heart defect and mental retardation.
Okay. What is there in Down syndrome?
Ma'am, Down syndrome is the trisomy of 21st chromosome. It results in formation of apicanthal fold. There is low set ears. There is simian crease. It is also associated with congenital heart defects such as atrioventricular septal defect. It is also associated with mental retardation and short wave neck.
And golden heart syndrome?
Ma'am, golden heart syndrome, there is incomplete development of ear, nose, and lip, and palate and mandible. There is also association of deafness and scoliosis and strabismus.
And hemifacial microstomia is there, and congenital heart defects are there. So so in all these congenital abnormalities, you can see there are two things which are there: facial abnormalities and congenital heart defects, which we are concerned in our anesthesia part. So we have to rule out congenital heart defects and any other congenital abnormalities present in these children.
Yes.
So you have taken history. Now describe the examination in brief. Tell me only the positive findings in the examination.
Ma'am, the general physical examination, airway examination, respiratory, CNS, and CVS examination are all within
Whenever
normal
you
limits.
present a case, you don't talk like this CNS, CVS. First of all, you tell that journal examination was normal. Then airway, no significant findings found in airway examination. Then speak cardiovascular. Don't say CVS, ENS. Okay?
Yes, ma'am. Yes, ma'am. Cardiovascular system examination was normal. There is no added murmur. S1, S2 are present. Ma'am, there is normal CNS examination was also normal, ma'am.
Okay. And respiratory examination was
Patient
also.
oriented. Yes, ma'am.
So summarize your case based on the positive findings.
Ma'am, my patient is a 3-year-old male, which have difficulty in downward gaze since 8 months of age, which was progressive in nature. So it is an concomitant type of squint, ma'am.
Okay. So what is squint?
Ma'am, squint is the misalignment of the visual axis of one or both the eye.
Okay. So how does squint develops?
Ma'am, the normal anatomy and physiology of vision is controlled by extraocular muscles
Okay.
and cranial nerve 3, 4, and 6, and along with visual cortex. So, ma'am, disruption in any of these can lead to formation of squint.
So basically, squint is misalignment of eyes, and it occurs due to imbalance in the extraocular muscles or weakness of the extraocular muscles. So, what is the correct age of correction of squint?
Ma'am, it should ideally be corrected before 7 years of age.
Okay. So why up to 7 years of age?
Ma'am, the binocular vision is completed at 7 years of age. So the formation of double image in visual cortex, which develops at 7 years of age. So if corrected before that, it leads to good surgical result.
Okay. So what is happening is that by 1 month of age, there is orthoptic alignment of the eyes. Both eyes are focused on the same spot. And at early age, brain is learning to combine two images to form a 3D image. So when due to if correction is done later than 7 years, then eye loses the sense of depth of perception, and the good correction is not achieved because by that time the brain learns to interpret the signals from the eye. So correction should be done as early as possible and maximum up to 7 to 8 years of age. So what are the causes of strabismus?
Ma'am, the causes of strabismus can be briefly divided into two. It may be congenital or infantile, which develops before 6 months of age, and it can be acquired, which develops after 6 months of age.
Okay, so what are the acquired causes?
And the acquired causes are development of myasthenia gravis or thyroid eye disease or any ocular trauma.
Okay. So they can be divided into ocular disease like tumor, retinoblastoma, ocular trauma, then cranial facial nerve palsies, neurological. Cranial facial nerve palsies can be there. There can be myasthenia gravis, Guillain-Barré syndrome, multiple sclerosis, or there can be myopathies, right? Which can be due to thyroid disease or orbital disease, or there can be ophthalmoplegia myopathies, which might be there present. So what are the extraocular muscles of the eye? Since we are talking about extraocular muscles, so you should know about their names and their nerve supply.
Yes, ma'am. Ma'am, there are 4 recti muscles: medial rectus, lateral rectus, superior rectus, and inferior rectus. And ma'am, there are 2 oblique muscles: superior oblique and inferior oblique muscle.
Okay.
Ma'am, the lateral rectus is supplied by the abducens nerve, that is 6th cranial nerve. Ma'am, superior oblique is supplied by the 4th cranial nerve, and rest all the other muscles are supplied by the 3rd cranial nerve, that is trochlear.
So the mnemonic is SO4 and LR6.
LR6.
Yes. Very good. So, Dr. Arvind, what are the goals of squint surgery?
Ma'am, the goals of squint surgery is to restore the alignment of the eye and maintain normal visual axis, to avoid any amblyopia, or to correct the double vision and improve the depth of perception, that is stereopsis.
And since the child is undergoing squint surgery, and so we should always be aware of the steps of surgery in the brief so that we know at what step what is happening and what are the possible anesthetic concerns we can have. So can you tell in brief what are the steps of squint surgery?
Ma'am, Firstly, the incision is given through conjunctiva and tendon fascia, and then muscles are located and insertion points are exposed, and extraocular muscles and then repositioned to do the surgery.
So there are 3 steps involved, Dr. Arvind: recession, resection, and transposition is there. By recession, there is weakening of muscle is done so that it is moved from its insertion point. And in resection, strengthening of muscle is done by eliminating a piece of muscle. And in transposition, we alter the action of muscle by retracting muscle at a new location.
Yes, ma'am.
So we have done history examination. Now this child has to be taken up for surgery. So can you tell what will be the anesthetic concerns in a case of squint surgery in a child?
Ma'am, the anesthetic concern can be divided into 3. There may patient-related, surgical-related, and anesthesia-related. Ma'am, patient-related will be, as this is a pediatric population, so the airway would be difficult. Also, ma'am, we'll have to previously, we have already ruled out all the other syndromic associations. Also, ma'am, patient comfort has to be taken into consideration.
This child
Adequate
doesn't
NPO
have
would be-
this child doesn't have airway abnormality, but there might be airway abnormalities which might be there associated with the syndromes associated in these children. And there might be congenital heart disease also. So associated syndromes is one which we are concerned about, but it is not there in this case. Then what else?
Yes, ma'am. Ma'am, we'll have to take care for adequate NPO of the patient, and ma'am, comfort has
What are
to
the
be
other
ensured.
concerns? Oculocardiac reflex.
Ma'am, the other concern could be oculocardiac reflex, oculorespiratory reflex. There may be post-op nausea and vomiting associated, and malignant hyperthermia is also associated.
And there might be some systemic effects of ophthalmic drugs also, which we will discuss in the intraoperative course. So now you have to take up this child for surgery. Now, keeping everything in mind, whatever we have discussed, history and everything and the concerns, what investigations will you do for the child?
Ma'am, I would like to order hemogram and urine protein monitoring, ma'am.
Okay. And suppose the child is having congenital syndromes associated, then what else can you order?
Ma'am, screening 2D echo has to be done to rule out any congenital cardiac artifacts.
True. So if child is not having associated any congenital abnormality, then hemogram and routine microscopy are sufficient for the child. So now you have to take up the child. So what will be your pre-op orders for the child? And what will be your pre-op advice?
NPO, ma'am, first of all, written informed consent after procedure explanation has to be taken from the guardian, ma'am.
Okay.
And second,
It's a child,
NPO
so you need
nil per oral.
Yeah, since it's a child, so you need parent or guardian's consent. Very good. Then NPO orders, what will you order? What will you tell? How many hours NPO?
Ma'am, for clear liquids, we'll give for 1 hour. For breast milk, it is 3 hours. For infant formula, it is 4 hours. And for solid food, we'll have to keep NPO for 6 hours at least.
So you are discussing the Pediatric European Journal and in anesthesia and intensive care guidelines, the latest 2022 guidelines.
Yes, ma'am.
According to that, you can
Yes,
give
ma'am.
clear fluids 1 hour prior. So what do you understand by clear
Yes,
fluid?
Ma'am, clear fluid can be water. It can be pulpless juice. It can be coconut water, and milk-free coffee can be given.
Very good. So you have given NPO orders, you have taken consent. What pre-medication will you give to the child? What all can you do to allay the anxiety of the child, basically? What measures can you take?
Ma'am, we can give midazolam. That is, we can give per oral also. If already IV line is present, we can give intravenous also. So, ma'am, per oral dose is 0.3 to 0.5 mg per kg, ma'am. And it can be given 1 to 2 hours prior to surgery, and
So,
intravenous dose that is 0.1 to.
so how do
Yes,
you
ma'am.
give midazolam if you don't have this oral preparation?
Yes, ma'am.
Can
Ma'am, we
you?
can dilute it in
Yes.
5% dextrose solution, and we can give to the patient, ma'am.
Very
As
good.
it is bitter in taste, so we can use dextrose, ma'am.
So this is one of the methods. See, preoperative anxiety is a very favorite question of examiners. So this is one method. Can you, this is a pharmacological method. Are there some non-pharmacological methods also you can take to allay the anxiety of the
Yes,
child?
ma'am. Ma'am, we can parental exposure to the OT can also be provided along with the patient. Ma'am, we can use medical clowns, we can use video, we can use tapes, we can make child listen to the songs. These are all the methods we can
Very
use,
good.
ma'am.
So I would rather say, see, clowns and all are very corporate culture and they may or may not be present. But what you can do is simple steps like you can show video or pamphlets to the child, some pictures related, or you can make a preoperative visit of the child to the operation theater one day prior and put some BP cuff monitor on the child or pulse oximeter or BP cuff on the child's hand so that the child becomes comfortable and accustomed. Also, we can ask the parents to accompany at the time of induction, or we can hand over some mobile or tabs to the child. Nowadays, they are very much fond of these gadgets, so they can move wheeled in with these devices in hand. So that all also can be taken in. And midazolam is one of the medication. What other medications you are aware of can we give to the child for pre-op anxiety? Anything else? We can give dexmedetomidine. Intranasal preparations are also there. Oral ketamine is there, right? So you should know all the, see any case with the child, you should know about anxiety and pre-medication. So now you have to take up this child in operation theater. What all will you do? You have taken up this child. You have given pre-medication. Now you have taken up the child in the operation theater on the OT table.
Yes. We should be pre-warned, or should be available. Anesthetic should be checked, and the drug should be prepared, as we had my
You are not audible, Dr. Arvind. Hello, this network is, there's some trouble in the network. Hello. Yeah. OT should be pre-warned, you said. Hello. Slightly audible. OT should be pre-warned next.
audible?
Dr. Anshu Arvind will
Am I
be
audible now?
joining in a minute.
Okay.
Am I audible now? BB, audible now?
Yeah. Hello, Dr. Arvind.
Am I audible, ma'am?
Yeah, you are audible. Yes. So tell me
Yes,
one thing. Will you give IV antibiotic prophylaxis to this child?
No, ma'am. Am I audible, ma'am?
Yes, yes, you are audible.
Sorry for the interruption, ma'am.
No, it's
Network
okay.
keeps getting disconnected. I'm sorry.
No worries.
Uh,
So will you give IV antibiotic prophylaxis also to this child?
No, ma'am. No, ma'am. IV antibiotic prophylaxis are not required in this case.
Because it is required only in nasolacrimal duct surgeries. Otherwise, in all the ophthalmic procedures, including squint surgery, you don't require IV antibiotic prophylaxis. So now you take up this child in the operation theater. How will you further manage this child?
Ma'am, my plan would be to induce the patient under general anesthesia and then insert Procil LMA and with adequate muscle relaxation.
Wait. Before that, you will take the child on the OT table and you will attach monitors. What monitors will you attach?
And I will attach all the ESM, pulse oximetry, ECG, non-invasive BP, and temperature now.
Why temperature
Temperature.
monitoring?
Ma'am, as pediatric age population are more prone for hypothermia, and also, ma'am, in malignant hyperthermia, there is abrupt increase in temperatures. So to monitor that also, ma'am.
Very good. So would you like, before induction, would you like to give some drugs also?
Yes, ma'am. To counter post-operative nausea and vomiting, we can also give dexamethasone, or
Very good. How
we can
much?
also give dexamethasone 0.1 mg per kg, and to obtain the reflex, that is oculocardiac reflex, we can also give injection atropine 0.2 and 20 microgram per kg, or injection glycopyrrolate 10 microgram per kg. Can give that.
Okay, so you will give injection atropine and glycopyrrolate for the prophylaxis for the oculocordic reflex. Now,
Yes,
what is your plan of anesthesia?
My plan of anesthesia would be induction under general anesthesia with Procil LMA insertion and adequate muscle relaxation, controlled ventilation.
Why, first of all, why you want to give general anesthesia? Why not under blocks?
Ma'am, pediatric population are in very much, they are not cooperative, ma'am. So
Very
regional blocks would not be good for them. Second, ma'am, there is a reduced incidence of oculocardiac reflex under GA as compared to regional anesthesia, ma'am. Third, mechanically controlled ventilation could be achieved now.
So why controlled ventilation is required? Why not on spontaneous respiration since you have placed LMA?
Ma'am, LMA has certain advantages over.
Wait.
Yes, ma'am.
I am asking why controlled ventilation? Why not spontaneous ventilation? Because there is a risk of?
There is risk of hypercarbia and hypoxemia associated. with
Oculocardiac
the
reflex is
oculorespiratory
triggered.
reflex.
Oculocardiac reflex is triggered
Yes,
by hypoxia, hypercarbia. So you want to give controlled ventilation so that you can prevent all these things. But why have you
yes.
preferred LMA over endotracheal tube? Are there any advantages of LMA over endotracheal tube?
Yes, ma'am. Ma'am, firstly, it is easier to perform. It requires lesser time to do. Second, ma'am, it causes less airway irritation, so decreases the incidence of post-operative nausea and vomiting and sore throat, ma'am. Sorry, ma'am. Not
This decreased sore
post-operative
throat,
nausea,
you are
vomiting,
right.
sore
It
throat.
causes lesser trauma. Yes.
Lesser trauma.
And it also decreases the need for muscle relaxants also.
Muscle relaxant. Yes, ma'am.
But if it is a child with congenital abnormalities, if there are facial deformities, then you have to go for endotracheal tube. Then LMA we won't able to place the LMA sufficiently. So we can, but since our child is not associated with any congenital abnormalities, we can place LMA in this child. So choice depends on the type of patient we have. We can go for endotracheal intubation also and LMA also, but in this child, you are preferring LMA because it has got certain advantages over endotracheal tube. So you have said that you will go for controlled ventilation. So how will you induce this child? What will be your mode of induction? Will it be inhalational induction or what type of induction? Dr. Arvind, can you hear me?
Yes, ma'am, I can hear you.
So what is the type of induction you will prefer?
Ma'am, since there is no IV cannula present initially in the patient, we can start with the inhalational induction with sevoflurane.
Okay. So why do you prefer sevoflurane over halothane? Why not halothane?
Ma'am, sevoflurane has certain advantages over halothane. It causes smoother induction, and ma'am, it is
See, Dr.
ma'am,
Arvind,
it is
you
less.
have correctly said sevoflurane. It has got lesser incidence of oculocardiac reflex over halothane
Yes.
and lesser risk of dysarrhythmias and airway irritability. The only disadvantage with sevoflurane is that it has increased incidence of agitation, but seeing the risk-benefit ratio, you will definitely prefer sevoflurane. So what will be the choice for maintenance of anesthesia?
Ma'am, intermittent dose of IV non-depolarizing muscle relaxant can be used for maintenance, and along with inhalational agent sevoflurane with oxygen and air, ma'am, we can use
Why
in
air?
the
Why
ratio of
not nitrous oxide?
ma'am.
Dr. Arvind, I cannot hear you. Dr. Arvind. Yes. Can you hear me?
Yes, ma'am.
Why not nitrous oxide? Why have you chosen air?
Ma'am, nitrous oxide is associated with greater incidence of post-operative nausea and vomiting. So we will avoid
So,
that.
but if you talk
Also,
about post-op nausea, vomiting, then inhalational agents are more associated with post-op nausea, vomiting. So why don't
yes.
we give TIVA for maintenance?
Ma'am, TIVA is associated with greater risk of oculocardiac reflex.
Yes,
So we will
bradycardia is more and more risk of oculocardiac reflex with TIVA. So we prefer inhalation, seeing again the risk-benefit ratio. So now intraoperatively your child, the case is going on. So what are your intraoperative concerns in a child taken for squint surgery?
Ma'am, we have, ma'am, our goal is to achieve adequate depth of anesthesia. We'll have to prevent hypoxemia and hypercarbia. We'll have.
So surgeons sometimes use some vasoconstrictor drugs, some topical drugs used for mydriasis. Are you aware of that? Dr. Arvind? Network.
Am I audible, ma'am?
Yes, yes. So I'm
Ma'am,
saying that
phenylephrine.
surgeons put some drops in the eye for mydriasis before starting the procedure. So which
Yes, ma'am.
drug do they use, and why are we concerned about that?
Ma'am, phenylephrine is used as a topical analgesic action. Ma'am, it
For
causes
mydriasis.
mydriasis.
Phenylephrine is used for mydriasis. So that surgical
Yes, ma'am.
procedure is facilitated. So what can happen with that?
Ma'am, there could be systemic absorption of this drug, which can lead to increased in heart rate and reflex bradycardia associated with it. So we'll have to monitor that.
See, these drugs, when the surgeon put these drugs and give surgical incision, the incision is given in the pool of the drug. So these drugs are rapidly absorbed, and they can be hypertension, increased BP, and even pulmonary edema has been reported in pediatric patients as well as in adults. So there is a risk of hypertension, pulmonary edema, and even cerebrovascular absorption accidents, because the drug is rapidly absorbed. Even after conjunctival membrane barrier is disrupted, the drug gets systemically absorbed. So what is force reduction test? The surgeons also perform something called force reduction test. So what is force reduction test and how it is done? Dr. Arvind, can you hear me?
Am I audible, ma'am?
Yes, you are audible. So what is my question to you is, intraoperatively surgeons also perform force reduction test. So what is force reduction test?
Ma'am, force reduction test is used to distinguish between paralytic and mechanical causes of obstruction of the squint, ma'am.
Okay, so how it is done?
Ma'am, it is done in supine position. The lid is retracted via using lid retractor or speculum, and then at the limbus, extraocular muscles are grabbed and pulled to each direction to look out for mechanical obstruction of the eye.
So it
Ma'am, if there is
determines the type of corrective surgery required. The surgeon grasps the limbus with forceps and move globe in multiple directions, and they see to the resistance to the movement of the globe. Whether so, if there is free movement without any restrictive cause, then the cause is neuropathic or paralytic in the etiology. If there is resistance to the movement, then it is a mechanical cause which is present. So why we are concerned about this test? What is our anesthetic concern in post-reduction test?
Ma'am, if we use succinylcholine, that is a depolarizing muscle agent during muscle relaxation, so it affects prolongs up to 20 minutes. So during that time period, post-reduction test, they cannot perform. Will not be able to distinguish between a paralytic or mechanical cause of obstruction.
So you should give non-depolarizing muscle relaxants, because succinylcholine, it causes sustained contraction of extraocular muscles up to 20 minutes. So force reduction test may be delayed. So this mechanism, why there is prolonged effect of succinylcholine on extraocular muscles. This mechanism is not known, but it is there. So we should use non-depolarizing muscles whenever surgeons plan to do the force reduction test. So we are concerned about topical drugs. We are concerned about force reduction test. Now coming on to oculocardiac reflex. So what is oculocardiac reflex?
Ma'am, oculocardiac reflex is greater than or equal to 20% or more reduction in heart rate or presence of any arrhythmia in the presence of any mechanical stretching of the eye or extraocular muscle.
So whenever there is 20% decrease in heart rate from baseline in the presence of, or there is presence of arrhythmias caused by the traction on the globe, then oculocardiac reflex might occur. So are there any other causes besides squint surgery which can cause oculocardiac reflex?
Yes, ma'am. If there is trauma to the eye, it can happen. Or ma'am, during regional anesthesia, if we are planning, then we can also do that. So we'll have
So
to be
at the
very.
time of regional anesthetic nerve blocks or with
Yes, ma'am.
facial traumas or with mechanical stimulation also, oculocardiac reflex can occur. So what is the reflex arc for oculocardiac reflex?
Ma'am, the afferent fibers are carried by the trigeminal nerve, and efferent root is carried by the vagus nerve. So the stretch reflex are present at short and long ciliary nerves, which relays to the Gasserian ganglion, which is a cranial fifth cranial nerve ganglion, and then it transmits signal to the sensory nucleus of trigeminal ganglion, which then relays it to motor nucleus of vagus nerve. Then via vagus nerve, it causes SA node inhibition now,
So
which leads to
basically stretch receptors, you can open the diagram if you have. Can you do
Yes.
the screen sharing? Okay, no worries. I'll tell like
I'm
stretch.
doing.
Yeah.
This is the diagram now.
Yeah, you can open the diagram. Yeah, stretch receptors in the periorbital and ocular tissues. They stretch the long and short ciliary nerves. So impulse is transmitted through them to the ciliary ganglion first. And
Yes,
from
ma'am.
ciliary ganglion, they go to the ophthalmic division of fifth nerve, then to Gasserian ganglion, and then to trigeminal nucleus. Then if efferents are carried out in vagus nucleus, motor nucleus of the vagus nerve, and they cause SA node activation. So there is vagal motor response. So what are the effects you can see when there is oculocardiac reflex?
The bradycardia plus ma'am ventricular arrhythmias may be associated with Germany, may be associated with complete or partial heart block, and it can also lead to cardiac arrest.
And there can be asystole which can occur. So what are the triggering factors for oculocardiac reflex?
Ma'am, triggers are hypoxemia, cardia, and ma'am, am I audible, ma'am?
Yes, you are audible. You said
Sorry, ma'am.
hypercarbia, hypoxemia.
Ma'am, contraction of extraocular muscles along with lighter plane of anesthesia, and it is more pronounced in younger age group.
Okay. So what prophylaxis do you give for OCR?
Ma'am, before start of the surgery, we can give prophylactic dose of either atropine 20 microgram per kg or glycopyrrolate 10 microgram per kg.
It's atropine is 20 mics and glyco is 10 mics. Okay. What else? You can ask surgeon to give gentle traction on extraocular muscles. Anything else?
Yes, ma'am. Ma'am, we will avoid possible causes of hypoxemia or hypercarbia, ma'am. And we
Very
will
good.
always keep in a deep plane of anesthesia while undergoing
Okay.
surgery, ma'am.
So you have gone for controlled ventilation also for the same reason. And then you can give regional anesthetic blocks also. You can combine GA with regional anesthetic blocks, though not preferred so much in children. And topical anesthesia, you can give lignocaine drops also, which is very helpful in prevention of oculocardiac reflex. But suppose oculocardiac reflex occurs, the child
ma'am.
shows bradycardia, which is less,
Yes, ma'am.
more than 20% of the baseline, then what will you do to manage the oculocardiac reflex?
Ma'am, first of all, we will ask surgeon to not stimulate any further. Then we will
So you
most
will
of the
ask them to stop the surgery and
Yes.
so that there is no traction on the muscles. Yes.
Ma'am, if the bradycardia still occurs after 10 seconds of we can administer either atropine or glycopyrrolate in the dose of either atropine 20 microgram per kg or glycopyrrolate 10 microgram per kg. Ma'am,
So
we will also monitor.
Yes, speak. Yes, you are
We will
audible.
also monitor we will also monitor heart rate and any rate or rhythm changes along with it.
Very good. So if after immediate cessation of muscle traction, if arrhythmias doesn't stop in 10 to 20 seconds, you will give injection atropine or glycopyrrolate. And then after the effect comes, you'll ask them to continue with the surgery. So any other reflex which is present, which can be there besides oculocardiac reflex?
Ma'am, there could be oculo-respiratory reflex which can develop
What
during
happens
traction
in
of
that?
extraocular muscle.
What happens in that?
Ma'am, there is decrease in tidal volume and respiratory rate leading to hypoxemia and hypercarbia, which may further aggravate oculocardiac reflex.
And also there may be respiratory arrest. So what is the reflex arc for this?
Yes, ma'am.
What is the efferent and efferent pathway?
Ma'am, the afferent pathway is carried out by the trigeminal nerve and efferent is carried out by the phrenic nerve, ma'am.
Okay, very good. So how do you, what is the prophylaxis for oculo-respiratory reflex?
Ma'am, the same as of oculocardiac reflex. We can give injection atropine 20 microgram per kg and yes, ma'am. And ma'am, we will always keep plain anesthesia and deep. We can use regional anesthesia, however, not preferred in children. And ma'am, we will ensure adequate tidal volume. We will ensure adequate oxygenation and ventilation, ma'am.
So how do you manage oculo-respiratory reflex?
Ma'am, we will ask surgeon to stop the surgery and we will administer injection atropine 20 microgram IV. We will deepen the plane of anesthesia. We will administer 100% of oxygen and we will look for any hypoxemia or hypercarbia if any.
Very good. So you will also ensure adequate oxygenation and ventilation in this patient since there is decrease in tidal volume and respiratory arrest. So, another question is there any association of malignant hyperthermia and strabismus in these patients?
Earlier it was thought to be, but now there is considered that there is no increased incidence during strabismus surgery in children.
So nowadays it is more related to succinylcholine. But suppose malignant hyperthermia occurs, how will you detect intraoperatively in a patient who is under anesthesia that there is malignant hyperthermia?
Ma'am, there will be abrupt rise of end-tidal carbon dioxide in capnography. There will be increased heart rate. There will be there will be increased in temperature.
Very good.
Dark colored urine would be seen, and metabolic acidosis may ensure there may be increased level of potassium in the blood, that is hyperkalemia.
And what about BP?
We can see that.
What about blood pressure?
Ma'am, blood pressure will fall because
yes,
there will be excess of toxic metabolite which will lead into shock. Ma'am.
And they might be cardiac dysarrhythmia. So how do you manage malignant hyperthermia?
Ma'am, we will have administer 100% of oxygen. Am I audible, ma'am?
Yes, you are audible.
Ma'am, we will ensure adequate ventilation. We will administer 100% of oxygen, and we will give surgery, and we will give injection dentrolin. The dose is 2.5 mg per kg initially, and when
would you like to stop the triggering agents?
Yes, ma'am.
Inhalation
We will
agents and
switch off the anesthetic agent. Yes, ma'am.
And we have to avoid choline use. Yes.
Yes,
Dentrolin you said. Then what else?
Ma'am, we will actively cool the patient to correct hyperthermia. We will use ice pack, and we can also we will also have to correct the hyperkalemia. We can give calcium gluconate and insulin along with glucose. We will also have to correct metabolic acidosis. We can give injection bicarbonate. This all can be done now.
And you can continue.
And we will have to serially we will have to serially look for serial EBGs, temperature monitoring, and blood parameters to look out for any coagulopathy.
And one more thing, you have to ensure adequate urine output, at least at the rate of 2 ml per kg per hour. And for that, you can give mannitol along with the dentrolin.
Yes, ma'am.
Okay. So now, what are your post-operative concerns in this child? What can happen?
Ma'am, post-operatively, patient can present with post-operative nausea and vomiting, and child
So
may
how
be
it is caused? What is the mechanism of post-op nausea vomiting in a child of squint surgery?
Ma'am, trigeminal nerve, via trigeminal nerve stimulation, it goes to medial lateral fasciculus, which is very near to the vomiting center in the medulla, which can lead to vomiting and nausea in post-operative
Very
period.
good. So what are the anesthetic related factors which can reduce post-op nausea vomiting?
Ma'am, by not using any inhalational agent, if we can only use total IV anesthesia, then we can reduce the incidence. Ma'am, we can also give prophylactic dose of anti-vomiting medication such as either ondansetron or dexamethasone or metoclopramide. These all the measures
And
we can
you
take.
can tell surgeons to do gentle manipulation which stimulates, and you can combine it with blocks, regional anesthesia blocks, which are helpful. And you can use topical local anesthetic agents. So blocks can be combined, and then you can give drugs. Before induction, you had given dexamethasone to the child, and half an hour before
Yes, ma'am.
extubation, we can give injection ondansetron as well as injection metoclopramide. Now, what are the modalities for post-op analgesia in a child with squint surgery?
Ma'am, post-operative analgesia could be provided via paracetamol, injection paracetamol, or non-steroidal anti-inflammatory drug. We can also give a small amount of opioids, although it is less given because it will lead to post-operative nausea, vomiting. These are can be used.
Something else?
Also, regional blocks operatively, if
That
then it will
also
lead to
you
good
can give
analgesia.
subtendon block at the end of the procedure. You can ask surgeons to give subtendon block. And also, when surgeons are suturing the conjunctiva, we can give diclofenac 0.1% eye drops. We can give them sterile drops, and they can put at the time of suturing of conjunctiva. So subtendon block, diclofenac drops, and the IV medication, as you told. So tell me, since we are talking since long about regional anesthesia, what is the role of regional anesthesia? Can it be used as a primary anesthetic technique in adults? You said in pediatric patient it is not possible. Is it possible in adults to get the cases done under regional anesthesia?
No, ma'am, we do not usually go for alone regional anesthesia in adult also, because although it may provide complete akinesia, it is very discomforting to the patient. So we usually give it as an adjunct to general anesthesia.
So only in patients who are medically unwell, who are having lots of comorbidities, we go for only regional anesthesia, because even with complete akinesia, there is discomfort due to muscle traction and conjunctival manipulation. So we combine it with, usually combine GA with regional anesthesia in adults. And any advantages of regional blockade?
Ma'am, it is associated with less incidence of post-operative nausea and vomiting. So it is good, ma'am.
And post-operative analgesia also, and this decreased oculocardiac reflex also.
Reflex also reduces.
So are there any contraindications to regional anesthetic blocks?
Yes, ma'am, there are several contraindications associated to it. If the eyes are small or in ophthalmos, there is a lot of extensive fibrous tissue associated, which can happen in either myasthenia gravis or thyroid eye disease. Or ma'am, there is previous surgery of the eye, or sutures if already are in place, then we should ideally avoid
It
it.
will interfere with the spread of the drug, the previous eye surgeries, the scars.
Yeah.
Yes, right.
And
So,
also
Dr.
in
Arvind,
pediatric patient.
yes, because there is risk of injury from the sharp needles, because if there is the orbital area, it is occupied 50% by the eye in the globe at birth, and it becomes 33% at 4 years and 22% in adults. So there is more risk of sharp needle injury in pediatric age group than adults. So what are the blocks which we can give in regional anesthesia for eye? What are the blocks we are aware of?
Ma'am, we can give retrobulbar block, we can give peribulbar block, and ma'am, we can also give subtenon block, and facial blocks are also there, ma'am. We can also use them.
Where do we give retrobulbar block, and does it have any disadvantages?
Yes, ma'am. Retrobulbar block is given in intraconal area, that is the area of insertion of all the muscular and vascular structures. But the main contraindication or disadvantage is that it is even very near to the muscles and vessels. So there is more chances of retrobulbar hemorrhage and muscle damage, ma'am.
So we prefer which block? Peribulbar or retrobulbar?
So, ma'am, we prefer peribulbar block is more preferred because it is associated with less trauma to the eye and less incidence of retrobulbar hemorrhage.
Can we give subtenuous block also, and how it is given?
Ma'am, subtenon block can also be given. It is given under the fascia between limbus and surrounding orbit.
Okay.
Ma'am,
Right.
yes, ma'am.
So what are the signs of successful block? Suppose you are given block, what are the signs of successful blockade?
Ma'am, there will be complete akinesia. There will be anesthesia. There will be no extraocular movement. There would be tosses, and there would be inability to close eyelids.
And there will be good analgesia also, which is required. So any facial nerve blocks which we give for akinesia of muscles?
We can. Yes, ma'am. We can give Wandlin block. We can give O'Brien. We can give Atkinson block or Nedbeth block. These are all the blocks which we can give.
Okay, so what is the risk in the Van Lint block and where it is given?
Ma'am, it is given just above eyebrow, between the eyebrow and just below the orbital floor. Ma'am, the risk associated, it is associated with eyelid edema and hemorrhage, ma'am. Lid hemorrhage is associated with this, ma'am.
So this is all
And proptosis is also associated.
okay. So this is all about a child with squint surgery case. So the commonly asked questions are what is squint and how it develops, its association with syndromes, oculocardiac reflex, oculorespiratory reflex, post-op nausea, vomiting, malignant hyperthermia, and then role of regional anesthesia. Thank you so much.
Thank you so much, Dr. Anshu, and we apologize on behalf of our technical team because of so much of interruption because of technical glitch. I
Okay.
think there is something going on and network issue is there in this floor.
No, it's okay. Thank you so much for giving the opportunity. I would like to thank Nija ma'am and the whole Appec team for the wonderful program.
It's our pleasure, Dr. Anshu.
Thank you so
And
much.
thank you, Dr. Arvind. Very well presented case. So we would like to now move forward to our next session, for which I would like to invite our chairperson, Dr. Dalim. Can we have his CV, please? So Dr. Dalim Kumar Vaidya, he's a professor and head of anesthesia and critical care and pain medicine in AIIMS Guwahati. And he has got 220 publications with including 85 original articles and 25 SRME and 6,400 citations. He's book editor in Washington Manual of Critical Care, a South Asian branch, and he's journal editor and associate editor in Indian Journal of Anesthesia. He has got Best Researcher Award in ISA Delhi 2022 and Best Oral Presentation World Intensive and Critical Care Istanbul 2023 Congress. And his area of interest are critical care, perioperative medicine, and difficult airway. I welcome you, sir. We are honored to have you here as chairperson and hand over the session to you.
Thank you so much for your kind introduction, and it's always a pleasure to join the team Appec. I think without having any further delay, let us proceed to the talks, the remaining talks. So, for the first lecture, I would like to invite Dr. Lalit Gupta. He's a professor in anesthesiology department in Maulana Azad Medical College, and he is the editor-in-chief of Indian Journal of Clinical Anesthesiology, with more than 170 publications and 20 book chapters and 3 books to his name. Over to you, Dr. Lalit, for speaking on the recent advances in anesthesiology.
A very good evening to everyone. I am Dr. Lalit Gupta from Maulana Medical College. I will walk you through the remarkable advances in anesthesiology, from its origin to innovations shaping the future, highlighting the key developments in equipments, drugs, technology, and practice. So, a very basic question is, how new is modern anesthesia? Remember, although anesthesiology is constantly evolving, its core goal to keep the patient safe and pain-free remains unchanged. Over the decades, incremental improvements have created a specialty that blends historic wisdom with cutting-edge technology. And we always make sure that our patients never turn blue. So, before anesthesia, surgery was synonymous with unbearable pain when there was no answer. The agony drove early pioneers to seek substances and methods to silence pain, paving the way for the today's sophisticated anesthesia techniques. If you see from the where without anesthesia, the historic picture where the limb is cut and the pain you can imagine of. So the journey began with the crude herbal concoctions like mandrake break preparation, which advancement leading to dramatically to 1800s, 1406 October 16, when William T.J. Morton in Boston used ether to enable a tooth extraction without pain, a milestone that launched modern anesthesiology, and that was the ether era. After that, nothing, lot of changed. Around in 1855, if you remember, the Queen Victoria used chloroform for childbirth, providing royal endorsement that helped the anesthesia within medical practice and society. So we have an anesthesia specialty as a newborn. But 1948, the anesthesiology was recognized as independent medical specialty by the NHS, and it was the time since then every year, every time something new was invented, leading to the recent advances in anesthesiology. By 1950, the fundamental principles were stabilized. Since then, improvement has focused on safety, precision, and patient comfort. So the very first thing was, as you remember historically, was the inhalation anesthesia. The vaporizers for anesthetic agents were developed. Initially, it was the halothane in 1956. However, it was used because the ether used to cause a lot of room fire. So halothane was a boom at that time. But due to some side effects of cardiac arrhythmia and liver toxicity, newer agents were found out. And then with the 21st century, the digital revolution happened. From halothane to the desflurane, we reached the 1999 the kaleidoscope. It seems induction. The kaleidoscope brand has forced the path for an entirely new category of airway devices called as the video laryngoscopes. And in the same time, the end of the 21st century, the xenon was approved as an anesthetic agent, which does not act as a greenhouse gas. So 21st century was a milestone. It's a milestone actually, because it involved the fast-acting inhalation agents, target controlled infusions, technology for precise drug delivery, newer hypnotic agents, and mobile epidural system that enables laboring mothers to remain active. Non-invasive tools like 3D echocardiography, portable ultrasound methods provide the real-time bedside monitoring and is revolutionized the intraoperative patient management and are the part of the recent advancement. So what's new in the airway management? If you say, I will say airway armamentarium new includes now various tubes, video laryngoscopes, the bougie, the stellates, the supraglottic devices, flexible scopes, surgical airway option for emergencies, ultrasounds for capture of the clear airway, MRI machine to make the tube size selection safer, especially in the children and difficult airway. So we have the indirect laryngoscopy, as I told you, the MRI and ultrasound guided, they are the new addition to the airway management. And recent, as I told you, from the bougie to the surgical dynamic intubating sterate with a controllable tip, which can flex and retroflex. The newer and the latest addition is the iGel Plus, which has a more broad extra channel port like the iGel from the iGel differ, and it is a good conduit for the intubation than iGel. So we have now the flexible fiber optic, the endoscope, the disposable from the Telefax and other varieties. And now they can move not only from the anterior posterior, but also the lateral movements are also possible in them. Channel guided, I told you, channel guided devices. Devices like air track, which use the channel guidance with prisms and mirrors to reduce the trauma by following the airway natural anatomies during the insertion. So the concept of laryngoscopy, like natural curvature, is now a reality. The AirTag device is the forefronter for these devices. If you remember the video laryngoscope, like the gyroscope, as I told you, it provided indirect view of the vocal cords on a screen, improving success in difficulty intubations and enabling real-time technique opportunities. So from here we move to the newer things like the whole classification where I told you from C-tag to the Pentax, AirTag, the Bonofil retromolar, rigid bronchoscope, the CMAC and VMAC, Kaleidoscope, McGrath, and now the recently daily newer varieties are added to their armamentarium. So the most important is the tube with camera at the end. This is a newer advancement. It is called as the Viva side direct laryngoscopy tube, which is embedded with a camera which allows the continuous visualization of tube placement, and it reduces the complication from the misplacement or dislodgement. So it enables you to immediately detect and correct the mark position and any dislocation without compromising the ventilation. Apart from that, we have the innovations which includes the nasoflow, which are the nasopharyngeal airway device, which delivers the humidified oxygen nasally, and the WEI, called as the nasal jet tubes, which again, like if you see these type of WEI nasal jet tubes and the endotracheal tubes, which are connected to the receiver machine directly for oxygen delivery and has two channels. One for the jet ventilation and another for the end-tidal pressure carbon dioxide monitoring. So these new nasal and endotracheal tubes are the recent advancement. But these are not limited only to this. That's the jet endotracheal of the nasal jet tubes. We have the microcup subglottic suctioning endotracheal tubes, the Endoflex, which is a new type of tracheal tube with an adjustable distal tip, where you can move if the vocal cords are anterior, can be bent without the use of stellate. Tri-tube. If you remember, so ventilation by the 2.4 millimeter internal diameter is possible, and it has a cuff which makes the new possibility, especially in the microlaryngeal surgeries. We have the ventrain and ejector ventilator for emergency uses, where can be connected like the cricothyroid set, and patient can be immediately ventilated even if you do not have the facilities of Thrive and other things. The Magic atomizers, these are the atomizer which enhance the topical anesthesia delivery and maintain airway patency during delicate airway procedures. They not only tropicalize the oral, nasal, or pharyngeal tissue, but also keeps help the airway open. Then we have the hybrid disease. Hybrid disease means the diseases like the total track. We have MO which combines the video laryngoscope and laryngeal mask airway features, offering picture-in-picture view for superior visualizations. So they combine the video laryngoscope and bronchoscope into one, available now. They are available in the gyroscope. Vision guided supraglottic insertion, yes, they are the newer device where it includes the video laryngoscope mask and safe LM, which allow the precise placement with less tissue trauma. The main advantage is that they can easily insert it under the direct vision and facilitate tracheal intubation through the supraglottic airway device if needed. And moreover, they have the ability to detach from the scope once placed, thereby facilitating the reuse of video laryngoscope. Now comes the ultrasound. Now, you know, everyone is nowadays is having the facility of ultrasound. Ultrasound in airway, it provides a radiation-free, quick, and effective bedside method, not only to assess the airway anatomy, but also to identify the narrowing or dynamic changes safe. So the things that initially we used only the ultrasound, but now CT and MRI are also available, but they are costly and sometimes causes the radiation. That's where ultrasound deals. See, if you see these pictures, the tracheal tube can be seen, the air mucosal interface can be seen. You can see the thyroid gland, you can see the narrowing, the tracheomalacia if required. So all the things are possible with ultrasound of airway now. There was a paper published from the Rishikesh where they have used the dynamic ultrasound assessment of airway in the patients of the goiter. So as I told you, the tracheomalacia narrowing can easily be seen, especially in the smaller children and the big goiter. Everyone now discuss about the focus, the points of care ultrasonography. Its role in difficult airway scenarios is now established, and planning of the airway management options pre-op can be done with the help of this focus. So it is another way where we can use ultrasound. Now 3D reconstruction of airway. Yes, the CT-based 3D reconstructions helps to visualize the complex airway anatomy, assisting the precise surgical and anesthesia planning, especially in the pediatric and anatomical analysis. If you can see, this is the 3D model of the ear. It can be used from the thoracic CT data set, can transparent 3D plastic models of the glottis, cricoid trachea, and proximal mid-bronchi, and can be used for the intubation, like the lung resection method, where 3.5 micro cup tube with cup placed in trachea and tip at the carina can be seen if it will be possible during the one lung ventilation or the microlaryngeal surgeries or during the subpneumonia. Now, as the anesthesia advances, the oxygenation always remains the paramount. So apart from the intubation methods, the methods of oxygenations are also developed, which emphasizes the thrive, the technology delivers the warm, humidified, high flow oxygen by the nasal cannula, prolonging the safe apnea during airway management, decreasing the hypoxia risk. The another things which is now important everyone discusses the simulators in anesthesia. So a typical simulation anesthetic, it involves a patient management scenario where a learner is asked to conduct an anesthetic on a simulated patient. What it becomes? It immerses the learners in realistic clinical scenarios using many coins, VR technology, the computer models, and the cognitive skills without any patient risk. You can learn from the mistakes, you can correct, and there is always a guide who knows how to know what thing has been done wrong. All things are recorded, can be checked later on. So if you see, this is a medical patient simulator where the things can be done on this, and from intubation to any advanced procedure can be done with the help of this. These are simulators are various of types. The main, as I told you, part task trainers, the computer-based systems, where there is no physical components, only the computer algorithms are done, where scenarios can be conducted. Integrated simulator models, which includes a whole body coupled with a computer, so that the whatever you command is giving to the computer is manifested, is reflected on the body. The VR and haptic systems, which are especially used for the endoscopic and laparoscopics, and simulated patient environment, where for the layperson or actor trained to portray the specific medical rules or symptoms for a particular crisis situation. Apart from that, the newer thing is low flow anesthesia with guided simulation. It means simulation training immerses the clinicians to safely apply the low flow anesthesia technique, decreasing the gas use and environmental. So there is always some computer attached which guides you how much slow flow is to be kept, what are the calculations, all are seen. So basically, it's a model of the air. Tele anesthesia method. Tele anesthesia enables the remote perceptive evaluations and even the anesthesia delivery through automated systems, extending reach and efficiency, relevant in military and emergency medicines. So it is a place where you can laugh or quite far from your place. You can tell if you have heard the news where Chinese complex surgery was done, thousands of the meals apart by the surgeon. This was basically, similarly, the anesthesia and other things, they all were controlled remotely. This was supervised and the proper instructions was given. So all this becomes a part of the tele anesthesia. There is a famous paper on that which says that the use of electronic information and communication technology supports healthcare when distance separates the participants. And India is characterized by low penetration of healthcare services, where PSC facilities are highly inadequate. So in India, the scope of telemedicine is quite bright. Now, apart from the telemedicine, we have the Type 2 care. These can be used for PSC and telemedicine. The Type 2 care includes an otoscope, stethoscope, and a basal thermometer. So it's a device which can be used, patient can use, and you can remotely set how to use them, where the things are recorded, and it is transferred to you in the real time. You can see in your computer on your phone. So practical application, if you ask me for the telemedicine, I will say they are the automated and remotely controlled anesthesia delivery platforms, like automatic critical care systems, the Auto TIVA. They are being titrated to provide the safe anesthesia even in the remote or hostile environment. So all these are the newer admissions in the anesthesia. These systems are used for the critically, especially in the military warfares or other times of like casualties like earthquakes, the drowning can be used easily. Futuristic advancement, emerging AI technology, everyone is now aware of robotics. You must have seen in your OTs, advanced devices, nanotechnology. They all transfer the anesthesia safely and efficiently and with precision. And you know the latest is being the gently target medicines. Artificial intelligence, where large language models in histology for are being used for how the anesthesia is models are being developed from time to time. So they all support the high accuracy tasks like depth monitoring, event prediction, drug delivery optimizations, and enhancing the clinical decision making. There's post-op pain management and chronic pain. The role of the artificial intelligence is all well established, where things are done with the software capable of predicting the pain level and analyzing response, allowing for increasing individualized care. So as I told you, from the depth of the monitoring to the pain control to the operating room logistics, all can be done with the help of these artificial intelligence. Robots, yes, can be used for operation, not only for intubation, but not for operation, but now they are being developed for intubation also. Intubation, laryngoscopy, ultrasound, all things can be done with the help of robots, as you can see in those pictures. Mechanical robots are there, as I told you, for the regional anesthesia procedure and endotracheal intubation are being developed, not in India, but in the Europe and the China. They have been used in the trial cases. If you see, these are the mechanical robots. Their arms are developed, where the video assistants perform the automatic or semi-automatic intubation, nerve blocks with safety and efficiency. Newer technology, if you goes to the real well ventilator, which is a portable ventilator suited for all age and settings, offering volume and pressure support with automatic lead compensations. And the beauty of this ventilator is that it can be used at home with minimal settings. So, or these things in the very compact type of ventilator, which can be used at home or in the surrounding, where it can be kept with the patient if the patient has to be traveled from one place to another place. CLAT, you know, the world's first phone AED. This innovation integrates the AED into a phone case, the guiding users through the CPR and the delivering shocks automatically in the cardiac emergency responses. So if you see, everything is the chip is inserted in the phase in the phone case, and with the lead which is that can be attached to it, the shock can be delivered. Apart from that, we have the new CPR devices. You must be all knowing, like the rescue POD and rescue pump, where can be pumped, CPR can be done as well as the respiration can be given with the help of these devices. We have the smart spirometers. They are portable smart spirometers connected via Bluetooth to your smartphones, allowing the patients to monitor lung functions in real time, lung functions, enhancing the self-care and clinical follow. So the peak flow, the FEV1 are now available on your smartphone whenever you are quite far from the patient. And they are ideal in the self-management of asthma, COPD, cystic fibrosis, where you can send your findings to your physician or the anesthetist. Another new things are, if you remember, the glucose chin up, which is designed to keep the airway open during the monitored anesthesia care, especially in the cataract surgeries, during the TIVA, sedation procedures, where the patient are prone for the OSA or the snorings. And the SAD lines. SAD lines use the bilateral easy that leads to monitor the brain activity during pediatric anesthesia, providing continuous feedback to enhance the safety. And nowadays, the thing is used is the CONOX, which is a monitor, like the entropy or the easy monitor. It not only measures the depth of the anesthesia called the QCON, the consciousness. The value is typically between 40 to 60. It also measures the pain assessment during the procedure. It should be between 30 to 50 or 30 to 60 in somewhere. We are called as a QNOX, that is a noxious. So it can be used as an assessment for the fentanyl or the opioid infusions, intra pain with your blocks. These type of monitors are very helpful. If you see this video, I show you. Okay, so these from there the readings can be changed easily, and we have the app-based mobile ultrasounds where the leads are connected to the mobile, and you can in the real time can see all the findings on your mobile. But these needs the clearance from the PIDT centers if you are using, otherwise it can be ethically wrong. So these smartphones not only allow the imaging at the point of care, but also enables the rapid huge quality bedside diagnostic. So it's very useful if the person who is using the ultrasound is well efficient, proficient with them, can be used safely. And recent in the epidural anesthesia, new text like balloon tip syringes, like by the this is by the with the balloon that collapse in the epidural spaces, AI powered 3D system with automate epidural space identifications, and acoustic systems which can predict with more than 94% accuracy, improving the safety of the epidural anesthesia. Genomic medicine, the latest thing. Genomic medicine, they help the genetic testing, which predict the individual responses to the anesthesia drugs, allowing the personalized dosing to maximize safety and efficacy. These genomic projects are managed to decode around approximately 92% of the genome, and the testing kits have become very affordable in the future. So nanomedicine, another technology to the local anesthetics where the post-surgical pain pathways may use the target like the sodium channel blocker, the potassium channel blockers in sensory neurons, calcium channel blockers, and in the various types of others like cancer drugs by the nanoparticles, or are possible with this nanotechnology. So this technology enables the targeted drug delivery and imaging with potential future application including the nanorobots for precise post-op anesthesia. The best part is that it can have the radiation. You can see where the drug is going in the body because of the the radiation part of this drugs. Genomic medicine, as I told you, genomic medicine is the another where like you can see which gene of particular is susceptible for a particular response. For example, dexmedetomidine, we have variable vasoconstriction because of the genetic variation at the AR alpha 2BD allele of the genes. Similarly, SLCO1B1 gene is susceptible for statin-induced rhabdomyolysis. RMD receptors and the GABA receptor, gamma aminobutyric acid receptor, they have the different hypnotic effect for the propofol and etomidate. Similarly, for the other, like for genetic polymorphism exists, which decides the effect of the drugs in various delivery systems. Automation means the closed loop anesthesia delivery system, also called as the CLADS, which adjusts the drug doses in real time based on feedback parameters like end-tidal CO2 and brain activity, allowing the precise automation. If you remember this famous diagram of the CLAD where there is a central computer called the memory of the computer, it is with the there is a vital machine is attached, the depth monitor is attached, and the syringe pumps are attached of the various where the computer chip is controlling each and every infusion as per the vital sign of the patient. So this is a closed system called as the closed anesthesia delivery system as a CLADS. These systems were first developed for specific parameters like including EEG monitoring, fluid resuscitations, but now are variably used for cardiac and the transcatheter aortic valve surgery. They are independent closed loops for hypnosis, analgesia, fluid management. So every part can be managed from fluid management to the pain management to the deeper surgery. The high-risk surgery can be used with the use of these CLADS. Now we have the famous anaconda in anesthesia, also called as the anesthesia conserving device, anesthetic conserving device. This device is a device which delivers a safe sedative dose of either SIBO or isoflurane to the patient using existing critical care ventilators, common saline pumps, and gas monitor. So it's a modified heat and moisture exchange device which replaces the conventional HME filter. What happens? It decreases the OT pollution and aims for the green OT as well. So Anaconda is the latest development. We have the smart glasses in the operating rooms, which project the ultrasound images into the anesthesiologist's field of vision. So you do not have to move your hand. You just can see what is in front, and that is very close. It enables the hand-free focus on the patient and improving the procedural accuracy. Then Sapphira is a nerve block device. It enables the nerve block safety by automatic pausing injection if the patient exceeds the safe limit by minimizing the nerve injury risk. So if it detects the pressure more than 70, the 3 unit below the maximum, that is the 20 where nerve damage can happen. At 70, it cuts off the flow from the needle, the needle which we are using for the needle blocks. So that is the another safety device which has been developed. Then regional nerve blocks, the drugs which has been developed like the liposomal bupivacaine and perineal catheters. These are like they are commercially available and have the lesser side effect than the initial one. And perineal catheters can be inserted using the ultrasound guided approaches, including they have the advantage of flexibility and control with regards to the block duration and intensity. Truncal blocks, quadratus lumborum, 3 approaches, the anterior, posterior, lateral. They are the newer additions, electrospiny. It was developed in 1216, although it's quite old, but it's a newer advancement. Costotransverse foramen block, which are alternated to thoracic paravertebral block. Modified MTAPA, that is called the perichondral approach thoracoabdominal nerve. Yeah, it's a novel approach which provides the effective analysis of the anterior and lateral abdominal thoracoabdominal wall during the laparoscopic surgery. Apart from that, the new blocks are developed as per the convenience in standard analysis. Newer drugs, Sugamadex, which is FDA approved only in the 2015 and can be used anytime for the rocuronium and now the vicronium reversal. And they are very much faster than succinylcholine for rapid sequence intubations. Can be used. Sufentanil for sublingual use. It was used as a IV or oral, but for sublingual, which has been only approved in the 2018 as a tablets, and it is 5 to 10 times more potent than the fentanyl. Dissolves immediately under the trunk in seconds and with the immediate effect. We have now the injections, new hypnotic drugs, new models, and new applications. Ramimazolone and ciprofol, which has been approved and is now in the user. The S-ketamines, the phosphopropofol, and the other drugs, which are the both benzodiazepine derivatives, propofol derivatives like ciprofol and phosphopropofol, etomidate derivatives like AVP 700 and ET26, and the steroidal like the Faxine. These few are in the preclinical stages, few are in the clinical, and like the Ramimazolone, ciprofol has been approved. Ramimazolone, as I told you, is only approved in 2020. It's a GABA receptor binding receptor, and it is very rapid onset of sedation compared to the midazolam, even though it is less potent. Effect can be antagonized anytime with the flumazenil. Ciprofol and phosphopropofol, as I told you, these drugs have the no lipid formulation, causes the minimal pain on the injections, and of the chemical structures similar to the propofol. However, the potency is of ciprofol, remember, it's 5 times more than that of the propofol. Esketamine, everyone talks about, is approved recently by 2019 by the FDA. It provides 2 times more anesthesia than the ketamine, 3 times more analgesia, as it's a receiving injection for anesthesia. It is used as a general anesthetic drug and as a nasal spray for the treatment of major depressive disorders. Bioavailability by the nasal is 30 to 50% and elimination T-half is 5 hours. Isotonitazine developed in 2019 as a derivative of benzodiazepine opioid analgesic, 500 times more potent than morphine. However, it has the potential for drug abuse. Schedule 1 drug, remember, chance of addictions and misuse are very high. Then we have the new models. You know, the pharmacokinetic and pharmacodynamic, like the various methods which we used in our T-shape pumps. Models like the Elevate and Dick, they are the newer method for the propofol, and Dick method for the dexmedetomidine, and Hennivoort Collin model. They have the 5D component, the pharmacodynamic component. These have been developed across the ages and weights for agents such as propofol and dexmed, and can be used by the target control mechanism. So you should know that the newer like Kataria and whatever Schneider, the previous model that we used to have, Schneider's, Kataria, and other models, which are now the older model. But these models like the Elevate, Dix, and Hennivoort model are the newer models. IV caffeine has been used recently, suggests that can be used for the hasten emergence from the anesthesia, representing their future recovery aid. But the dose is 25 mg per kg. However, it is still in the experimental phase. Guidelines have changed since then, and it is changing every year. So as an exam going student, you should know what guidelines have changed over. The recent guidelines are of 2022 acute and chronic pain. the August 2022 of the combination pharmacotherapy for painful diabetic neuropathy, cardiovascular anesthesia for the acute kidney injury during these surgeries, the PP and oxygen target during the sudden cardiac arrest, where the things have been changed from 77 to 63, and PO2 target from 68 to 75 to 98 to 105. The prothrombin complex concentrate versus the fresh frozen plasma during cardiopulmonary bypass, April 2025 latest guidelines. Prophylactic use of inotropic agent during cardiac surgery, January 2025. Guidelines for perio management of patient with pulmonary hypertension and right-sided heart failure. Laryngospasm during pediatric sedation outside the operating room, 2022 guidelines. Perio management of biological disease modifying anti-rheumatic drugs, the September 2022 guidelines. Then we have the timing of surgery after ischemic stroke, December 2022 guidelines. Marker liver fibrosis, risk of surgical mortality, December 22 guidelines. Elevator FIB4 score, which consists of A's, aminotransferase, platelet count, and is for the surgical mortality in the obstetric jaundice and the Fippers process. December 2022, we have the pre-operative exercise training before lung cancer resection surgeries and updated multidisciplinary guidelines for peri-op blood management during the November 2024. These are the few some guidelines, and apart from the latest one is the ASRA guidelines for regional anesthesia, which everyone should remember all the guidelines, the blood components and their alternatives 2022, and the newer society guideline for neuromuscular blockage, which is very important, January 2023. This is that Sugama Dex for reversal rather than myostatin for patient who have received the rocuronium or vecuronium and who have the residual block at or deeper than a train of 4 ratio of 0.4. So if it is more than 0.4, go for the Sugama Dex. So to conclude, I will say that anesthesiology continuously evolves through the innovation in technology, pharmacology, and personalized medicine. Our approach to innovation as provider and innovators will determine our standing after these development changes are felt and how they change our field. Future is here. Our engagement with innovation will determine our share of its prosperity. Thank you very much. I would like to say that these basics are there, although there are more innovations which cannot be discussed because of the time constraint. If you have any questions, you can ask.
Thank you, Dr. Lalit. I guess it was a brilliant talk on, in short period of time, you have covered almost a whole lot of things in the recent advances in anesthesiology, starting from drugs, various equipments, the lines, catheters, consumables, the AI models, the closed loop anesthesia delivery system, and yet you spoke about the genomics and precision medicine as well. So I think there is nothing much to add into it. You spoke about newer guidelines as well and newer, the recent latest studies as well, which the students should be aware of. So I don't see any questions in the chat box. So if any other faculty members want to make any comment, or else we move ahead thinking about the lack of time. Okay, I guess we should proceed now to the next lecture. So the next lecture is on the electrolyte disorders, specifically calcium, magnesium, and phosphates, and it will be delivered by Dr. Abhishek Sharma. He is the senior consultant in Max Super Speciality Hospital, Saket, New Delhi, and his special area of interests are bariatric anesthesia, trauma, airway, and regional anesthesia. So over to you, Dr. Abhishek.
Respected organizers, respected chairperson, seniors, students, and dear friends. We're now going to discuss about three important minerals: calcium, magnesium, and phosphorus. Now, calcium, magnesium, and phosphorus are important extracellular and intracellular functions, and their functions are closely linked. And the metabolism is often linked through common hormone signals. Therefore, you will find that much of their symptoms, cardiovascular and neurological especially, are quite similar. Now, Bone, we'll now discuss about all the common aspects of these minerals. Bone acts as a reservoir for all the three. In the bone consists of inorganic and organic phases. In organic phases, the most important component is hydroxyapatite, which has calcium and phosphate as much of its components. Magnesium also resides in the bone on the surface of the hydroxyapatite crystals, and about 1/3 of it is exchangeable. Now, these minerals are transported from blood, bone, renal, and GI cells and vice versa during their homeostasis. Now, their transport is mediated by energy-dependent cellular transport or passively by paracellular transport. Now, these mechanisms also involve corresponding co-transportation of other minerals like sodium, potassium, chloride, and bicarbonate. And the three target organs are the main organs which are involved in homeostasis are the gut, the bone, and the kidneys. Therefore, abnormalities in these elements are very often linked together. Yeah. Sorry about that. So there are three important hormones which are important in the homeostasis of these minerals: parathormone, vitamin D, and calcitonin, which act on three important systems. That is the skeleton, the kidney, and the GI tract. Just remember these three. These are the most important factors. The other hormones which are responsible are the fibroblast growth factor and the estrogen. Now, both FGF and estrogen mainly act on the renal tubules and are important mostly in phosphate metabolism. Now let's see, we'll start with parathormone and build up on the homeostasis. Parathormone is stimulated by low ionized calcium, and it has three main actions. One is to activate vitamin D by alpha hydroxylation. Other action is on the bone, and third one is a direct action on the renal tubules. This causes increased reabsorption of calcium from the tubules, decreased absorption of phosphate from the proximal convoluted tubules, and this vitamin D hydroxylation is also stimulated by low phosphate in the blood. And vitamin D has again three important actions, just like parathormone. One is on the gut, one is on the renal tubules, and another is on the bone by stimulating osteoblasts, thereby increasing deposition of calcium in the bone. That is what vitamin D does. The parathormone will cause increased resorption of calcium from the bone via osteoclasts. So calcitonin has the opposite effect. It is stimulated by hypercalcemia, and its effects are mostly just opposite of parathormone. Now, a few important factors. Magnesium is a negative regulator of parathormone, just similar to calcium. Mild deficiency will increase the PTH secretion. However, a severe deficiency might paradoxically block the parathormone secretion. So in cases of hypocalcemia, which is refractory, it is important to check the levels of magnesium also, which might be secondly causing hypocalcemia. There are certain important receptors which are involved in the metabolism. One is the receptor activated nuclear factor kappa, the rank, and the rank ligand, which are present on osteoblasts and osteoclasts, which is stimulated mostly by vitamin D, prostaglandins, and various cytokines, which act on the osteoblast to cause bone remodeling. In adult, about 5% of the bone mass is under continuous remodeling, right? So the another one is calcium sensing receptor, which is actually triggered by the foreign ionized calcium in the blood, which inactivates the calcium receptors and causes increased secretion of the parathormone. It has a similar response to blood magnesium levels also. Then there are certain cation channel family receptors and sodium dependent phosphate receptors, which are important in the absorption of calcium and phosphate from the gut. Now, the reason I'm mentioning it is because the common receptors, which when mutated can cause genetically or congenital problems in metabolism of these minerals. Now, coming to calcium, biological functions of calcium are very important, and they're very important cell signaling. They act either as a direct signal transduction or they act as a second messenger. It regulates a large range of physiological cell functions in the body. It acts on many enzymes and proteins, muscle contraction, nerve transmission, cellular motility, and growth. And together with phosphate, it is also important in bone mineralization. Now, the net calcium balance in the body is 0 in an adult. However, in children and in pregnancy, there can be a positive balance of calcium. And about the total amount of calcium in the bone is about 1 kg. Right? So 99% of the calcium in the human body is in the bone, and 1% is in the extracellular tissues. Out of these 1%, which is in the blood, the normal value of calcium in the blood is about 8.5 to 10.5 milligram per deciliter. 50% of this is ionized, about 5.4 milligram per deciliter. The rest 40% is protein bound, mostly to albumin, and the other can be anion bound, a complex other ions like phosphate and citrate. So it is this ionized calcium which is important, which is physiologically active, and which is important to us. Now, of this, about non-diffusible is 3.5, whichever is protein bound is non-diffusible, and diffuse. Rest of it is diffusible, which is physiologically active. So when there is saturation of calcium, it will result in deposition of calcium into various tissues, and will cause the kidney stones, and deposition to various tissue, causing tissue calcification. The important point again is to note the ionized calcium. It is tightly regulated because of its physiological role. Another important factor is the pH in the blood. So pH will cause the concentration of ionized calcium to vary. So in case of alkaline pH, there will be more binding of calcium to the albumin, thereby decrease ionized, physiologically available ionized calcium, and this may cause symptoms in case of alkalosis. So again, hypoalbuminemia theoretically can decrease the amount of bound calcium and lead to a decreased reported total calcium. And so calcium has to be adjusted in case of derangement in albumin concentrations. This is an equation which is used, is the Payne equation, which gives the correction of the calcium levels in the blood. However, this may be inaccurate in case of severe extreme situations, and it can actually overestimate, can give incorrect diagnosis of hypercalcemia. This is especially important in critical care patients, and where you need more important accurate assessment of ionic calcium, and ABG can be done in these patients to have a more better value of ionized calcium. Again, hypocalcemia, coming to hypocalcemia, less than 8.5 milligram per deciliter, or ionized calcium less than 4.65 can lead to hypocalcemia. Again, in general population, it's quite rare, and the most common cause in general ambulatory population is vitamin D deficiency. However, in case of hospitalized patients, especially in intensive care patients, the incidence can be as high as 85%. Now, again, the symptoms will depend on the rate of development and chronicity of hypocalcemia. So usually it is asymptomatic in mild deficiency. In severe deficiency, symptoms can be seizures, tetany, laryngospasm, and if the value of ionized calcium is less than 0.5 millimole, there can be muscle cramps, seizures, arrhythmias, and prolongation of QT interval. And now again, since it is important in muscular contraction, there can be weakness. It can cause increased nerve excitability, which is evidenced by the Shostak and Tozius sign. Tapping of the nerve, or the facial nerve, which we call contraction of the facial muscles on the ipsilateral side, and the inflation of the PP cuff for above systolic for about a couple of minutes can cause the adduction of thumb, flexion of the wrist, flexion of the MCP joints. This can be a sign of impending severe hypocalcemia. Now, again, in the ECG, there can be QT prolongation. This is an ECG of a post-thyroidectomy patient where QT prolongation can be seen. These are all signs of severe hypercalcemia. Just some mnemonics for you to remember: CATS, spasmodic, or cramps. They can be used just to remember the symptoms. Many of the symptoms you will find quite common in other electrolyte abnormalities, as you'll see again in this presentation. Now, coming to the causes of hypocalcemia, you can divide them into high or normal parathormone or other causes. So in case of low or in normal parathormone, the most common cause is post-surgical, and which leads to hungry bone syndrome, and there's rapid movement of calcium to the bone from the blood. Autoimmune causes, congenital causes, gland destruction due to infiltrate diseases like sarcoidosis, hemochromatosis. In case of high or secondary, or it's called pseudo hypoparathyroidism, the result can be due to vitamin D deficiency. Chronic kidney disease is a very common cause of hypocalcemia in admitted patients. Secondary or even tertiary, secondary hypoparathyroidism. Then other cause could be pseudo hypoparathyroidism, where there is high PTH, low calcium, and high phosphate levels. Again, magnesium imbalance, when hypomagnesemia can be caused due to PTH resistance. Other causes can include pseudo hypocalcemia, where is low albumin, causing false report of hypocalcemia. Acid-base disorders, again, alkalosis can reduce ionic calcium. Acute pancreatitis, again. So these are just a list. Acute pancreatitis, in you can have fat necrosis and calcium precipitation. Magnesium, massive blood transfusion, where saturated blood binds to the calcium. It's just the point just we have discussed. Just have listed out. You can read this in the PDF that we'll share. Again, osteoblastic metastasis in prostatic cancer, for example, there is increased uptake of calcium by the bone. Medications are important. Loop diuretics are a very common cause, and it's important to note that thiazides will inhibit the excretion, causing hypercalcemia, but Lasix, furosemide, will stimulate the excretion, causing hypocalcemia. Other drugs can be glucocorticoids, estrogens, bicarbonate, which can result in hypocalcemia. There's just an algorithm just to go through. So once we have a value of the calcium levels, we have to rule out pseudo hypocalcemia, measure the ionized calcium required, especially in critical cases. Consider the medications, take a proper history, and evaluate the patient if the patient is on medications. Measure parathormone. If it is high, the cause could be due to CKD, kidney disease, or due to tumoritis or pseudo hypoparathyroidism in case the kidney functions are normal, or it can be due to vitamin D deficiency. And magnesium levels should also be checked if there is the PTH level is normal, and its cause could be due to magnesium or genetic causes, as we have seen in calcium sensing receptor mutations. Again, so the treatment will depend on severity of symptoms. Intravenous calcium is usually required for severe symptoms. Where there's prolonged QT interval, there can be arrhythmias. Again, calcium gluconate is usually preferred, although calcium chloride will have a higher elemental calcium, but you can use either of them. Calcium gluconate has less tissue necrosis, and patients may require continuous infusion in case of based on the clinical features and the calcium levels. Avoid mixing bicarbonate or phosphate, as it can precipitate calcium salts. Right. So again, avoid aggressive correction, especially in acute cases, especially in patients with shock, with the decreased tissue perfusion, as it can increase perfusion of the tissues and cause calcium overload. For less symptomatic cases, milder cases, calcium carbonate and calcium citrate can be used for the treatment. Again, disease-specific management, post-surgical hypothyroidism is usually transient. Hypomagnesemia, correct the magnesium first. Then recombinant pH can be used in case of hypoparathyroidism. In CKD, vitamin D can be given because that's the causative factor of hypocalcemia. So hypercalcemia, again, the two most common causes are hyperparathyroidism and malignancy. Now, in case of primary hyperthyroidism, the treatment, the duration is usually long-term. Patient is usually stable. Malignancy, patient can be acutely unwell, and the levels, again, the severity of the levels more than 14 and milligram per deciliter can cause severe symptoms of hypercalcemia. So as we have seen, the cause just listed out. Tertiary hyperparathyroidism, just to point it out, can be found in chronic kidney disease, which is basically this hypertrophy of the parathyroid gland. Drugs, thiazide diuretics, which will reduce the excretion of calcium, and vitamin D excess, and lithium, these drugs can cause. Again, just list out most of the medications that are there. So the symptoms are, again, you will see fatigue, lethargy, confusion. Again, just the opposite of hypocalcemia. There can be nausea, vomiting, palpitations. There can be altered mental state. Must see the signs for kidney injury, acute injury. There can be decreased urine output, arrhythmias. Just a mnemonic for you to remember the symptoms: bone groans, bone stones, drones, and psychiatric overtones. So again, for this algorithm, you can, once you've measured the ionized calcium, consider medications, consider measuring parathormone. If it's normal, it can be renal failure. It can be due to tertiary hyperparathyroidism. And again, rule out malignancies. It's an important cause. So bone mets, myelomas, lymphomas can be there. You have to rule it out. Right. So one of the first step is maintenance of intravenous volume. Hypercalcemia will cause calciuria and thereby dehydrate the patient. So hydrate the patient using 0.9% saline, and lasis can be used, but then again it can cause hypovolemia again. So it should be used judiciously, and measure and correct other electrolyte abnormalities of potassium, magnesium, and phosphate if needed. Other steps can be increase calcium elimination, reduce GI absorption, decrease bone absorption, and the specific treatment. So these are some of the medications which can be used. Senecalcet is used in hyperparathyroidism when surgery is not an option. Bisphosphonate is commonly used in case of kidney disease. Right. So parathyroidectomy can be done in case of primary hyperthyroidism where there's parathyroid adenoma. And the following, these are some of the criteria which are to be met for hyperparathyroidism. Other therapies include the renal replacement therapy for severe hypercalcemia with renal failure, where calciuresis active is not an option. And these are just for historical importance, some of the agents that we used previously. And of course, treat the underlying cause, for example, malignancy, hyperparathyroidism, or vitamin D toxicity. Coming to magnesium, magnesium is mostly intracellular ion, and it is a very important function as it functions as a coenzyme for over 300 phosphate transfer reactions, which are involved in energy production. So it is critical for energy transfer, storage, and use, and is mostly regulated by the kidneys and controlled by tubular reabsorption. So about, as we have discussed, about 1/3 of magnesium from the bone is available for transfer. Less than 2% of the body in the serum is in the blood, and about 50 to 70% ionized. 20-30% is protein bound. Again, we have seen the many functions. These are just out some of the functions of magnesium in the body. Now, in case of anesthesia, magnesium is used extensively. It enhances analgesia, sedation, muscle relaxation, cardiac stability, and it's used in various doses in anesthesia. Just a tablet form, just for you to just list out. It is also used in bronchospasm, bronchial asthma as a second line or third line agent. Now, the normal value of magnesium is about 1.2 milligrams per liter, of which about half of it is ionized. Again, listing out some of the symptoms depending on the levels of magnesium. Severe symptoms can happen more than 12 milligram per deciliter or 10 milligrams per liter, which can lead to muscle weakness, coma, heart block, severe bradycardia, and respiratory distress. In case of hypomagnesemia, the levels, the symptoms can be severe in case the values are less than 1.2 milligram per deciliter, and you can see symptoms similar to hypocalcemia, tetany, nystagmus, seizure, psychosis. Many of the symptoms, as discussed before, are quite similar. So again, decreased intake. These are some of the causes. Can be due to decreased intake or redistribution from extracellular to intracellular compartment. For example, in refeeding syndrome or correctional metabolic acidosis or in acute pancreatitis. They can be increased GI or renal losses, like as in acute diarrhea and hungry bone syndrome, post thyroidectomy or parathyroidectomy, acute pancreatitis. Genetic disorders like Bartter syndrome, Gitelman syndrome, all these can cause hypomagnesemia. So medications, as we discussed, loop and thiazide which increase excretion of magnesium, decrease reabsorption of renal tubules, and that can lead to hypomagnesemia. So early presentation can be very vague, nausea, vomiting, loss of appetite, and in severe cases, there can be neuromuscular hyperexcitability. Just like hypercalcemia, you can see tetany, drowsiness, and Shaw's sign, seizures, psychosis, apathy, delirium can be seen. Cardiovascular manifestation, again, ECG, there can be widening of the QRS complex, peak T waves, prolongation of PR interval, and diminution of the T wave, basically slowing down of the ECG. There can be premature systoles, there can be AF, atrial fibrillation, ventricular arrhythmias, and cardiac ischemia. Now, again, it can also increase the risk of digoxin toxicity. Other electrolytes should be checked, especially calcium, and checked for potassium and hypoparathyroidism also. Now, it's common in medical wards and it's very common in ICU patients. Is usually depression is usually overlooked. And once you suspect these signs, then electrolytes in total, including magnesium levels, should be done. Treating the patients is based on the kidney functions, the severity of symptoms, and the hemodynamic stability. Again, initial investigations should include all the electrolytes, the kidney panel should be done. The tools that can be included, the other diagnostic tools are serum magnesium. 24-hour excretion should be done. It helps in differentiating renal wasting or kidney as a cause of magnesium deficiency. Magnesium loading tests, it identifies assess the intestinal absorption of magnesium and the indirectly assess the bone status also. Now again, intravenous preparations are available 50% magnesium sulfate, which contains 1 gram in a 2 ml ampule. Oral preparations include magnesium chloride and magnesium oxide tablets. So IV intravenous magnesium is used in severe cases, severe arrhythmias like polymorphic VT, TDP, tossitis depointis. 1 to 2 gram is used. It should be diluted and given over 2 to 5 minutes. And the infusion can be given depending on the clinical situation. It's also used as a second line drug in acute asthma. Same 1 to 2 gram can be given slow IV. Again, for eclampsia, IV, these are the regimens which are used, the Pritchard regimen and the IV regimens. So once we use these magnesium, these are, you have to watch for the signs of hypermagnesemia, the patellar reflexes, respiratory rate, renal output should be monitored, and severe hypermagnesemia, it can cause respiratory paralysis and cardiac arrest also. So basically, we have just discussed hypermagnesemia, the features, symptoms are the same. So the cause for hypermagnesemia can be decrease in excretion, compartmental shifts, or increased intake, right? Now, the most common cause is the chronic kidney disease, by far the most common cause of hypermagnesemia. Again, so serum magnesium levels should be done and complete renal workup should be done in case of hypermagnesemia. Electrolytes levels should be checked and ECG should be done. In mild cases, basically just we have seen, stop all the magnesium you are giving. It can be iatrogenic, so whatever you give, just stop it and it should settle down within a day. Symptoms should settle down. In severe cases, monitoring is required and ICU admission may be required in case of problems. ECG, blood pressure, neuromuscular signs should be monitored, and intravenous calcium gluconate can be given, which is an antagonist for magnesium. So again, the goals are to enhance the excretion. You can give loop diuretics, hemodialysis for in case of renal failure patients in which diuresis is not an option. Again, ICU care may be needed. In eclampsia, as we have seen, again, stop the infusion and monitor the signs for hypermagnesemia. So come the last one, phosphate. Again, normal inorganic phosphate levels in adult is about 2.5 to 4.5 milligram per deciliter. Children, men can have a higher level. So phosphate is important for bone and cell membrane structure, and ATP, oxygen transport, and acid-base balance. Again, it is closely linked with calcium in its metabolism, right? So so the intake is and the excretion are usually, it is a net zero balance again. Important point is the sodium inorganic co-transporters, which are important in absorption of phosphate from the gut and from the intestine. Again, FGF that you discussed is important. It promotes the phosphate excretion in the kidneys. So in the blood, inorganic phosphates are completely ionized and present as hydrogen phosphate or dihydrogen phosphate in ratio of 4:1. Plasma phospholipids consists of mostly of phospholipids, ester phosphates, and inorganic phosphates. This is some of the biological functions of phosphates. Now, one of the most common cause of hyperphosphatemia is renal failure, and other can be due to acute phosphate load, cellular shifts. Pseudo hyperphosphatemia is present as a laboratory artifact seen in patients with hyperglobulinemia, increased lipids, and increased bilirubin. Now, in case of severe cases, symptoms are mostly cardiovascular and neuromuscular. And you can just remember that hyperphosphatemia and hypocalcemia, the features, symptoms could be similar. They can be tetany, they can be hyperreflexia, and they can be positive signs for increased nerve excitability. In chronic situations, there can be bone weakness, fractures, and precipitation in soft tissue and of calcium and phosphate. Now, diagnosis again, hypophosphatemia, repeat the testing, again, check for the renal function and other electrolytes, very important. Rule out hemolysis syndrome, vitamin D intoxication, and pseudohypophosphatemia as in lab artifacts. So, urinary phosphate can be differentiated with renal external causes. Incidental X-rays may show metastatic calcification for the diagnosis. And now this is if you find hypophosphatemia and CKD, these are some of the guidelines for monitoring phosphate, calcium, and PTH and vitamin D according to the GFR levels. So again, phosphate level should be maintained less than 4.5. In dialysis and CKD patients, dialysis, it should be towards the normal lower limit of the normal. And approaches, the goal is dietary restriction, phosphate binders, diuresis, and dialysis. So these are some of the phosphate binders which are used to reduce the absorption of phosphate. Now, nicotinamide and tenapanor are used, which act on the sodium and phosphate co-transporters, which inhibit them and reducing absorption. Dialysis and secondary hyperparathyroidism, dialysis alone may be insufficient and may require other medications like the phosphate binders, vitamin D analogs can be used. These are some of the targets for dialysis for phosphate and calcium levels in CKD patients. So hypophosphatemia, again, they can be inadequate phosphate intake or due to GI losses or due to renal phosphate wasting. These are three of the common ones. The other ones can be redistribution to the cells. They can be hormonal causes, secondary hyperparathyroidism, and in cases of dialysis, there is excess removal of phosphate during dialysis. This is the algorithm for the approach of hypophosphatemia. Clinical effects are usually seen when the levels are below 1 milligram per deciliter. And they can be neurologic, they can be irritability, confusion, and seizures, muscular features, weakness, rhabdomyolysis, again respiratory failure in case of severe cases, cardiac arrhythmias, and decreased contractility. So oral replacement is preferred for mild and moderate cases. Commonly used preparations are for intravenous preparations are used for severe cases. Commonly used preparations are sodium phosphate and potassium phosphate. The dose can range from 1 milligram per deciliter to 1.2 milligram per deciliter given over 6 hours. Again, the dose should be adjusted in case of renal dysfunction. Right. Thank you.
Thank you, Dr. Abhishek, for the wonderful lecture. Do you have any questions?
No, sir, not yet.
Okay. So, I guess we have covered everything very comprehensively. And for the students, since we tend to focus more on sodium and potassium in our clinical practices, these are often overlooked. This calcium, magnesium, and phosphate disorders, and we got to suspect them. Then only we'll do the levels and find them appropriately and take necessary corrective measures. So, since I guess we are running short of time, let us move ahead. Any comments, Dr. Abhishek, if you want to make?
No, I think not right now. We're running short of time. We're already
Yeah.
quite delayed. Yeah. So
Yes. Okay.
yeah.
Nice. So I guess we move ahead in the next lecture. Thank you so much, all the speakers, Dr. Lalit and Dr. Abhishek. And thanks a lot, Team
Thank you, sir.
Appec,
Thank you.
for thanks a lot, Team Appec, for inviting me here. Thank you so much.
Thank you, Dr. Dalim, for your precious time, efforts, and thank you for sharing your wisdom with us. And thank you, Dr. Abhishek. It was the Thank you, Dr. Dalim. So, forward, for which I would like to invite our chairperson, Dr. Sapna Batla. She's professor of anesthesia in BMC and Safdarjung Hospital. She is ex-anesthesia and head of office. She was ex-HOD anesthesia at Chandru Baj Chikitzalaya. and she has done already fellowship in pediatric anesthesia, and she is also national IAP executive member, currently secretary of IAPA Delhi, and she's also a NABH assessor and PPLS instructor. Her areas of interest are pediatric anesthesia, quality and safety in healthcare.
Thank you so much. Good evening, everyone. Good evening. Am I audible?
So I welcome you, ma'am, and am I audible, ma'am?
Yes, you are audible now.
I welcome you, ma'am.
Yeah.
So please, I'm handing over the session to you.
Thank you so much. Good evening, everyone. Thank you for the kind words, kind introduction. Now I take the privilege of introducing our next speaker and of course the last speaker of the day and the session. This is Dr. Devang Bharti. He is an assistant professor at Maulana Azad Medical College and Associated Hospitals. He's a member of Government of India mandated multidisciplinary team to curb COVID, ISA President's Appreciation Award 2024, AHA and IRC certified ACLS and BLS instructor, associated as a reviewer with over 25 index journal. His area of interest are airway, CPR, obstetric anesthesia. So he'll be talking about the multimodal anesthesia, which is a very important aspect for the anesthesia management. So over to you, Dr. Devang.
Thank you, ma'am.
Dr. Devang, you can unmute yourself.
Ma'am, there seems to be some problem from the technical end. I was just contacting the organizers. This is a
Yeah, sure.
supposed to be a pre-recorded lecture, ma'am, so the technical team must look into it.
Yeah, sure.
Yes, so we are checking at the technical. We are checking at the tech.
Review the pain pathway and explore the consequences of inadequate pain control. You will also be able to grasp the concept and rationale behind multipodal analgesia or MMA, various drug classes used, evidence-based guidelines, risks, and practical applications of MMA in different clinical contexts. Let's begin by defining pain. The International Association for the Study of Pain, or IASP, defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Pain can be classified based on duration into acute, chronic, or acute on chronic, and based on pathophysiology as nociceptive, inflammatory, neuropathic, visceral, and psychogenic types. Pain perception involves 4 key steps. First is the transduction at the site of injury, which converts mechanical, thermal, or chemical stimuli into electrical impulses. Then comes the transmission of these impulses via peripheral and spinal pathways, modulation at the level of spinal cord or brain, and finally perception in the brain. Each of these steps has its own distinct role in the complex neurophysiological processing that ultimately results in the experience of pain. Acute postoperative pain is a predictable but multifactorial response to surgical trauma. Surgery causes tissue damage, leading to inflammatory response, which acts as a nociceptive input and causes pain. This acute postoperative pain peaks within 24 to 48 hours and comprises of somatic, visceral, and referred pain components. If uncontrolled, it can evolve into complex physiological and psychological consequences. The consequences of poor pain control are wide-ranging. Physiologically, it triggers stress response, compromises respiratory and GI function, and increases thromboembolic and infection risk. Psychologically, it causes anxiety, depression, and delays mobilization and rehabilitation, leading to prolonged hospital stay and increased healthcare costs. Finally, inadequate pain control also increases the risk of chronic pain development. A serious yet preventable consequence of poorly managed acute pain is chronic post-surgical pain, which is typically defined as pain persisting beyond 3 months after surgery. This transition involves complex mechanisms such as central and peripheral sensitization, glial cell activation, and long-term neuroplastic changes, which make pain self-sustaining and dissociated from the original tissue injury, thereby losing its protective purpose and instead persisting as a maladaptive and pathological state. That means that instead of being a vital sign of an underlying problem, pain becomes a problem in itself. So now let's connect all these concepts. We have seen that surgical tissue damage and inflammation cause severe pain. If not managed early and adequately, this leads to physiological burden, psychological stress, and potentially chronic pain development. Hence, effective acute pain management is not optional but a priority. We have also seen that pain has a complex pathway involving multiple sites and mechanisms. Therefore, a single analgesic agent cannot control pain efficiently. This brings us to the concept of multimodal analgesia. MMA combines agents acting at different sites across the pain pathway, thereby providing superior analgesia while minimizing side effects associated with any single agent. The core principles of MMA include targeting multiple pain pathways, achieving synergistic analgesia through drug combinations, reducing opioid use and its side effects, and tailoring the regimes to the individual patient and their surgical context. The concept of MMA evolved from the principle of balanced anesthesia in the 1980s, which combined multiple anesthetic agents to achieve hypnosis, amnesia, analgesia, and muscle relaxation with minimal side effects. This concept was extended to pain management, recognizing that no single analgesic covers all aspects of pain pathways. The term multimodal analgesia was introduced in the 1990s to highlight the combining of drugs with different mechanisms for superior pain relief. The earliest MMA protocols combined opioids with NSAIDs or local anesthetics to achieve opioid-sparing effects. Backed by mounting evidence, by the early 2000s, MMA was adopted as standard perioperative care. Present-day multimodal analgesia integrates regional anesthesia, systemic non-opioid agents, and adjuvants to provide comprehensive pain relief. The advantages of MMA include superior pain control, reduced opioid requirements and their side effects, faster recovery, and shorter hospital stay, leading to improved patient satisfaction and fewer post-operative complications. There is mounting evidence for MMA. Multiple RCTs and meta-analysis show that employing MMA reduces post-operative pain, opioid consumption, associated side effects, MMA hastens recovery, and improves functional responses. MMA is cornerstone of ERAS because it facilitates early mobilization by providing effective pain control while minimizing the use of opioids. Prospect guidelines too recommend procedure-specific MMA strategies. Core components of MMA include non-opioid analgesics, opioid-sparing techniques, regional anesthesia, adjuvants, and patient-specific modifications. Now let's explore them in greater detail. Non-opioid analgesics are cornerstone agents in MMA. They target the peripheral and central pain mechanisms while reducing opioid requirements. These agents include paracetamol, which is effective for mild to moderate pain and is synergistic with NSAIDs. Non-steroidal anti-inflammatory drugs or NSAIDs are the second class of drugs. They act by inhibiting COX-1 and 2 and are useful for moderate to severe somatic and visceral pain. The third class, IV lignocaine, is a sodium channel blocker with anti-hyperalgesic effects. Opioids are effective agents for managing severe pain, but they have dose-dependent adverse effects like respiratory depression, PONV, and sedation. Additionally, there is concern regarding development of opioid-induced hyperalgesia and risk of prolonged or chronic opioid use. Opioid-sparing strategies aim to reduce opioid consumption by combining non-opioid drugs and regional techniques. Importantly, MMA does not eliminate opioids entirely. but rather reserves them for breakthrough or severe pain. And at that times also advocates using short-acting agents like fentanyl and remifentanil so that their use can be controlled and titrated. Regional anesthesia is a key pillar of MMA and significantly reduces opioid requirements. It provides targeted pain relief by blocking nerve conduction. RA techniques include both neuraxial and peripheral nerve blocks, both of which are highly effective, especially with adjuvants and catheter-based techniques. Adjuvants are agents that enhance analgesia when combined with other drugs or techniques. They target specific pain pathways and reduce central sensitization, improve pain control, and provide an opioid-sparing effect. Commonly used adjuvants include NMDA receptor antagonists like ketamine and magnesium, alpha-2 adrenergic agonists like dexmedetomidine and clonidine, gabapentinoids like gabapentin and pregabalin, IV lignocaine, dexamethasone, tricyclic antidepressants, and serotonin norepinephrine reuptake inhibitors. This image illustrates the exact sites of action of the commonly used analgesic agents. For maximum pain relief, it is advisable to combine complementary agents acting at different sites at this pathway. But how to choose an appropriate MMA technique for a patient? One needs to follow these 6 basic principles. Individualize analgesic plan, consider surgical procedure, pain intensity, account for patient factors like age, comorbidities, drug allergies, hepatic and renal function. Then combine mechanism of actions. Use agents acting at multiple levels of pain pathways. Avoid excessive use of a single drug class. Prioritize regional anesthesia. Use an appropriate RA technique whenever feasible. RA reduces opioid requirements and improves recovery. Follow ERAS protocols. Use preemptive and scheduled dosing rather than demand dosing. Combine systemic analgesics with local or regional techniques. Minimize opioid exposure. Restrict opioid use to breakthrough or severe pain only. And even at that times, use short-acting agents like fentanyl and remifentanil. Monitor and adjust. Assess pain and side effects regularly. Adjust dosages and combinations as per the respective post-operative course of the patient. Here is a list of surgeries and the suitable MMA combinations. It is always advisable to include an appropriate regional anesthesia technique wherever feasible. This list offers a practical blueprint for tailoring perioperative multimodal analgesia for your patient. Daycare or ambulatory surgeries need rapid recovery. MMA offers excellent pain control while avoiding opioids and their side effects like sedation and PONV, which can delay discharge. This makes MMA especially relevant to daycare surgeries. Core agents for MMA in daycare surgeries include PCN, NSAIDs, dexamethasone, and peripheral nerve blocks. Agents like opioids, gabapentinoids, and neuraxial blocks, all of which have side effects that may delay discharge, should be avoided. A well-planned MMA protocol for daycare surgeries ensures excellent pain control with fast ablution and timely discharge. ICU patients pose unique challenges. They might not be able to report pain, have multiple injuries and hemodynamic instability, and require effective analgesia due to underlying conditions. MMA in ICU relies on round-the-clock infusion of drugs like opioids, ketamine, dexmedetomidine, and apart from these infusions, paracetamol and regional techniques should also be utilized. We have seen that clinical application and benefits of MMA are wide-ranging and well-established. But it is also important to acknowledge the practical challenges one might face during its implementation. The use of multiple drugs increases the risk of interactions, which can be minimized through careful dosing and avoidance of overlapping medications. Then individual variability due to age or comorbidities or genetic factors necessitates tailored MMA plans to accommodate patient-specific factors. Vigilant monitoring is crucial, both for detecting adverse drug reactions and for managing potential complications related to regional anesthesia. Then elderly and high-risk patients often exhibit heightened drug sensitivity and may require lower titrated doses. Another major limitation is the lack of standardized MMA protocols, leading to variability in practice. Whenever possible, established frameworks such as ERAS should be adopted. Lastly, implementing MMA involves multiple drugs, equipments, and trained personnel, posing resource and cost challenges. Hence, rational, cost-effective choices should be made based on specific patient needs and available resources. So, to conclude, the key take-home message is that effective post-operative analgesia is not optional, but is central to recovery. Using multiple agents and targeting multiple pain pathways, MMA ensures superior analgesia, minimizes opioid-related side effects, and enhances recovery. Regional anesthesia and non-opioid agents are the core pillars of MMA. And finally, multimodal analgesia is evidence-backed, guideline-supported, and rest assured here to stay. Thank you. I hope that after this discussion, all of you are much more confident regarding MMA for both your exams and clinical practice. All the best.
Thank you so much, Dr. Devang. I can say so very well in time. Besides the content that is wonderfully covered and it is complete in terms of, you covered pain pathways, the concept of MMA, the requirement of MMA, various guidelines that need to be read by the students, and of course, ERAS protocols, etc. But so very well covered and covered in time. Thank you so much.
Thank you, ma'am.
And any questions in the chat box? I don't think any question is there. So can I conclude this session and hand over to the...
No, ma'am, there are no questions.
Yeah. So hand over to you for the further proceedings. Thank you so much, Dr. Shivpriya, Dr. Nisha, and the organizing team.
Thank you,
so
Dr. Sapna. I'm Dr. Neerja.
Yeah,
Thank you
hi,
for being
ma'am.
here.
Good evening. Yeah.
And for this
Yeah.
last session. A lot of thanks to my team for being here on a Sunday evening and spending time with us. Thank you, Dr.
Thank you
Devang,
so
for
much.
covering for covering the topic in such a comprehensive manner.
Thank you,
It's a
ma'am.
very important topic. At the end of every long case or short case, this question is asked as to what is the postoperative analgesia, and the answer is multimodal analgesia. So this completely comprehensively covers it. I'm sure the students will be able to answer it well, and it also comes in their theory paper. Yeah.
Thank you, ma'am.
Thank you.
Thank you.
Dr. Shivpriya?
Yes, ma'am.
So
Thank you
switch
so
on
much,
your video.
Dr. Sapna. Yeah, thank you.
Yes, we have come to an end of this Appec 7-day program where the whole team Appec has worked really, really hard to make this 7-day program, and then to interact with faculty at different places. So I'm like really, really thankful to everybody, all those involved in teaching, all the faculty. The team Appec extends sincere appreciation to all the faculty who have brought excellence and depth into their teaching. They have interacted so well with the postgraduates, and they made them confident in long case discussions, short case discussions, and the didactic lectures, the instrument vivas, the X-rays, ECGs, ACLS. Everything that we have covered has been covered so well. A very, very heartfelt gratitude and thanks to all of you for putting in so much of an effort, because the virtual programs have their strength, and the only disadvantage that it has is that you do not connect with the audience. But you never made us feel that you are missing that out, and you interacted with the students who were on the other end, whom you could not see, as though you were interacting with them. Thank you very much from whole team Appec. And I would like to thank my team, my department, who has been there with me all throughout in organizing it, running the OT simultaneously, and our department also has multiple other additional responsibilities besides this. So I thank you, all of you, from bottom of my heart, for being here, for being there all the time, and I have never ever heard no for anything. So I'm like really, really thankful for you, to all of you. That's a big, I would like to give a big thumbs up to all of us for completing a 5th Appec course. And from all of us, thank you, delegates, for being with us, for showing interest in interacting with faculty, from learning from their experience. And yes, that we can tell you that the 7-day capsule is going to be significantly helpful for you as far as your exams are concerned. These are like your these have been brought, the knowledge has been brought to you by the experts who have put in a lot of effort. So please, after reading the books, go through them. It's going to help you in your exam, written and practical exam. All the best from us, from Team Appec. And yes, hip hip hooray. Thank you so much. Thank you, everybody. Thank you, Dr. Shivpriya. Thank you, Namita. I can see your pictures. Others who have logged in, thank you very much.
Thank you so much, ma'am. Thank you so
And
much.
thank you, minutes and more, meetings and more. Thank you, Zia. Thank you, Sudhir, your team. For the
Thank you,
hi,
ma'am.
Achal. Thank you so much for
Thank you
joining.
for taking the initiative of conducting
Yeah,
Appec.
thank you, and Dr. Anupama.
Thank you, ma'am.
Thank you, Dr. Namita Arora, Dr. Namita Saraswati, Dr. Abhishek, Dr. Deepak, Dr. Abhiti, Dr. Lalit, Dr. Nidhi, Dr.
Thank you,
Sapna.
ma'am.
And thank you so much. The amount of hard work that goes in executing is really a lot. All the day coordinators and all the faculty who works behind in the OTs, thank you very much for all your unconditional support. I am forever grateful for that. And from team, thanks to all of you. Thank you, Sudhir, for being so patient and
Thank you.
managing small things at the last moment. Thank you very much.
Thank you, ma'am. Thank you, ma'am.
You are a perfect leader. Nita, you are a perfect leader. You take everyone together. You give the rhymes to everyone. Let them. You give them freedom to express themselves, and that in itself is the quality of a true leader.
Thank you so much.
Thank you for
I
everything.
can't do anything alone. So
Absolutely,
when
ma'am.
you come along and be with me, stand by my side and say, we are there with you. I think that's the biggest support that we can have. And the department can never run by one person. It's always a team effort. And our team is a wonderful team. Thank you so much. I
But
can't
ma'am,
express
the team
words.
leader always matters.
या बट वो भी अकेला नहीं कर सकता तो मेरा तो बहुत बहुत हार्टफेल्ट थैंक्स है सब लोगों के लिए जेन्युइन इट्स नॉट ओनली इन वर्ड्स बट you know that I mean it. Thank you so much to all of you. Thank you.
Thank you, ma'am.
I'll say bye. 7 days, grueling, long days, preparing for lectures, recording. कभी इंटरनेट जा रहा है, कभी आ रहा है, आज भी थोड़ा सा हो गया. So thank you for your patience. Thank you for your hard work. Thank you for your support, dedication, everything. Thank you so much. I'm overwhelmed by your support. Thank you. Bye.
Bye.
Happy Sunday of whatever is left.
Happy Friendship Day. Bye, ma'am.
Enjoy yourself.
Happy
Bye.
Friendship Day.
Happy Friendship Day to all of you
Happy
too.
Friendship
Bye.
Day. Happy
Bye.
Friendship Day, ma'am. Happy Friendship.
Happy Friendship Day. Bye. Bye.
Bye.
Bye.